Father Kunya, Assistant Professor, Department of General Medicine, Azizia Medical Hospital.
Good morning, everybody. Welcome to Azizia Medical College, Department of Medicine. Dr. Ijaz is a consultant physician of our institution. He did his MBBS from Kozhikode and MD General Medicine from here. And now he will present that topic, syndromic approach to the fever. Thank you. Yes, please.
Hope I am audible, right? So, dignitaries on and off the dais, and my dear colleagues, myself Dr. Ijaz Mohammed, in-house consultant physician. So, the topic for the talk is syndromic approach to tropical fever. I'm very happy that I got an golden opportunity to have a talk. It's a beginning session on the CME. So, the topic is syndromic approach to tropical fever. So as we all know, we belong to one of the tropical region, and the last year, when Kerala is considered, the reports have suggested that there were around 13,000 fever cases per day. The last monsoon season, there were 13,000 tropical fevers per day, and a lot of deaths as well. So it's high time that we are moving ahead of monsoon. So we should have a talk like this. So I would like to give a synonym to my topic, that the syndromic approach to the life-threatening febrile illness of monsoon. Moving to the topic, I would like to begin the session with an interesting case scenario that a 27-year-old male patient with no relevant history, he was found unresponsive by policemen. He was found naked with a frothing of mouth, and he was found on the road. And he was brought to the ED by the policeman, and at presentation he was in shock with a GCS of 3, and ECG was showing within normal limits. And the patient was hypoglycemic, and on evaluation he was having metabolic acidosis. So we were not able to elicit the history, went to the routine evaluation. Patient HB was, the day 1, HB1 6.6, total leukocytosis 21,000 was present, platelet was 6,100, the range LFT, RFT, and CT imaging showed, and during the serial evaluation, these blood parameters found to be improving. And the CT was showing the presence of cerebral edema. RBS initially hypoglycemic was managed with D25, and the X-ray didn't show any evidence of ARDS, and gradually there was decrement of lactates and resolving acidosis, and the USG was suggestive of hepatosplenomegaly. And this was a classical case of cerebral malaria. The patient was mechanically intubated, and around the day of 7, the patient gradually improved and was discharged. So we should have a look that a tropical fever can present like this. So with this, I would like to start the topic. So as a definition, the tropical disease were defined as a disease that are prevalent in or unique to tropical or subtropical regions. And the diseases are less prevalent in temperate climates due to, in part, of the occurrence of a cold season, which controls the insect population by forced hibernation. And most often, the disease is transmitted by an insect bite, which causes transmission of the infectious agent. And the Indian subcontinent, by its very location, presents one of the largest tropical and subtropical region, with many of these infections being prevalent. And we, the Keralites, belong to one of the tropical region. In India, the southern part is one of the most tropical region. So I think it's a high time to have a discussion on this topic. So as a case definition of acute undifferentiated fever, it can be defined as seen in a previously healthy, that is non-immunocompromised, belongs to urban or rural community, dwelling adult age of 19 to 64, reporting no previous medical illness or recent hospitalization in the preceding 30 days, and presenting with acute onset of fever more than 38.3 degrees Celsius for more than 2 days and lasting up to 14 days. And should note that the patient should have not received no specific treatment for this current illness with anti-malarials or antimicrobials, antibiotics. So we have the, as we all know, we have the common pathogens. We have the tropical, all are the different names, tropical fever, seasonal fever, monsoon fever, outbreak fever. We have the common pathogens like malaria, then dengue, then leptospirosis, typhoid, chikungunya, and influenza-like illness. And we have the other pathogens like strep typhus. Then we should concentrate more on the strep typhus because we have the area Paravur. A lot of cases are coming from Paravur like with leptospirosis and strep typhus. So other pathogens like strep typhus, then infectious mononucleosis, then hepatitis A, rheumatic fever, and tuberculosis, all with different presentation. So moving to the approach for a case of tropical fever, the symptoms may be nausea, vomiting, diarrhea, headache, myalgia, backache, cough, shortness of breath, purulent sputum, hemoptysis, seizures, jaundice, or may be presenting with bleeding. And the patient may be having underlying diseases like angina or myocardial infarction, arrhythmia, hypertension, diabetes, renal insufficiency. Patient may be a smoker with underlying COPD or asthma. Patient may be having liver disease, corticosteroid therapy, seizure disorder, or pregnancy. And the patient may be presenting with a syndrome. That is, patient will be having fever with thrombocytopenia. Patient might present with fever with respiratory distress or ARDS. Patient might present with fever with renal failure, and sometimes patient with present with fever and encephalopathy. Sometimes patient may present with fever with jaundice and may present with fever with multi-organ failure. So these are the syndromes that we can see along with the fever. So just recalling some recent studies, there were some presenting syndromes, and with these syndromes, the study says that these syndromes led to the final diagnosis as follows. That is, clinical syndrome consists of thrombocytopenia or rash in patients with most of the cases with leptospirosis and with dengue, and in about 2/3 of strep typhus and malaria. Respiratory distress will be a prominent clinical feature with strep typhus, and renal failure with most of the cases of leptospirosis, malaria, strep typhus, and dengue. And in most patients with acute CNS infection, encephalitis syndrome will be seen in patients with strep typhus being a present feature in 25% of cases. And multi-organ failure was observed more commonly in patients presenting with sepsis, that is around 31%, and those without a specific diagnosis. So just showing the trends of thrombocytopenia in some of the tropical fevers, we can see this is a chart showing tropical fever with thrombocytopenia. We can see the trend of improving thrombocytopenia. That is, in malaria, there will be gradual improvement. In enteric fever, there will be step-ladder pattern. Then in dengue, there will be a gradual decrease in platelet count. Leptospirosis, rickettsiosis, and trach fever, there will be gradual increase in the thrombocytopenia. Considering the signs and symptoms like chills, rigors, myalgia, headache, then arrhythmia, then jaundice, lymphadenopathy, splenomegaly. These are the clinical features shown in different tropical fevers. And like different organ involvement, we should note that the first three, that is the malaria, dengue, and leptospirosis, in these three cases, there is involvement of most of the organs. Like there will be CNS involvement, lungs, liver, kidney, then platelet, there will be thrombocytopenia, and there will be variations in the total count. These are the charts showing tropical fever with thrombocytopenia and different organ involvement. So moving to the approach in the department, emergency department, we should assess the stability, that is airway breathing and circulation. You should look for the red flag signs. And we should try to find out the focus of identified infection. So if the focus is identified as well, it may be pneumonia, pyloraphrenitis, then cellulitis, etc. We should send for appropriate investigation and blood cultures, 2 blood cultures, and should start on empirical therapy. And there is, we are not able to elicit the focus of infection. We should assess the clinical syndrome. That is, you should consider the risk factors, geography, season, and associated symptoms. And if the patient is having fever with encephalopathy, we have different approach for that. And if fever is with rash, thrombocytopenia, jaundice, ARDS, or multi-organ dysfunction, we should go for further evaluation. Like we should send investigation that is essential to be performed in all patients with a blood culture of 2 samples. We should send CBC, platelet, electrolytes, CRP, creatinine, LFT, urine analysis, and chest X-ray. And we can go for rapid diagnostic tests in case of dengue and malaria, but we should be conscious about the specificity of the rapid diagnostic test. And if the rapid test suggests diagnosis, if it's malaria, we can go for the specific therapy with artesunate. If it's dengue, we know the management with isotonic fluids and other supportive measures. And it's typhoid, we can consider ceftriaxone. And if the rapid test is not if it is inconclusive, we should go for the empirical treatment. We can consider ceftriaxone plus doxycycline or injection azithromycin 10 milligram per day, and should move for further workup. And we should send serology for scrub, then dengue, leptospirosis, and Vidal. And you should check for USG abdomen and go for bone marrow examination and cultures. So the other entity, that is fever with encephalopathy. The patient is presenting with fever with encephalopathy. You should assess and support the airway breathing and circulation. You should assess the blood glucose level. If it is normal, it's good. If it is low, we should manage with dextrose, and if it is high, with insulin infusion. And in all the patients, we should go for assessing the hydration status. If it is normal, it's well. And if it's dehydrated, we should give normal saline. And if the patient is having seizures, obviously we should go for anti-epileptics. And we should try to elicit a good history and physical examination. And if there is no focal signs of raised ICP, we can go for lumbar puncture. We should send for the relevant studies and can start with the specific treatment. And if there is signs of raised ICP, we should give the cerebral edema, anti-edema measures, and we should go for neuroimaging like CT or MRI. And also we should assess the ABG, CBC, electrolytes, RFT, LFT, and EEG. Also we should go for the rapid diagnostic test for malaria. And if it suggests the diagnosis, we can give artesunate. And in all these cases, we should start on presumptive therapy with injection ceftriaxone plus or minus acyclovir and other supportive care. And we should, along this presumptive therapy, we should go for ongoing evaluation and re-evaluation. And after that, we should send for Vidal, serology for strep typhus, leptospira, dengue, Japanese encephalitis, and herpes. And we should start the specific therapy. So moving to some of the few details about the tropical fevers that we used to see. Regarding the malaria, we all know the types of malaria, that is falciparum, bivax, ovale, malaria, and nolsi. So the diagnostic text, we have the thick and thin smear test. Also we have the rapid diagnostic test, bedside test. And the treatment algorithm, we know it's Plasmodium vivax. We should go for chloroquine for 3 days plus bromacin for 14 days. In the case of falciparum, artemisinin combination therapy for 3 days plus bromacin as a single dose. And if it's negative, we should go for further evaluation. So just few words about the severe malaria, because we start with a case scenario of cerebral malaria. So in severe malaria, patient will be presenting with impaired consciousness or coma. There will be repeated generalized convulsions, renal failure, jaundice, severe anemia, pulmonary edema, hypoglycemia. There will be metabolic acidosis, circulatory collapse, abnormal bleeding, hemoglobinuria, hyperpyrexia, and hyperparasitemia. So we should ensure the requirements for the treatment of a case of severe malaria. That there should be parenteral antimalarials, there should be antipyretics, antibiotics, anticonvulsants, intravenous infusion facilities, special nursing for patients in coma, blood transfusion facility, laboratory with clinical chemistry and hematology facilities, and facility for oxygen administration. So regarding the treatment, as you all know, we have the artesunate and the quinine. Artesunate is having more efficacy and efficiency than the artesunate. But in the case of pregnancy and all, we can move for quinine. And you should remember that the dose of artesunate is 2.4 milligram per kilogram per body weight. Given at the time of injection, then at 12 hours and then 24 hours. That is 0, 12 and 24 hours. Then once a day. So the dengue patient, I think my colleagues, mainly the UG students here, are more aware with the dengue patient, because in everyday rounds we are getting around, this season we are getting around 2 to 3 or around 4 to 5 dengue patients every day. So we all know the causative organism is dengue virus, that is flavivirus with the serotypes 1 to 4. The vector transmitted from infection person to another patient by the bite of female Aedes mosquito. So about the pathogenesis, it is a case of immune reaction. So I would like to chart out the pathophysiology of dengue fever or dengue hemorrhagic fever with a flowchart. That is, when the dengue virus infection occurs, there will be production of antibodies, presence of enhancing antibodies, antigen antibody reaction with complement activation, deposition of vessels, various tissues and platelets, and it leads to the clinical manifestation of coagulopathy or bleeding. At the same time, there will be activation of T cells, production of various chemical mediators, increased vascular permeability, and again leading to the clinical manifestation of vasculopathy, that is capillary leakage. These all lead to the symptoms and signs of in the patients with hypotension or shock, pleural effusion, ascites, bleeding, or another organ involvement. Regarding the cause of dengue illness, the chart showing the cause of dengue illness, you should aware that it's the post-febrile period is the critical period for a dengue patient. That is, patient might develop shock or bleeding due after the post-febrile period. Regarding the clinical manifestation, it's like an old school classification, that is undifferentiated dengue fever and severe dengue fever. So undifferentiated dengue fever means mild to moderate fever with maculopapular rash with signs of bleeding and capillary leakage may be present. And in the case of severe dengue fever, it's the undifferentiated fever with non-severe and severe manifestations presenting with shock, plasma leakage, bleeding and organ involvement. And with non-severe dengue fever grade 1, grade 2 with significant bleeding, and severe dengue fever grade 3 and 4 with or without significant bleeding. So we have the new guidelines, new classification for dengue fever. We have dengue fever, hemorrhagic fever 1, 2, 3 and 4. And we have the warning signs, that is in the probable dengue fever, show with nausea, vomiting, rash, aches and pain, tourniquet, test positive, leukopenia and any warning sign. And abdominal pain, the warning signs means abdominal pain or tenderness, presenting vomiting, clinical fluid accumulation, mucosal bleeding, lethargy, restless, liver enlargement more than 2 centimeter, laboratory showing increase in HCT and concurrent with rapid decrease in platelet. So it may be with dengue with warning sign, without warning sign, and dengue with warning sign showing severe dengue. So in severe dengue, there may be severe plasma leakage showing the features of dengue shock, then severe bleeding or severe organ involvement. So again, these are the signs and warning signs in dengue fever. So we have the expanded dengue syndrome with CNS involvement, GI involvement, renal involvement, cardiac involvement like myocarditis and pericardial effusions, respiratory involvement and eye involvement. So we have the classification for dengue fever, that is, it may be mild dengue fever, moderate dengue fever or severe dengue fever. So mild dengue fever, we can have the home management, and in the moderate dengue fever, we should have close monitoring and possible hospitalization, and the severe dengue fever, always patient should be admitted and treated in the tertiary care center. So it's the natural cause of infection showing the dengue fever. So regarding the diagnosis, we have the specific and sensitive NS1 antigen in the first 5 days, and ELISA, IgG ELISA develops by 5 days, and the rapid diagnostic test. It results within 15 to 25 minutes. And regarding the clinical management, we should know that there is no specific antibiotic therapy for the dengue fever. Patient should be given adequate IV fluids and bed rest, and should be given antipyretics. These are the charts showing the fluid management of dengue fever. So management of bleeding manifestation, there is indication for platelet transfusion if the platelet count is less than 10,000. So regarding the leptospirosis, we know the organism Leptospira intergens. We have the two types, that is anicteric leptospirosis and icteric leptospirosis. Icteric means severe leptospirosis like Beale's disease. This is showing the different phases of leptospirosis like acute age, convalescent age. Regarding these are clinical manifestation of leptospirosis with mild and severe form with fever, myalgia, conjunctival suffusion and headache, and severe form with myalgia, jaundice, conjunctival suffusion, headache, abdominal pain, nausea and vomiting. Regarding the clinical management, we have the incubation period of 5 to 14 days, and the diagnosis with raised CPK, then blood culture, positive serology and MAT and IgM ELISA. This is the flowchart showing the approach to the diagnosis of leptospirosis. So regarding the clinical management, we have the conventional therapy with first line penicillin G1 and penicillin G with 1.5, 6 hourly for 7 days. And as per the Indian guidelines, we have doxycycline 100 milligram Q12 hourly and injection crystalline penicillin. So graph showing the hepatitis A, I think all of are aware about this. Then hepatitis E virus. Regarding the typhoid, we know the organism is Salmonella typhi. And in the first week, the patient may present with fever, headache, or relative bradycardia. In the second week, abdominal pain, diarrhea, constipation, hepatosplenomegaly. And in the third week, intestinal bleeding and perforation may happen. So regarding the diagnosis, we have the typhoid dot and the bidal, but it is non-specific. And regarding the treatment, we have the first line being ceftriaxone. And we have the alternatives like azithromycin and ciprofloxacin. And we can consider dexamethasone 3 milligram per kilogram per day, followed by 1 milligram per kilogram, 6 hourly for 48 hours in selected cases with typhoid encephalopathy. Regarding the strep typhus, we know the organism and the classical clinical feature of Eschgar. And the treatment, we have the first line doxycycline, azithromycin or rifamycin can also be considered. Regarding the Japanese encephalitis, we have the causative organism, Japanese with the Culex mosquito, and the diagnosis, we can have IgM capture ELISA, and the treatment we give for supportive airway management, seizure control and management of raised intracranial pressure. So just showing a chart with a fever with the following symptoms like pallor, malaria or blood smear seen in case of malaria, fever more than 1 week with abdominal pain and positive blood culture seen in the case of typhoid, fever more than 1 month with weight loss, positive HIV serology showing seen in the HIV infection, marked myalgia, eye pain, rash, leukocyte, reduced WBC and thrombocytopenia seen in the case of dengue, and freshwater exposure with conjunctival injection with fever seen in the case of lepto. And in the case of rash, we have measles with cough, conjunctivitis and coryza. In dengue, the islands of normal skin. And in case of neurological febrile encephalopathy, patient might have cerebral malaria, meningitis and encephalitis with a relevant history. And hemorrhage is seen in Ebola, yellow fever and dengue. So just showing the disease, incubation period, symptoms, signs and investigation. So I would like to conclude the topic with just 15 seconds with a syndrome-based treatment guidelines for critical and tropical infection. So if the patient is presenting with the case of fever with thrombocytopenia, we should go for antipyretics for control of fever, IV fluids, you should avoid aspirin, anticoagulants, watch for bleeding, platelet transfusion if the platelet count is less than 20,000, clinical bleeding, no role for steroids, and specific therapy once the diagnosis is established. If the patient is present with fever with jaundice, we should go for antipyretics for the control of fever, injection ceftriaxone, 2 gram IVBD, tap doxycycline, watch for urine output, seizures and encephalopathy. Then we can have fresh frozen plasma with cryoprecipitate for bleeding and specific therapy once the diagnosis is established. And if the patient is presenting with fever with renal failure, we should give antipyretics for the control of fever, injection ceftriaxone 2 gram IVBD, tap doxycycline, IV fluids, we should watch for encephalopathy, bleeding, seizures or ARDS, and renal replacement therapy, and specific therapy once the diagnosis is established. And finally, if the patient is presenting with fever with encephalopathy, we should give antipyretics, then again injection ceftriaxone, injection acyclovir can be considered, and we should give IV fluids, IV mannitol for raised ICP, watch for seizures and specific therapy once the diagnosis is established. So I would like to conclude my talk with sincere thanks to all the colleagues, and with the hope and gentle reminder that we are moving ahead to the monsoon season. So all my colleagues, you should pick up from the history, you should look for conjunctiva, you should look for SGAS, and you should not miss out per abdomen examination. That's all regarding the topic. Thanks for your patient listening. Thank you.
Thank you, Dr. Jas. You have discussed the problem elaborately, and we are, however, I think there may be 1 or 2 questions. 2 minutes is given. Please. Questions from the floor.
Dr. Jas, fever in the first week is very difficult to diagnose. Fever in the first week is very difficult to diagnose. Maybe 20 years back, you used to have some symptoms or some signs which indicates that the fever is typhoid, fever is dengue, like that. Can you elaborate on that?
Actually, during the initial time, it was very difficult to diagnose the typhoid, and at that time, we were using a triad for the diagnosis of typhoid. That is, the patient may be presenting with high-grade fever, patient will have hepatosplenomegaly, and patient will be presenting with a encephalopathy. That is coma vigil or muttering delirium. That is typhoid encephalopathy. So this was the classical triad for the diagnosis of typhoid.
Any clues whether it's a dengue or leptospira? Any clue which can give you an idea whether it's a leptospirosis or a dengue fever?
Sir, one is from the history with the exposure, then with conjunctival suffusion.
The symptoms.
Symptoms. Conjunctival suffusion will be present, and myalgia, mainly the calf tenderness, will be present more in the case of leptospirosis.
Okay.
If there are no more questions, we will close the session. Thank you. Yes, I think there is one more question from Dr. Santosh Kumar.
In fact, it's not a question. It's like in typhoid, what we I'm basically pediatrics. In typhoid, what we generally see is one is this enlargement of liver. Although we actually look for spleen, most of the time we find the liver to be enlarged. And the second thing is when we give ceftriaxone, we have had biliary sludge to the extent of producing jaundice. So that is also another thing that I wanted to add. Thank you.
Thank you for the information, sir. Thank you.
Thank you.
Thank you, sir. I invite the chairs to kindly present the memento to Dr. Ijaz Mohammed. Let me invite Dr. P.R. Rajiv, Consultant Physician, Pathfinder Diagnostic Solutions, Pathanapuram, and Dr. Anil Vijaykumar, Associate Professor, Department of General Medicine, Azizia Medical College Hospital, to present the mementos to our chairpersons. Attendees, please note, kindly fill up the feedback forms at the end of each session. It is your valuable feedback that motivates us to move forward.
In life, everything is temporary, whether it's good or bad. It's the nature of life to be transient, always moving forward, always changing. These transient events are important considerations in clinical practice, as they may mimic or precede more serious conditions, necessitating careful evaluation and management to ensure optimal patient care. Now, we have the second session of the day, Transient Events in Clinical Medicine by Professor Dr. R.N. Sharma Sir, Emeritus Professor, Department of General Medicine, Pushpagiri Medical College, and former Head of Department, Department of General Medicine, Government Medical College, Kottayam. Let us invite Professor and Dr. Lekha Ma'am, Head of Department, Department of General Medicine, Travancore Medicity Hospital, and Dr. Shashidharan Sir, Senior Consultant Physician, Department of General Medicine, Azizia Medical College, to chair the session.
ആദ്യം ടോപ്പിക്ക് പറഞ്ഞിട്ട് സാറിന് തരാം. Good morning to all. I think we are moving on to a very important session of the day, and we have an eminent speaker, Dr. Sharma sir, and I am extremely proud to chair a session being presented by him. And I am sure he requires no introduction because everybody here knows sir as a good teacher, academician, and a good loving person.
Thank you, madam. Respected senior teachers, delegates, and my dear students, with immense pride, I am introducing to you my teacher, Professor R. Neelakanta Sharma, shortly known as R.N. Sharma. Now he is working as Professor Emeritus at Pushpagiri Hospital. He is a native of Kottayam, to be precise, Kumarapuram, and he had his undergrad training at MCH Kottayam. And it is interesting to see that he received a gold medal for ophthalmology during his undergrad study, and his interest in ophthalmology was well known at that time. Now, after that, he took the PG from the prestigious PG Institute, JIPMAN. He joined Medical College Kottayam as a junior doctor, and gradually he became the HOD, and he was there as HOD of medicine from 2001 to 2003. He voluntarily resigned and joined as Professor Emeritus at Pushpagiri College from 2003 to 2008, and at Amrita Institute from 2008 to 2012. Presently now, he is the Professor Emeritus of Pushpagiri. Total years of undergraduate and postgraduate teaching spans over 45 years, that is from 1977 to 2022. And he received a lot of awards. Best Teacher Award by the KGMCTA in 2002, Lifetime Achievement Award, APA, in 2016, and Eminent Teacher Award by South Zone Association of Physicians. He has got 13 publications to his credit, and he had been undergraduate and postgraduate examiner and paper setter at MCH Trivandrum, Kottayam, Alappi, Kozhikode, Thrissur, Mueller Medical College, Jipmer, and ESI Medical College, Bangalore. Even now, he is a student. He spends a lot of time reading and searching the internet for new informations, and he is always ready to impart the newly gathered knowledge to his students. We have actually formed a WhatsApp group in which sir frequently posts his new informations. Thank you, sir.
We'll move on to the topic, transient events in clinical medicine. Over to you, sir.
Thank you so much. Good morning to all of you. First, I thank Dr. Rajshekharan and his team for giving me this opportunity to talk on this particular subject. Now, transient events, we have got a lot of transient events that are happening in clinical medicine. It comes and then disappears after a while. Now, what are they? It can be a TIA, all of us are familiar with, TMB, transient monocular blindness, TGA, migraine, syncope, seizure. And I actually prepared for half an hour topic, but now I think I will have to cut short. So therefore, I will be slicing many slides, and let us see. And mainly intended for the PGs. Now, amaurosis fugax, it is one of the transient events. It is called transient monocular blindness. Current definition is transient mono or binocular visual loss. That is the amaurosis fugax. Many of them are benign, but many of them are malignant. It can be neurological cause, it can be ophthalmological cause, or systemic conditions. As physician, we should not forget systemic conditions. Because patient will go to the ophthalmologist, patient will go to the cardiologist, neurologist. They will not miss anything. But systemic conditions, physician will have to look after. This is a case scenario. 70-year-old male, bifrontal headache on and off 1 month, weight loss, anorexia, developed monocular blindness transiently 3 times, first on the left side, then on the right side, then on the again left side. So alternating monocular blindness. In 2 days' time, we experienced several episodes. Complete ophthalmology examination, everything was normal. Then the acute vision, ophthalmic examination, neurological examination, systemic examination, everything was normal. CBC was normal, ESR 43, computed tomography, MRA, MRI, carotid Doppler, 2-dimensional echocardiogram, everything was normal. Suspected cerebral ischemia, treated with intravenous heparin. Continued to have visual symptoms despite intravenous heparin. On day 3 of his hospitalization, still no diagnosis. Still the visual symptoms continued. What next? What shall you do? Any pages? Any pages? Neurologist has seen, ophthalmologist has seen, as well as cardiologist has seen. It is still continuing heparinized. Anybody? We will come to the answer later. Now you have got a monocular or binocular. It is important, but it is practically impossible to make out whether it is monocular, binocular from the history. But it is safer to investigate for both. Now, monocular blindness means, transient blindness means, it is anterior to the optic chiasm. Therefore, in a monocular, if you are very sure that it is monocular, the culprit could be in the ocular disease or ischemia of the due to carotid artery disease. If it is binocular, the lesion is at the chiasm, optic tract, behind that, optic radiation or occipital lobe. So therefore, the diagnosis and investigations will change. Now, the duration of it may vary from few seconds to several minutes. If the patient has got papilledema, it usually lasts for few seconds. Thromboembolic events also will produce amaurosis fugax, lasting for 15 minutes. And migraine aura, it will last for 30 minutes to half an hour. Now, duration will therefore help us to make out the diagnosis. Now, blindness is the main manifestation. Sometimes positive phenomena also occur. When you say positive phenomena, it is photopsia or scintillation. Bright colored objects happen. That is positive. Positive as well as negative, marching from one end to the other end of the field, will be classical for migraine. Now, retinal ischemia usually produces negative phenomenon. Patient sees something dark, something blurred, nothing is visible. That is the picture. Positive symptoms also rarely can occur in patients with ischemia. Now, the causes of transient monocular blindness are taken from Bradley. Innumerable number of them are there. But one thing you should not forget, physicians should not forget about hyperviscosity and hypercoagulability. Also, should not forget about vasculitis. Otherwise, we will miss it. Now, causes of binocular transient blindness. Again, multiple causes are there. I am not reading out all of them because of lack of time. Now, we go back to the clinical scenario. History was retaken. Patient had systemic symptoms. There was weight loss and anorexia, shoulder stiffness and pains in the limbs, and had jaw claudication. Chewing gum test was positive. Review of head to foot examination showed prominent temporal artery. The diagnosis was giant cell arthritis. This is something which should not be missed by the physician. Biopsy confirmed GCA. Now, bilateral transient visual loss can occur in migraine, seizure, and vertebrobasal ischemia. These are the common causes. I am skipping these slides. Transient monocular visual loss sometimes can be a manifestation of orbital mass. This is called gaze-evoked amaurosis. Gaze-evoked amaurosis. Now, gaze-evoked force fields, which is likened to Lermit sign. This is called Lermit sign of the optic nerve. This can be a sign in optic neuritis. Now, loss of vision after exercise or after taking a hot shower, they typically called eutho phenomenon, should make us think of a multiple sclerosis or demyelinating illness. Now, if you have got a transient monocular visual loss with transient contralateral hemiplegia, you should naturally think of a severe carotid occlusive disease. Vertebrobasilar symptoms usually produce bilateral manifestations, and specific bilateral manifestations of TIA will be vertigo and diplopia, which will not occur in carotid TIA. And when the patient comes with amaurosis fugax, you have to investigate with ophthalmologist, cardiologist, neurologist, as well as you think of a generalized condition like hyperviscosity. All of them has to be investigated. Whole lot of investigation have to be done. Now, what is this? PGs. Any diagnosis? Transient monocular blindness. What is this? Holland-Holtz plaque, HOLLAN-HORST. This is a cholesterol crystal, atheroembolism. Now come to another problem, transient loss of consciousness. This is a real story. 6-year-old chartered accountant went for inspection to client's office at Alway. He felt giddy and fell down. In the veranda, fell down, brought to Ernakulam hospital by office people. He opened his eyes in hospital, started asking, where am I? You are in XYZ hospital. Doctor asked, what happened to you? He said, I don't know. Where is your house? Kottayam. Where am I now? In this hospital. How I reached here? I don't know. What happened? The doctor specialist made a diagnosis of seizure. Why? We'll come to that. These patients were not satisfied because they are related to another gynecologist. The changed neurologist went to the local neurologist. He made a diagnosis of syncope. So one neurologist make a diagnosis of seizure, another neurologist make a diagnosis of syncope. This commonly happens, not uncommonly happens. Therefore, physician can definitely make mistakes. 2 opinions from 2 neurologists. Now went to the personal physician. He took a detailed history. Patient was visiting Alway as part of his official work. He reached the first floor and then had a fall. Afterwards, he did not remember anything. When he opened his eyes, he was in Ernakulam. He did not remember about how he reached that hospital. He had traveled several kilometers unawares to reach the hospital. No tongue bite, no incontinence, no tonic-clonic movements. There are no stigmata of epilepsy because there are no eyewitnesses. A diagnosis of seizure was made confidently by the physician because there was a typical amnesia. He traveled from Alway to Ernakulam. He did not know whether he has traveled or not. Just opened his eyes, he was in Ernakulam, another place. That is typical of amnesia, typical of seizure. And sent to an academic neurologist, diagnosis confirmed on anti-epileptic drugs, patient is all right. Now, transient LOC, there are only 2 diagnoses, seizure, syncope. Very often difficult to identify what is correct unless you take proper history. Syncope is due to hypoperfusion of the brain, characterized by hypotonia. That is very important. Why I say hypotonia is important? If somebody is fainting, if there is some stiffening of the limbs, some movement which tells that there is increased tone, the diagnosis has to be seizure, not syncope. Very often you will not get eyewitness, therefore history may not be revealing. Very often you find diagnosis is elusive. Actually, 2006 Neurology Lancet says diagnosis of seizure versus syncope is the most difficult problem in clinical medicine. Repeatedly, it has to be investigated in order to arrive at a diagnosis. This is true even now. This is 2006. So there is a Now, Sheldon and colleagues, he had made a scoring system which will be useful for physicians. There are several points. If there is a tongue biting, point 2, déjà vu or jamais vu phenomenon, 1, emotional stress preceded by the event, 1, head turning during a spell, 1 point, unresponsive, unusual posture and limb movement and amnesia, that is what our patient had, 1 point. There are other things, confusion after a spell, again 1 point. Lightheaded spells, sweating before spell, spell associated with prolonged sitting and standing, it is actually -2. If you add them together, if the value is more than 1, there is 94% chance that it is a seizure. So this will be useful for us. Now, any unconscious lasting for more than 5 minutes, it will be seizure, not syncope. Now, this is the algorithm for it. I am not going to that. Now, ECG may be helpful. Now, what is this? Any pages? Patient comes with syncope. What is this? This is epsilon potential diagnostic of arrhythmogenic right ventricular cardiomyopathy, an important cause in youngsters producing arrhythmia and syncope. That is very, very important. PG should know about it. I am not going to the causes. Too much are there. I have to stop by, I think, another 2 minutes only. Now, this is a 14-year-old boy. He was fond of football, watching. Suddenly started crying and screaming. Parents came running. On asking what happened, he was bewildered and told parents that the court was upside down. The football court was upside down. The people were playing in an inverted manner. They were running not like this, they were running like this. And 10 minutes time he became drowsy and partly unconscious, taken to the hospital, vomited 4 times, had bilateral headache. By that time he recovered. Similar episode happened few times in the following days. One of the episodes, while watching again football, he found the football court has come very near to him. Football court is there, he was watching from a distance. It appeared that the whole thing was coming to him. It is very near, maybe 1 or 2 feet away. That is what he felt. Developed headache, vomited, became drowsy, taken to the hospital, recovered. Diagnosis, any PGs. Transient event, headache, vomiting, stereotyped attack. Diagnosis will be migraine, basal artery migraine, or otherwise called Bickerstaff migraine. So, repeated stereotyped attacks with headache, vomiting, and visual phenomena. That is, occipital lobe is involved, you get what is called a zoom vision, you get entomopsia, you get floor on ceiling phenomenon, which is typically found in DASH. Any pages? Common condition. Floor on ceiling phenomenon, the whole thing gets inverted. I have seen several patients. Lateral medullary syndrome. Classically, you get in lateral medullary syndrome. Now, patient put on amitriptyline, and Cipla, he became all right. Now, I am not going into details of the migraine. Now, these are the visual phenomena in migraine. This is another story. 62-year-old professor, real happened, medical college, confusion memory loss that occurred at 9:50 a.m. while he was in the clinic, home clinic. Suddenly became confused and began repeatedly asking, where are we, where am I, what happened? The patient forgotten where he lived and who is working, where he was working. Unable to identify his cousin, confusing for his son. Who are these people? People were sitting, patients were there. Who are these people? He asked. Prior to the episode, his behavior perfectly normal. At 12:04 p.m., he presented to the emergency department with his son, repeatedly asking, where am I? Told several times he is in this particular hospital in the casualty. The question was further repeated several times, not knowing, in spite of telling him that you are in the casualty of this hospital. no head injury, there was nothing, absolutely nothing, perfectly normal, healthy person, doctor, professor. Now, many mental status examination showed he was unable to name the president, year have forgotten, month is forgotten, home address is forgotten, and he also forgot which hospital he is working, forgotten what he had taken for the breakfast. Neurological examination perfectly normal, all features of amnesia. Digit repetition task was normal, which means that the primary memory is normal. 5-item test was miserably, he was failing. That means short-term memory is abnormal and remote memory was normal. So he satisfied all the criteria of amnesia. Primary memory normal, secondary memory abnormal, tertiary memory normal. But he also had confabulation. So what is the diagnosis? Transient global amnesia. They are not uncommon. I have seen several patients, and it is not uncommon. Patient suddenly get confused, develops a total amnesia which lasts for several hours, maybe 1 or 2 days sometimes, usually several hours, 10 hours, 15 hours, then it becomes perfectly normal. Now, TA I am not touching because everybody knows about it. Now, there is something called autolytic catastrophe occurring in Meniere disease. We had a patient where patient had Meniere disease, suddenly he collapsed without any loss of consciousness. This is called autolytic catastrophe at Tamarkin, and spontaneously recovers in a matter of few seconds. Now, this is another case which I happened to see several years back. Transient fall while awaiting in consultation clinic, at my clinic. From Todupuzha, he was waiting for consultation. Physician announced his name to get in. Suddenly he fell down. People carried him to doctor's examination table, conscious, examination was unremarkable. History revealed he came to consult the physician for irresistible sleep. Anybody? He came for consultation for daytime somnolence, irresistible sleep. He sleeps while taking food. That is the reason why he consulted me. He had features of narcoleptic tetrad. He had narcolepsy, daytime somnolence. He had hypnagogic hallucinations, sleep paralysis, and the event that occurred now, transient loss of tone, suddenly it happened, that is cataplexy. That is, he fell down without any loss of consciousness, and people carried him to the table. And this is very typical of cataplexy, one of the components of narcoleptic trap. Panic attacks, this is usually treated by a psychiatrist, repeated episodes of anxiety, fear, sense of impending death. One point I would like to stress, don't forget about arrhythmia. Pheochromocytoma should be considered in every case of panic attack. Also hyperthyroidism, don't miss TLE, also don't miss hypoglycemia when there is a panic attack. Now, I think time is over. Now I discussed some of the transient events. I had to cut short many of them. The quality would have been lost. I am sorry for that. Discuss various transient phenomena like TIA, amorous fugax, TGA, and migraine. Thank you so much for this opportunity. Thank you so much.
Thank you, sir, for the excellent talk, made concise and in a nutshell. I think the topic is open for discussion. Sir, I will make a comment. I think years back I had a patient, she was a 50-year-old. Years back I had a patient, she was a 50-year-old physics professor working in SD college. And one day she was looking through the spectroscope and she had an amaurosis fugax. So she was evaluated by the senior consultant in the medical college and other physicians. There was no abnormality in all her blood examination, ECG, X-ray, biochemical parameters. But her ESR was 130. So she went from Alleppey to Ernakulam to all the hospitals, including the senior ophthalmologist, and they said nothing is wrong to you, with you. After 5 years, she landed in our cardiology department, was referred by our neurologist. She had a similar episode. She went to our neurologist, Dr. Girija, and she examined her and said, no, you are perfectly all right. Nothing is wrong with you, but your ESR is still 135. So madam thought I will record her BP. So she tied the cuff, and when she palpated for the radial pulse was absent. So on doing, and she was referred to the cardiologist, Dr. Venugopal, who admitted her, evaluated her, sent her to SCT Trivandrum, and an iotogram showed that she had an arthritis. So she went in for a surgical intervention, and she came back to us and asked us, if my disease was diagnosed 5 years before this, could it have been prevented? What's your answer, sir?
Now, very often we miss to examine the patient from head to foot. If you don't examine, we are going to miss many, many conditions. Now, that is not the fashion of the day. It is not to examine. Just come here, listen to the story, and send some investigation. I think as physicians, we should start examining from head to foot. Recently, I had 2 patients. One was investigated for PUO, and everything was done. CT was done, MRI was done, CT, thorax, abdomen, MRI, brain, everything was done. PET scan also was done. Nothing was visible. And the patient had jaw claudication, and I gave chewing gum. Chewing gum test was positive. Chewing gum test, the patient is, it is even in NEJM. Chewing gum test was positive. It is positive in 50% of the cases of temporal arthritis. So it is positive. When there is a jaw claudication, you think of giant cell arthritis, you think of Takayasu and McArdle disease. That is for the PGs. McArdle disease, temporal arthritis, and young female arthritis. These are the 3 differential causes for jaw claudication. So I gave this, and the diagnosis was made. I did a temporal artery biopsy. It was positive. Another case again from Ernakulam came last year, again related to a neurosurgeon. And while taking the examination, head-to-foot examination showed there is a prominent temporal artery. So I thought it should be a temporal arthritis, and sent the patient with a basic investigation. I started on steroid because it will cause anterior ischemic optic neuropathy. So vision will be permanently lost. Then she came after 2 weeks. At that time, the temporal artery was not tender. When I examined, it became nodular and then became tender. And diagnosis was made by biopsy. And PET scan also was done in the first case. That did not reveal anything. So we are missing arthritis unless we examine. When you examine the pulse, as our teachers used to say, examine the radial pulse on the right side, left side, dorsalis pudis, posterior tibial, femoral, everything has to be, along with that you have to palpate the temporal artery also. Thank you, madam. Thank you.
Sir, one doubt, sir. In the case of migraine, you told baseline migraine or Bickerstaff migraine.
Pardon?
In the basilar migraine or Bickerstaff migraine, then what is familial hemiplegic migraine? It is also
Hemiplegic migraine. Any neurologist who can answer better than me? Any neurologist? No, hemiplegic migraine. Patient have got a migraine associated with a hemiplegia. But it is got a strong hereditary tendency, and patient aura comes in the form of a weakness. So patient develops hemiplegia. The only problem is when you make a diagnosis of hemiplegic migraine, it may be a tumor. So don't make a diagnosis of hemiplegic migraine unless you rule out more dangerous conditions.
Thank you, sir, for that excellent presentation. I would like to add a couple of cases like episodic nerve stem dysfunction. One was the case of a subclavian steal syndrome who presented with repeated episodes of fall while driving. That's one. Second is was a case of a craniovertebral junction anomaly, again complaint of recurrent attacks of seizure-like syndromes. I think it's prudent to, as Dr. Leah correctly pointed out, to screen the pulse and the neck also for any evidence of a CV junction anomaly. Thank you, sir.
This is not uncommon because we have mistake is patient was in another hospital where I was working, high-tech hospital. Patient came with a fever, headache, and all the investigation for fever was done. Investigation for inflammatory, everything was done. Ultimately, while in the hospital, patient developed loss of radial pulse. At that time only it struck that it could be an arthritis. Angiogram was done, it showed the young female arthritis, it was tracheostosis. So we can miss this condition unless we examine the patient totally from head to foot, correlate, repeatedly examine. And radial pulse was not lost in the beginning. Only about 10 days, 15 days later, radial pulse was lost. Till then we should not thought about it, but we could not actually go for that investigation. Ultimately the patient died because of encephalopathy.
So I think as we are running short of time, we'll wind up the session. Let me and my co-chairperson thank Dr. Rajashekharan and his team for allowing us to chair this session. Thank you.
Thank you, sir. I request our chairpersons to kindly present the memento to Dr. R.N. Sharma, sir. May I request Dr. Rajashekharan, sir, Head of Department, Department of General Medicine, Azizia Medical College, and Dr. K.M. Prasad, sir, Senior Consultant Physician, Holy Cross Hospital, Kottayam, to present the mementos to our chairpersons.
Ladies and gentlemen, now we will move on to the inaugural ceremony of Adamcon 2nd edition. We have gathered here to collectively share knowledge and exchange insights in the advancing field of medicine and go beyond our limits to improve the quality of patient care. Azizia Institute of Medical Sciences, one of the leading medical colleges in Kerala, embodies commitment to providing compassionate care and innovative medical services to all those in need. This institute reflects on the importance of accessible and high-quality healthcare for all. Established in 2008 and chaired by Shri M. Abdul Aziz, together with a team of directors, Dr. Ansar Aziz, Dr. Hashim Aziz, Dr. Midilaj Aziz, Dr. Anas Aziz, and Dr. Hassan Aziz, who's worked relentlessly to building this institute as a beacon of excellence in healthcare and becoming a sanctuary of healing, comfort, and hope for all those who walk through its doors.
Welcome to Adamcon 2nd edition, Updates in Clinical Medicine. It is with great pleasure and excitement that we gather here today to embark on a journey of discovery and advancement in the field of medicine.
Adamcon, an initiative pioneered by our own medicine faculties and our seniors, held 2 years ago with the theme Diabetic Advancements, remains etched in our memories as a day of profound significance. It was a day where we stood united for its inauguration and success, bridging the gap between seniors and juniors and fostering collaboration across all faculties. The event provided a unique platform for interaction with doctors from various fields and eras, offering insights that left a lasting impact on us. Adamcon stands as a testament to the power of unity and the shared pursuit of knowledge in the medical community. A mesmerizing day we'll always cherish and carry forward in its legacy.
Throughout the course of this conference, we will delve into a myriad of topics ranging from groundbreaking research findings to cutting-edge technological advancements, from novel treatment modalities to emerging trends in patient care. Through engaging presentations, thought-provoking discussions, and collaborative exchanges of ideas, we will enrich our understanding, broaden our perspectives, and forge invaluable connections with colleagues from across the globe.
Let us approach this conference with open minds and receptive hearts, ready to learn from each other, to challenge assumptions, and to inspire one another towards excellence. Together, let us embark on this enriching journey of discovery, united in our shared pursuit of advancing clinical medicine for the betterment of humanity.
To commence this gathering, let us take a moment to invoke the blessings of wisdom and unity. I request everyone to take a minute in a silent prayer. Thank you all. To officially welcome you all, I invite Dr. Rajashekharan sir, Head of Department of General Medicine, Amnesia Institute of Medical Sciences, to extend his warm greetings to all the attendees and to set tone for this event.
I invite Dr. Anas Aziz, Consultant Pediatrician and Director of Amnesia Institute of Medical Sciences, onto the dais. Next, I invite Dr. K. Shashikala, Principal, Amnesia Institute of Medical Sciences, onto the dais. Next, I invite Dr. Santosh Kumar A., Medical Superintendent of Amnesia Institute of Medical Sciences, onto the dais. I invite our respected Dr. Srikanthan sir, former head of the Department of General Medicine, Amnesia Institute of Medical Sciences, onto the stage.
I invite our renowned professor and senior consultant physician of Department of General Medicine, Dr. Shashidharan sir, onto the dais.
To officially welcome you all, I invite Dr. Rajashekharan sir, Head of Department of General Medicine, Amnesia Institute of Medical Sciences, to extend his warm greetings to all the attendees and to set tone for this event.
Ladies and gentlemen, dignitaries and honored of the dais, a very good morning. It gives me immense pleasure to put a start to this auspicious occasion by heartily welcoming you all to the annual conference and the CME Adamcon, Updates in Clinical Internal Medicine. It is with great honor and enthusiasm that I extend a heartfelt welcome to everyone of you to this event. Today, we unite not only as healthcare professionals, but as fervent seekers of knowledge, dedicated to refining our skills and advancing frontiers of patient care. As Sir William Oster once remarked, medicine is the science of uncertainty and art of probability. It encapsulates the essence of clinical medicine and continuous quest for updates and advancement in the field, a sentiment that aligns seamlessly with the ethos of our theme, Updates in Clinical Medicine. It's an honor to stand before you with such a distinguished audience and medical professionals, researchers and scholars, united by our shared commitment to the betterment of healthcare. Before we embark on this enlightening journey of knowledge, I wish to extend a respectful tribute to our esteemed chairman, Sri Abdullah Sisar, the patron, the backbone of the Assisia Group of and Podikun Charitable and Education Trust, with the illustrious legacy of fostering higher education and social welfare. His remarkable contributions have been nurtured a generation of forward-thinking individuals poised to lead with the competence and compassion. Although unable to be with us in person for this event, our unwavering dedication to our cause continues to inspire us all. Your presence at our previous event felt an indelible mark with the absence of deeply felt. Rest assured, your legacy resonates strongly with us as we convene our honor for your commitment to advancing medical knowledge and practice. To serve as the backbone of the organization, we have got a board of directors who have been imparting such a great responsibility in various fields of organization to assure its lawful, strict and stringent social empowerment. I welcome Dr. Ansar Aziz, Dr. Hashim Aziz, Dr. Midilaj Aziz, and Dr. Anas Aziz. Now today we have got Dr. Anas Aziz, Director and Consultant Pediatrician. I welcome you, sir, onto the dais. With all the support, guidance, and expert opinions, Dr. Shashikala, Madam, our respected and beloved principal, is always with us. Even when she was sick, down with the laryngitis, she has come a long way. I welcome Madam to our CME. It is my distinct honor and privilege to extend a warm welcome to my classmate and the superintendent of this hospital, Dr. Santosh Kumar Ray, Professor in Pediatrics, Assisia Institute of Medical Sciences. Welcome. Now, I would like to welcome all the chairpersons and the presenters to our annual conference and Adamcon second edition, whose presence and privilege always add fascinating colors to our conference. I cannot move forward without having a few words about our department, where the occasional delightful chaos and fruitful disorder converge, offering a unique blend of excitement and harmony akin to embarking on a splendid adventure. Yes, it's about the Department of General Medicine. We got our mentor, Dr. Srikantan, Professor HOD, a former HOD and professor who has been here from birth of Assisia and has served for his best in the institution for the empowerment of the institution. I heartily welcome you, sir, to the function. And we have got Dr. Anil Vijaykumar, Dr. Shashidharan, Dr. Reshma, Dr. Amit, and the resident physician, Dr. Ijaz Muhammad, and our beloved pages and secretaries. Also, we have other department faculties furnishing the glue to our institution. I welcome on my own behalf and on behalf of the department, I welcome you all for this session. Once again, on behalf of all, on the top to bottom of Assisia, I welcome you all to Adamcon second edition. Let us gather together to make this occasion at its best, and let me conclude my words with a big thanks. Thank you.
Thank you so much, sir. As we celebrate this milestone, I invite Dr. Anas Aziz, sir, Consultant Pediatrician and Director of Assisia Institute of Medical Sciences and Research, to officially inaugurate Adamcon second edition and deliver the inaugural address. Sir, please.
Respected Principal, Medical Superintendent, distinguished delegates, faculty members, staff and students. It is my distinct pleasure to welcome you all to this important CME focused on the latest updates in clinical medicine. As we gather here, surrounded by colleagues and experts in the field, we embark on a journey of knowledge and discovery. This CME represents not just an opportunity for professional development, but a commitment in excellence in patient care. The landscape of medicine is constantly evolving, driven by groundbreaking research, innovative technologies, and the dedication of healthcare professionals like yourselves. Each day, we encounter new challenges and new possibilities. It is events like this that enable us to stay at the forefront of these advancements, ensuring that our patients receive the highest standard of care. This year's program has been thoughtfully designed to cover a range of critical topics from emerging therapies and diagnostic approaches to best practices in patient management. We will explore the latest findings in areas such as cardiology, neurology, oncology, infectious disease, and more. These insights will not only enhance our clinical acumen but also empower us to make informed decisions that positively impact the patient outcome. I encourage all of you to fully engage the sessions, participate actively in discussions, and take advantage of the networking opportunities available. The interactions and collaborations that stem from events like this often spark ideas, foster innovation, and strengthen our professional community. Before I conclude, I would like to extend my deepest gratitude to the organizers, the Department of General Medicine, especially our HOD, Dr. Rajashekharan sir, Dr. Sriganthan sir, Shashidharan Dr. Amit, Dr. Bibin, Dr. Ijaz, Dr. Anil Vijaykumar, and the residents, and the sponsors who have made this event possible. And one more thing I would like to say is, in our institute, I can say that one of the best department I can say is our general medicine department. So I appreciate our HOD and the entire team for conducting these kinds of CMS. Not only the CMEs, but their entire team is fully involved in a lot of activities in the department. So I expect other departments also to follow the same thing. In closing, let us approach this CME with enthusiasm and a commitment to learning. Together, let us embrace the challenges and opportunities that lie ahead in the dynamic field of clinical medicine. With these few words, I officially declare the inauguration of today's EME on the latest updates in medicine. Thank you all for your attention, and I wish you a productive and rewarding experience over the coming sessions today. Thank you very much.
Thank you, sir, for doing the honors. I heartily welcome Dr. K. Shashigala, Principal, Azizia Institute of Medical Sciences and Research, to Adamcon. We understand that ma'am will not be able to talk today due to personal inconveniences. Thank you, ma'am, for your gracious presence.
Now, I'd like to invite our dearest Medical Superintendent of Azizia Institute of Medical Sciences, Dr. Santosh Kumare, to address the gathering.
Respected Director, respected Principal, other dignitaries, my own classmate, Dr. Rajashekharan, head of the department. I have two more classmates down there, Dr. Lekha and Ravi is there. First of all, congratulations to the Department of Medicine headed by Dr. Rajashekharan for arranging this update, because these are the things that keeps us informed about the current developments of medicine. So this time last time it was a focused one on diabetes. This time it is a mixture of various topics. So I think it is going to be useful for most of the people who are practicing medicine. So all the best wishes for this endeavor. Thank you.
Thank you, sir, for doing the honors.
I invite our respected Dr. Srikanthan sir, former head of Department of General Medicine, to say a few words.
Good morning to all. Respected Hospital Director Dr. Anas, our Principal Dr. Shashigala, Professor Dr. Rajashekharan, Superintendent Dr. Santosh Kumar, and my colleague Dr. Sasiran. And I am standing here to deliver a felicitation for this CME. I expect gratitude for giving me this opportunity. CMEs are essential in medical institutions for delivering new knowledge to other faculty, other members of the medical field. This is the second CME conducted by the Department of Medicine in this hospital. For a proper conduction of the CME, you should have a good organization, then the support from the institution authorities, then help from the medical pharmaceuticals for sponsoring, and good faculty for delivering the speech, and the good participants when the medical, our hospital and other institution hospitals in the local areas. I express a good wishes for this CME. Thank you all.
Thank you, sir, for your kind words. To convey our appreciation, I invite our renowned professor and senior consultant physician of Department of General Medicine, Dr. Shashidharan, sir, to deliver the vote of thanks.
Good morning, respected teachers and my dear friends. As the time is running short, I will make my duty briskly. First, our department is extremely thankful to the directors, principal, and other administrative persons for allowing us to conduct the CME and the financial backing they gave us. Next, I express our great gratitude to various speakers who have spent hours to prepare slides and presentation to enhance the boundaries of our wisdom. Now, I express our gratitude to the audience, without which the program would have been in a great failure. And several pharma companies have supported the programs, and I am thankful to them also. Lastly, several doctors, including senior professors, superintendent, and PGs, house surgeons, all sections of people have had their own role in the program, and to tell the name of all the persons will be time consuming, but I cannot complete this without naming one person, that is Rajashekharan sir. Without him, this would not have happened. The whole program was planned and meticulously executed under the leadership of Professor Rajashekharan. Thank you, sir, and thank you very much.
Thank you, sir, for doing the honors. May I humbly request all the esteemed dignitaries to come off the dais so that we can start our next session. In the realm of oncology, myths linger like shadows, obscuring the path to understanding and healing. Yet, armed with knowledge and fortified by truth, we stand poised to dispel these misconceptions that have plagued the discourse surrounding cancer. As we convene to unravel the tangled web of oncological myths, together, let us embark on a journey of discovery, where the light of truth banishes the darkness of misinformation, paving the way for a future where cancer myths are nothing but a distant memory. by dispelling myths and promoting accurate information. Our next session is on oncological misconceptions by Dr. Parvati Rajashekharan, consultant oncologist, Karkinos Healthcare, Trivandrum. Let me invite Dr. Anas Aziz, consultant pediatrician and director, Azizia Institute of Medical Sciences, and Dr. Santosh, medical superintendent, professor, Department of Pediatrics, Azizia Institute of Medical Sciences, to chair our next session.
So let us start the session. So I invite Dr. Parvati Rajashekharan, who is the daughter of our medicine HOD, to Azizia.
Good morning, all. Our speaker today is Dr. Parvati Rajashekharan, who is the consultant oncologist, Karkinos Healthcare Center, PRS, Trivandrum. Here she has had her MD radiation oncology from RCC and had published research work on a few important topics which you can read from that. And the area of her interest is radiotherapy, CT simulation, 3D IM, which I do not know what. Brachytherapy. I heard of brachytherapy in vaginal radiation. I think it is the same. Interstitial and intracavitary, and work experience in special techniques. So over to Dr. Parvati for the session.
Good morning, everyone. So my topic is a relatively very simple topic that had been presented by when compared to the topics that had been presented here by our seniors. So regarding oncology, so I'll start with a small event that happened recently in our department. So around 6 months back, one of my friends, she came with her mother. She had a lump in her breast. Now, clinically, it was a very early stage disease. The lump was hardly 2 centimeters in size. There was no palpable axillary nodes. Now, the biopsy from the lump came as a luminal A disease. So, luminal A disease is one of the least aggressive subtypes of breast cancer. So, we even told her that she might not require chemotherapy or radiation. So, they went on with treatment. She underwent primary surgery. Now, she underwent an MRM. Now, after MRM, when the final histopathology report came, the disease turned out to be a stage 3 disease. Now, what started out as a stage 1 disease clinically, when the final HPR came, it was a stage 3 disease. The size of the lump was in fact 7 centimeters. She had 6 nodes positive with extranodal extension, LVS, IPNI, all those are representing poor prognostic features. Now, being a stage 3 disease, she required a full course of 8 chemotherapies with radiation and 5 years of hormone therapy, along with 2 years of CDK inhibitor therapy. Now, that is a very long course of treatment. Now, this particular event that got me thinking, if she had underwent a screening mammogram at least within 1 year, we might have been able to pick up that lump at least sometime earlier. Now, for her, she was a lady who was extremely healthy. She did not have any risk factors like we say. She did not have a family history. She lived a healthy lifestyle. She ate the healthy food. She worked out well. She was not obese. She was multi-para. She did not have a family history. She got tested. She underwent executive checkups every year. But then she always thought that she was healthy. She did not have any symptoms. So why should I get screened for cancer? I'm healthy, so why should I even think of getting cancer at some point of time? Now, that is the problem. Thinking that we are healthy, we don't have any symptoms, so we need not get tested for cancer is the basic root cause of all misconceptions in oncology. There are a lot of false thoughts about cancer. Like people think that if they don't have family history, they will not develop cancer. If a lump that they develop is not painful, then we will not get cancer. Cancer will happen only in older people. If I am young, I need not get screened for cancer. If I don't have habits, I don't smoke, I will not get lung cancer. Gynecological cancers will occur only in older women. Things like that. There are a lot of false misconceptions in oncology. Now, in order to understand the facts in oncology, the basic thing is to understand about the techniques or the modalities we have in cancer screening and early detection. Now, if we talk about the statistics, about 1.3 million people are diagnosed of cancer in India. New cases were diagnosed in India in 2022, which crudely translates into the fact that about 1 in 10 Indians are likely to develop cancer during their lifetime. Now, Kerala, the scenario in Kerala is also not different. About 66,000 people, new cases were diagnosed in Kerala in the year of 2020. Now, the problem is, if a person is diagnosed of cancer, the 5-year survival in a middle-income country or a developing country like India falls below 30%. Now, that is almost less than 50% of the survival rate in a developed country like USA. Now, if you look at these statistics, if you look at the epidemiology, breast cancer remains the most common cancer in women in the world, which is followed by cervical cancer. In men, the most common cancer in the world is prostate, which is followed by lung cancer. But if we talk about the mortality rate, in males, the most common cause of mortality is lung cancer, followed by prostate cancer. In female, again, breast cancer remains the most common cause of mortality. Now, like I said, with these statistics, with the cancer number being rampantly in a rise, or when there is an increase in number of cancer cases, with increase in number, misconceptions will also start thriving. So people, like I said, have a number of false beliefs regarding cancer, early detection of cancer and cancer screening. Now, this lack of understanding of cancer about the basic screening tests that we have, early detection modalities that we have, this understanding is required to address the misconceptions. So even today, because of this lack of awareness, most people will wait for a symptom to develop to get tested. Even for screening amenable cancers like breast cancer or cervical cancer, people will always wait to have a symptom to get tested. Very simply put, we all have executive checkups in our hospitals. I mean, most people after the age of 30 years, they'll all go forward for an executive checkup after 30 years. But most hospitals does not have cancer screening incorporated into their executive checkup. So that is the problem. People in India, let alone in Kerala, we all lack the culture of getting screened for cancer. So people, they are ready to spend a lot of money for a haircut, but when we order a expensive test for screening, people are always reluctant to do it. Now, because of this, about 70% to 80% of cancers in India is being diagnosed in a late stage. Now, the problem with that is, once the cancer is diagnosed in an advanced stage, there is a huge toll of financial toll on the patient and the family. Also, the chance of getting a complete cure when the cancer is diagnosed in an advanced stage is also less. If we can detect the cancer in an early stage, we always have the option of treating it completely. If we talk about screening amenable cancers, There are 6 cancers that are amenable to screening. 2 of them we all know, breast cancer and cervical cancer. Those two are the easily screenable cancers that we have. Now, if we talk about breast cancer is the most common cancer in women in India. About 27% of all cancers in women are accounted by breast cancer. This is usually occurring around the age group of 50 to 64 years, more common in urban women. That is, about 1 in 22 women in urban areas are likely to develop a breast cancer, while only 1 in 60 women in rural areas are likely to develop a breast cancer. So if we look at the statistics in developing countries, all the developing countries show a rising trend in the incidence of breast cancer over the recent years. Now, what are the screening modalities that we have? We all know mammogram, but then it's not just mammogram. It is according to the guidelines, a female should start screening for breast cancer from the age of 20 years. Now, from 20 years onwards, we should always advise them self-breast examination. By the time of 30 years, after 30 years, women should be advised clinical breast examination. That is, at least once a year, they should go to a hospital, get checked up by a physician. Now, if there is anything suspicious in the clinical breast examination, what we advise is, if the woman is less than 40 years, an ultrasound. If she is more than 40 years, we advise mammogram. Now, regarding when to start doing a screening mammogram, we usually follow 2 sets of guidelines. One is by the US Preventive Task Force and another one by the American Cancer Society. What we usually follow is the one by the American Cancer Society. So according to them, all women from 45 years onwards should be advised a screening mammogram every year. Now, this is till 54 years. After 54 years, from 55 years to 74 years, what is recommended is a screening mammogram every 2 years. Now, after 75 years, usually we don't have a recommendation like that to do an yearly or bi-yearly mammogram. What we say is, if the woman wants to get screened, or they have a life expectancy of more than 10 years, or she is healthy enough, then we should always give her the option of getting screened with a mammogram. Coming to the second most common cancer that is amenable to screening, that is cervical cancer. This usually occurs around 20 to 67 years, in women of 20 to 67 years. It accounts for about 22% of all cancer cases in women. Now, unlike breast cancer, cervical cancer is more common in women in rural areas. Now, a peculiarity of cervical cancer is, it is one cancer that is caused by a virus. The cause of cervical cancer is actually persistent infection with human papilloma virus, like we all know. Now, what happens is, about 95% of sexually active women and men harbor HPV virus in their system. In most of them, it is self-limiting, it will go off on its own. But in some people, for some reason, the infection with HPV just persists. Now, over years, this gradually destroys the mucosa, causing low-grade dysplasias, which we usually call CIN, cervical intraepithelial neoplasia. Now, if we don't address it at that point, it will again keep persisting, ultimately leading into an invasive cancer. So, HPV virus, it not only causes cervical cancer, it causes other cancers of the genital tract, including cancer of vagina, vulva, penis, anal canal, and even cancer of oropharynx. Now, what we recommend is screening for HPV virus from the age of 30 years onwards for all women. If we don't usually recommend it for women below the age of 21 years, even if she is sexually active. From 21 to 30 years also, we just recommend once in 3 year cytology testing. Now, after 30 years till 65 years, what we recommend is an HPV DNA testing. It's a simple RT-PCR test for detecting infection with HPV virus. Now, once it is negative, it has to be repeated only after 5 years. Now, by the time the woman is 65 years, we usually recommend to stop screening, but we should not stop screening if any female have a history of cervical intraepithelial neoplasia 2 or 3. Now, because cervical cancer is caused by a virus, we always have the option of vaccination for cervical cancer. Now, what WHO recommends is children, I mean boys and girls before the age from 9 years onwards can be vaccinated for HPV. Ideal age is usually told between 11 to 12 years, that is before the onset of sexual activity in children. The recommendations say that from 9 to 14 years, 2 doses are warranted at 6 months apart, and from 15 to 26 years, 3 doses are warranted at 0, 2 months and 6 months. Above 27 years till 45 years also, women can take vaccine, but the efficacy is not as good as when taken in a lower age group. Now, earlier we just had Gardasil 4 and Gardasil 9. Now the Serum Institute has developed our own vaccine. So the cost of the vaccine has come down tremendously. Now, even if any person is vaccinated, it does not mean that they don't have to get screened. Even if they are vaccinated, screening has to go hand in hand for the prevention of cervical cancer. Now, other less common cancers. In India, especially in Kerala, we have a lot of oral cavity cancers. Now, all the studies shows that in recent years, there is an increase in rate of oral cavity cancers among adult men. Now, most commonly, we see patches, leukoplakia and erythroplakia in the mouth as precancerous lesions. Now, these individuals with precancerous lesions has to be followed up regularly to look for any malignant transformation in these lesions. There are a number of tests that is available for screening, but what is practical for us is to do a very simple oral visual examination for patients who have history of habits. Now, when we do an oral examination, always make sure not to miss the hidden areas in the mouth, especially the gingivobuccal sulcus, the undersurface of tongue, RMT, palate, all those areas should not be missed while doing a oral visual examination. Now, this is one very commonly encountered lesion in the mouth. This is a leukoplakia. This is what we see most commonly. Leukoplakia has a 9% chance of getting transformed into malignancy. Again, it is leukoplakia. This is nodular variant of leukoplakia. This is an ulcerated variant. Now, in this picture, you can see a small white patch beneath, and above the white patch, there is a proliferative lesion. So here, the leukoplakia has got a malignant transformation. So such lesions should not be missed. They should always prompt a biopsy for people who have such lesions. Coming to the next common cancer, that is lung cancer. According to recommendations by the US Preventive Task Force, something called a low-dose CT scan is what is recommended for screening for lung cancer. This is usually recommended for people from 55 to 74 years of age with at least a 30-pack year smoking history, who currently smoke or have quit smoking within the past 15 years, and those who are in relatively good health. But then in a low middle income country like ours, where the resources are very scarce and where the resources are not readily available, something like LD CT scan is not readily available everywhere. So in that case, we don't routinely recommend it. We just ask them to take a chest X-ray in those people who are symptomatic or those who warrant screening for lung cancer. Next is colon cancer. Colon cancer can be screened with 3 tests. One is a simple FOBT test or fecal occult blood test. Another is flexible sigmoidoscopy and colonoscopy. What is recommended is a yearly FOBT test, a sigmoidoscopy once in every 5 years, and a colonoscopy once in every 10 years. Now, an average individual should start screening for colorectal cancer after the age of 50 years. But then if there is a family history of colorectal cancer, say the family member had the cancer at the age of 45 years, then all the blood relatives, I mean the first degree relatives, should start screening at least 10 years prior to that. Say the person had a colon cancer at 45 years, the first degree relatives should start screening at 35 years. So just like I said, FIT test or FOBT test is very simple test. It's just like a UPT or a COVID rapid antigen test. It is something that can be done by the patient themselves or the person themselves. Just in those tests, it just one line means negative and 2 lines means positive for blood in stool. So if such a positive test is encountered, we always refer the patient for colonoscopy. Now, lastly, prostate cancer, which is on the rise these days, usually encountered in men above the age of 65 years. For them, what we recommend is, for men, what we recommend is routine PSA testing at least yearly after 60 years of age. From 50 years onwards, it is recommended if the person is symptomatic, that is, if they have any lower urinary tract symptoms. So, more or less, those were the common screening tests that were available. Now, understanding of these screening modalities that we readily have is very important. Usually, why it is important for everyone, all doctors, not just oncologists, everyone is, no cancer patient will come to an oncologist first. They always present to a physician first because they are the ones who always evaluate the person first. All the initial evaluations will be done by them. So mostly the early pickup or early detection are usually done by the physicians. Once the diagnosis is made, only these patients, I mean cancer patients, are referred to the oncologist. So in our place in India, where majority of the cancers are being diagnosed in a late stage, where we have resources that are very less, it is very crucial that we are able to pick up cancer in an early stage. At least by stage 1 or 2, we should be able to pick up cancer to give them a better treatment and better possibility of cure. So I'll be winding up. In that note, I will be winding up my presentation. Thank you very much for everyone's patience.
This is actually an interesting topic because a lot of alternative medicine people are involved in this. And I think you have cleared all the myths regarding the oncology. And I would like to ask you one doubt, that is, what is the incidence of breast cancer in men?
Sir, not much, sir. Breast cancer, even though it is seen in men, maybe less than 2%. Hardly, if we take women, when 1,000 women develop breast cancer, only one man will have breast cancer. But it is there.
It is there.
It is
but
there.
Less than 2%.
Yes.
And any screening test?
No, we can't really recommend the mammogram because for mammogram, we need to have breast tissue so that the plates of the, that X-ray plates has to compress the breast. So for men, it is quite difficult because they have less breast tissue. But then we can do an ultrasound for them.
Okay. Okay.
Thank you, Dr. Parvati. Any questions from the floor? I have a few questions.
Yes, sir.
First of all, as our director said about the male, and you need a breast tissue to compress and do the mammogram, which is actually very uncomfortable. Can we do ultrasound instead of that?
Yes.
This is one question that many mothers of children that I look after ask me.
We can, sir. Actually, if the woman is less than 40 years, we'll definitely do USG. But then the pickup rate with the USG for breast lump is very difficult. Also, how we grade a breast lump is with BIRAD scoring. So to do a BIRAD scoring, if it is BIRADS 4 or above, we usually suspect a malignancy. To do that scoring, we need to have a mammogram. In women who's less than 40 years, if we cannot do a mammogram, we usually recommend MR mammogram. That is not painful.
Okay. Then regarding the HPV,
yes, sir.
You said you look for the HPV DNA beyond. Suppose the person is beyond the usual immunization age, say 30 years, and the DNA is negative. Do you recommend vaccination?
Yes, definitely.
Okay.
Because the recent studies have shown that even if the woman is more than 26 years, say 40 years, even if she is vaccinated, her chance of developing the cervical cancer is less when compared to an unvaccinated cohort. There is a recent study in NEJM for that.
Okay. Then regarding prostate CA, you said about ultrasound. Is it rectal probe that you meant or the abdominal ultrasound?
Sir, I didn't get it.
I mean, in the prostate cancer, you mentioned about the ultrasound. Do you want a rectal probe or abdominal ultrasound?
Rectal probe will be better, sir.
Okay. But that's not usually being done.
No,
That's why I
it's not a
asked.
part of screening.
Okay. Oh, okay.
No, it's just that we do PSA for screening. Once we suspect something, we'll directly go for MRI and a biopsy.
Then a few myths. One is when I was in SAT, I had a request for the 11 kV power line, which we initially declined because of risk of leukemia and all. Is there anything like that?
Not
Power
that I
lines.
know of, sir.
Oh, you are frightening me. Second thing is the mobile, because director himself is always on the mobile. I am always on the mobile. Does it have any influence on your brain CA and all?
There are few studies that show that prolonged exposure can increase the risk of meningiomas. Other than that, meningiomas in brain.
Okay, regarding now the WhatsApp is full of sugar frightening. Don't take sugar, you will develop cancer. What's your take on
No,
that?
sir, definitely no.
Okay. And before I wind up, biopsy, suppose you do a biopsy, does it really spread the malignancy? Suppose you do a biopsy, the breast lump, does it cause a spread of the disease?
Not really, sir. The point is, it might cause some seeding in the surrounding tissues, but the whole point is we need to have a diagnosis and we need to know the subtype, because the entire treatment changes with each subtype. So the benefit is way superior to the small risk that is associated with it. That is why we always do biopsy first.
Okay, thank you very much. Any questions from the floor?
One answer to Dr. Santosh's question whether mobile phones are related to cancer. Well, the studies say that traveling with a mobile phone, if you receive a call, the chances are high. It operates in the frequency of 300 to 3000 megahertz. But when you travel, it switches towers. There's something called the uplinking frequency and a downlinking frequency. Then the power of the mobile phone emission is to a tune of 10 raised to the power of 9 gigahertz. Then the tumorigenicity is high. Those who travel with in a train or the bus, you travel with the mobile phone, there are studies which say that the frequency of cancer is high. That's why in a closed compartment, Shatabdi, as a pregnant lady here, you ask them to switch off the mobile phone. In rapidly multiplying tissues like the testis or the ovum, it does have an effect. I think one of the reasons for infertility is mobile phones.
Not proven, but still I think HOD has got a point, because when we travel, our mobile phone loses charge very rapidly.
Yes.
So that could be one of the reasons. Is there any more questions? So thank you, Dr. Parvati, for the very informative lecture. And let's close the session. Thank you.
Now I humbly request our respected chairpersons to hand over the memento to Dr. Parvati Rajashekharan. Next, I invite Dr. P. Suresh, Consultant Physician, SUT, and Dr. Abdul Majid, Consultant Physician, ESI retired, to award our chairpersons with a memento. A gentle reminder to all the delegates to submit their e-poster material near the reception area. Thank you.
The primary and most beautiful of nature's qualities is motion. It is said, if you are not moving, then you are not living. Ability to move makes one independent, self-sufficient, helps explore the intricacies and live life to its fullest. Arthritis affects millions of people worldwide, making a significant impact on daily life, causing pain and disability that may affect mobility, work, and quality of life. Our next talk is on approach to arthritis by Dr. Ashwin M. Nair, consultant rheumatologist from Travancore Medicity, Kollam. Let us invite Dr. C. Rajashekharan, Head of Department, Department of General Medicine, Azizia Institute of Medical Sciences and Research, and Dr. Sanju Daniel John, Senior Consultant Physician, Apollo Hospital, Kochi.
Good morning. The next topic is Approach to Arthritis by Dr. Ashwin M. Nair.
Dr. Ashwin is personally known to me. He's a consultant rheumatologist, Travancore Medical College, Kollam. And I was fortunate enough to chair one of his CMEs, which is one of the flamboyant CMEs, I would say. And as we know, arthritis is a real difficult issue when you encounter clinical practice. Of late, I had a case of arthritis which was VDR positive, TPHA positive. First time in my life I am seeing the case. And to put in a simple way, most often arthritis is very straightforward in presentation, but sometimes it may be a masquerading presentation. Dr. Ashwin, please.
Good morning to all. At the outset, I would like to thank Rajashekharan sir and his team for having me here today. My wishes to all the seniors, Lekha ma'am, Anil sir, and all the others gathered here today. Today, I thought when sir gave me this topic of approach to arthritis, there's so many aspects to, like what sir said. Infection is a very important differential whenever we approach a patient with joint pain. So I thought we'll clinically approach arthritis in a way it's supposed to. Listening to the patient, the patient will give us a diagnosis. All we have to do is closely listen to a patient. So broadly, this is all our rheumatological diseases can be divided into three aspects. One is arthritis per se, the connective tissue diseases, and vasculitis. Now, all of these things, I'm talking about the non-infectious parts, all of this can present with arthritis. You can have, like today morning as Sharma sir was saying about Takayasu arthritis and giant cell arthritis, you can have arthritis when those patients with vasculitis can also present with arthritis. You might be having a patient with lupus, or you might be having a patient with Sjogren's who might be sitting with arthritis. So not all patients of arthritis are rheumatoids. That's a very big misconception which all of us have. Now, early diagnosis and early recognition, like what Dr. Parvati has said, early recognition is very, very important for diagnosing these conditions. It allows early intervention, better long-term outcome, and reduces the damage accrual. I hardly or any other system being involved. Now, once historically you have an idea, there is no referred pain, it's not a diffuse pain, you know it's from the musculoskeletal system. You start off, is it arthritis, is it bursitis, is it tendinitis, is it enthesitis, is it bone pain, is it muscle pain, is it fibromyalgia, or is it a growing pain which is very common among our pediatric population. Now, each of these things are very, very important. Arthritis, pain, swelling involving the joints. Bursitis, pain, tenderness over the anatomical sites which correspond to a bursa. Tendinitis are often long, tender swellings along the distribution of a tendon. Enthesitis often occurring wherever tendon, fascia, ligaments attached to a bone. Bone pains, which are often diffuse. Muscle pains, vague ache, which the patient says. And fibromyalgia, which is very, very common among our women nowadays. So once you've established that this is in the musculoskeletal system, now you move on thinking, is it articular or is it non-articular or periarticular? So that is one of the most important things. Articular is when it arises from the synovium, capsule or the cartilage. Periarticular is basically when it occurs from the tendon, ligaments or bursa. Now a very easy way of basically asking is, ask the patient whether he has pain in all the ranges of movement, irrespective of whether it's active or passive. And the other thing is just examining for external rotation if shoulder is a problem. The first and foremost movement which is limited periarticularly in a patient with shoulder joint pain is external rotation. So once you have established that this is musculoskeletal, this is from the joint, now you have to distinguish whether it's an arthralgia or an arthritis. Arthralgia is just pain in the joint, arthritis is pain and swelling. Once that is done, now you go to the most important, and this is basically what I'm teaching my students from this thing. All you have to do in my OPD is distinguish between whether this is inflammatory and non-inflammatory. By this per se, we can basically, several infections, several other differentials can ideally be ruled out by just asking these questions. Do you have pain in the early morning hours? Do you have pain when you get up in the early morning hours? If yes, how much time does the pain take to wean off? Is it associated with an early morning stiffness? If the early morning stiffness is more than half an hour, any pain which occurs in the early morning hours worsens on awakening with early morning stiffness lasting for more than 30 minutes is highly suspicious of an arthritis. If it is more than 1 hour, if the early morning stiffness is more than 1 hour, your specificity for diagnosing arthritis increases. Swelling may or may not be there. You can have early morning pain even in patients with osteoarthritis also. So once you are sure that this is an inflammatory thing, next you have to find out whether it's an acute or a chronic onset. Now acute is anything less than or equal to less than 6 weeks, and the chronic is basically more than or equal to 6 weeks. So if you have a patient, like it's a very common thing, patient coming to a casualty with a single joint pain. Often, very common, our thought process is it's just a gout, we can send off the patient. But please just sit with the patient, ask for this thing. But many times we have missed septic arthritis, tubercular arthritis in this way. So broadly, I would like actually to send in a message. If you have a patient with monoarthritis, the first and foremost, please distinguish between septic arthritis versus pseudoseptic arthritis. And pseudoseptic arthritis is your gout, CPPD crystal disease. Even rheumatoid arthritis can present as a single joint involvement. Gonococcal arthritis, etc. can come. The other things, often in a pediatric population, hemarthrosis and even trauma is quite common. Chronic, anything lasting for 6 weeks and more. In this, you have again infections coming, tubercular, fungal arthritis. And so, if you have a patient who has joint involvement going on for more than 6 weeks in a patient, please ask your ortho colleagues for a biopsy of the joint before you put the patient on steroids. We have had several consults earlier. We have had patients coming, single joint, predominant single joint involvement, X-ray showing completely damaged joints, but you see that just a biopsy will give you the diagnosis of a tubercular etiology. Next is basically, so what you did first is musculoskeletal, yes or no. joint, is it yes or no? Then whether you looked at whether it's inflammatory or non-inflammatory, looked at whether it's acute or chronic. Now you have to look at the extent and pattern of involvement, and that's very important. Now when you look at the extent and pattern of involvement, now you're asking the patient which all joints are being involved, and what is the symmetry, or is it symmetrical, asymmetrical, is it how, what is the extent of involvement, which all joints, or the sequence of involvement is basically what you ought to ask. Is it appendicular or axial? So if it's appendicular involvement, it's more for peripheral arthritis. Axial involvement, seronegative spondyloarthritis. Whether it's monoarticular, oligoarticular, or polyarticular, which I'll come to. Whether it is large joint predominant arthritis or a small joint predominant arthritis. So few examples like our typical rheumatoid arthritis, which is ideally defined as a deforming, inflammatory, symmetrical polyarthritis with predominant involvement of the small joints, particularly the metacarpophalangeal joints. And if you can see the picture, the metacarpophalangeal joints is very much involved. A similar one is a distinguished one involving the the axial skeleton is your ankylosing spondylitis, where the patient gives a typical history of an inflammatory low back ache, pain in the lower back on awakening, which lasts for more than half an hour, with early morning stiffness lasting for more than half an hour. Psoriatic arthritis is again another, it's grouped under this broad category of seronegative spondyloarthritis, where you have ankylosing spondylitis, reactive arthritis, psoriatic arthritis, enteropathic arthritis. Again, can have both appendicular and axial involvement, but it's always asymmetrical. Can be polyarticular. Most of us would know the various pattern of involvement in psoriatic arthritis. Polyarticular, oligoarticular, or just it could be a sacroiliitis or just a DIP joint involvement. Reactive arthritis, again, asymmetrical, large joint, predominant lower limb involvement. So if you have a patient coming to you with lower limb involvement, your differentials should be seronegative spondyloarthritis like psoriatic reactive arthritis. Then it goes into other conditions like sarcoidosis and gout. So if you look at the causes of monoarticular arthritis, like what Sir said, you can have a umpteen number of causes for monoarticular arthritis. So please don't consider that all your arthritis is rheumatoid. No. And this is a general notion. You know, if you look at the first and foremost thing is infection. If you have a patient with just one joint involvement, infection has to be ruled out. And only then infection, crystal induced arthritis, and then only the other differentials come. Now, this was a patient who had recently come with history of just IP joint involvement. And to my, this thing, I've actually worked under my professor, my late professor, Dr. Danda, and this is basically a sign on him. Dr. Danda's sign, which is basically when there's involvement of the IP joint, very, very characteristic of psoriatic arthritis. This was another patient who came with a right sternoclavicular joint involvement. And when you see monoarthritis involving a right sternoclavicular involvement, please think of septic arthritis, seronegative arthritis, and gout. And these are the most common ones. This was a patient of seronegative spondyloarthritis. Now, causes of oligoarticular involvement are again plenty, but again, the differentials, again, acute and chronic, whether it is spondyloarthropathy, it could be reactive arthritis, it could be rheumatoid. Sarcoidosis can also present as an oligoarticular involvement. Now, polyarticular involvement, and this is basically the foremost common presentation to most of us. So I've written a workflow, and I would basically encourage all our postgraduates to basically follow this order in your history taking when you are approaching these patients with polyarthritis. First and foremost, is it in the joint? Distinguish between inflammatory and non-inflammatory, then further divide it into acute and chronic, and then think of whether it's infectious, whether it's a rheumatological condition, or it is something else. Now, age and gender also helps in our, if you have a male patient coming with arthritis, it's more probably a spondyloarthritis, crystal-induced arthritis, most probably. If you have a patient with women coming to you, rheumatoid should be first. Other connective tissue diseases like lupus, Sjogren's, all being differentials of your patient with arthritis. Next is basically what I said, symmetricity. Look at whether it is a symmetrical involvement, which typically is a rheumatoid, or it could be asymmetrical involvement like your psoriatic, reactive arthritis, gouty arthritis. But mind you, onset of these things may be asymmetrical and it may progress on to developing a symmetrical arthritis. So just because a patient has a duration of illness of 2 years, now has a symmetrical involvement, doesn't mean that it can't be a psoriatic or a reactive arthritis. Please dig up how did it start? Was it always one joint or it was multiple joint involvement, and which is very typical of a rheumatoid arthritis. Now the joints also involved can give you a clue. If the patient has a predominant DIP joint involvement, it's often gout, osteoarthritis, or it could be another condition called as multicentric reticular histiocytosis. Psoriasis can also have predominant DIP involvement. PIP involvement, again, osteoarthritis, very predominant. You have your Heberdens and the Bouchard's nodes there. It can occur in lupus, rheumatoid arthritis, psoriatic arthritis. Typical metacarpophalangeal joint involvement is the rheumatoid arthritis. Wrist, again, rheumatoid arthritis. First CMC joint, and that is basically what I would like to say in the next few slides. Now, the other thing is the row and ray pattern of involvement. A row pattern of involvement of the joints is very typical of rheumatoid arthritis, and a ray pattern of involvement is very typical of psoriatic arthritis. And please always keep this sequence in your mind whenever you're approaching patients. As I said, a very important distinguishing feature is osteoarthritis. You have to distinguish, even patients with osteoarthritis can have early morning pain, but please ask for the duration of the pain and whether the early morning stiffness is the duration of the early morning stiffness. That's very important. In degenerative arthritis, the early morning stiffness lasts for often less than 15 minutes. 0 to 15 minutes is often, of the early morning stiffness is often degenerative. 15 to 30 is a gray zone, and more than 30 is often inflammatory. That is basically the dictum or what you have to remember. Now, you have a patient who comes to the casualty with a red hot joint. So if you have a red hot joint, please consider infections first and then gouty arthritis. This was 2 different patients who had come to us. One was a man who presented with acute onset of pain and swelling over his middle finger, and on examining he had psoriatic plaques, and this was a dactylitis rather than a joint involvement. That was a patient with psoriatic arthritis. The other one is an elderly lady who presented with acute onset of pain in her right wrist. We did an MRI, I did an ultrasound, then we did an MRI. Rheumatoid factor was markedly positive. Even then, I went on to do a biopsy and came out to be a tubercular synovitis in this patient. Now, migratory arthritis is very important. Rapid onset of swelling in 2 or more joints with resolution over a few days. And as the symptoms resolve, it emerges in another joint. And there are several examples for migratory arthritis. Gonococcal arthritis, rheumatic fever, sarcoidosis, SLE being some of the more commoner causes of migratory arthritis. So that is why the pattern of involvement is very, very crucial in our patients. This is basically a typical lesion of Lyme's disease, which has been reported in India as well, so not quite far away. Now, episodic arthritis is another thing. Often patient comes with episodic pattern of involvement where you have to consider palindromic rheumatism, psoriatic and relapsing polychondritis as differentials for episodic arthritis. And finally, you have to ask for extra-articular manifestations, like is there involvement of enthesitis, dactylitis, uveitis, tenosynovitis, all very suggestive of a seronegative spondyloarthritis. And also you have to distinguish between a rheumatoid and a psoriatic arthritis. I'll just skip this slide. And is there any other organ involved? Now, these are all our patients which we have been dealing with over the last couple of an year or so. The one above is a lady who had come with scleromalacia perforans, and she was then diagnosed retrospectively to have rheumatoid and had come. One man who had no other issues, rather just nail pitting, and later on he evolved to develop arthritis. The third is a girl who presented with joint pains, and within a matter of few days she developed cough, breathlessness, landed up in ICU, and that is the first picture of a diffuse alveolar hemorrhage. So this was a patient of lupus. So not all joint pains are typical. So these are the other skin lesions which you have to think of. and then fever and polyarthritis. Infectious causes have to be ruled out, reactive arthritis being other, but you can have Still's disease as a very important differential when you are approaching fever and joint pains. I think I'll stop with this, but this is what I would like to summarize. When you are approaching a musculoskeletal system, please look at the distribution. First, establish whether it's articular or non-articular, whether it is a single joint oligoarthritis or is it a polyarthritis, and then think of whether it's acute and chronic and make your differentials. So this is something that I would like to leave with everybody. Pattern recognition is a key in arthritis, and if you get the pattern recognition, half of your job is done. Thank you so much.
Thank you, Dr. Ashwin, for that very informative presentation. I think it's open for discussion. Any questions, queries?
Dr. Ashwin, it's a very good talk that you have done. Here, Dr. Sanjay. In OPD, commonly we see many patients with arthritis, but then most of the patients we see gouty arthritis and osteoarthritis. So in gouty arthritis, when patients come to it with uric acid levels, is it very important or we have to clinically treat the patient with gouty arthritis?
Very, very true, sir. Actually, it's because of time constraints that I couldn't put it up. The dictum, or please make this thing, I've often seen patients asking, my uric acid level is normal during an attack. During an attack, if you look at it pathophysiologically also, the uric acid moves into the joints. So the blood uric acid level is either normal or low. You'll never get a high. You might get a high, probably 7 or 8, but ideally speaking, the patient might be having somewhere around 9 or 10 or even higher. So interictal uric acid levels is basically what's more important. Interictal meaning between the attacks. So probably asking the patient to repeat a uric acid level after 3 weeks or a month later is ideal. Till then, I think clinical acumen is basically what's required for gouty arthritis. The distribution, involvement of the first metatarsophalangeal joint, which again is not very uncommon nowadays. We have several patients coming with ankle joint, knee joint, even the wrist joint involvement presenting with gouty arthritis. So
it was a very informative talk. It was very important for all of us here, approach to arthritis. One last question is from my side is, what is the indication for doing a musculoskeletal ultrasound in arthritis?
I am doing a lot of musculoskeletal ultrasounds. So it's like, for me, it is my stethoscope actually. It's very important. I don't rely on a radiologist. I do it myself. Why? Because there's a very fine line. I mean, there's actually a gross discrepancy between what I want and what a radiologist wants. I don't want what the orthopedicians need. I want to see whether there's inflammation or not. That's basically what I want. If anything other than that, I send the patient over to my orthopedic colleague. Basically, why? Because I want to know whether there's synovitis or not. I want to know the extent of synovitis, whether there's effusion in the joint, is there any destructive element, is there any erosions there, so that I can approach and treat the patient. And for gout, typically if we see, there are several signs also being described, double contour sign, snowstorm appearance, several signs being described. If I see all those things, I do start the patient very early and quite rewarding actually. So.
Thank you. Any questions?
One comment. I have at least 2 mothers whom I have treated as children for rheumatoid arthritis and got relieved with standard treatment, and now they have SLE. So is it a common pattern that it presents like rheumatoid arthritis?
So that's what I'm sorry, sir. That's what I was just telling. We had actually a patient contact session a couple of days back as an awareness for rheumatoid arthritis. So many of the patients actually said, I have a relative with some other disease. Then how did I get rheumatoid? Is it all hereditary? A switch in pattern is known, but often it is not rheumatoid to start with. Just because they have a rheumatoid factor being positive doesn't mean that the patient has rheumatoid arthritis. And that's why the pattern of involvement is very important. I think what most of us do in our OPDs, in our busy OPDs, is basically when a patient comes with joint pain, we just directly, patient has come with joint pain, right? Do rheumatoid factor, anti-CCP, ANA, a battery of tests is basically written. Sometimes to the extent that I've seen people even writing off ANCAs also as a part of arthritis evaluation, which is wrong. ANCAs is 1,200 for just PR3 ANCA and the other one. So that itself you're basically asking the patient to shell out about 4,000, 5,000 rupees without listening to the patient. So if there is a typical, like I told you, sir, that elderly the elderly lady who had come with monoarthritis, her rheumatoid factor levels was more than 640. By all extent, she is looking at it. But a monoarthritis presenting with a strong rheumatoid factor positivity, without there's some oddity to it. And that's why I asked for the biopsy and it came out to be tuberculosis. Once the tuberculosis was treated, a repeat rheumatoid factor was done, which was normal. So probably to start with, this patient always had, but this is known. Shift in connective tissue diseases is always known. Patients often have an undifferentiated course, and with time, if left untreated, they do differentiate into either one of these conditions. We've had mothers of rheumatoid having children of lupus. We've had lupus patients having sisters with rheumatoid arthritis. There are offsprings coming with different things. There are normal patients also. The permutation combination is normal. But often I think when we look at pediatric, we have to be a little cautious. Why? Because pediatric arthritis can change their pattern, and that's why they have to be kept under close follow-up now. And I think there are very stringent criteria, protocol now to follow children with JI, juvenile idiopathic arthritis. So it shouldn't be a problem.
And the painless uveitis,
yes, sir.
That is also something that people miss.
Absolutely, sir. So that is something that I would like to encourage everyone. Any child coming with arthritis, please send them to our ophthalmologist for looking for uveitis. And the painless uveitis, rightly what sir said, is very, very typical of an oligoarthritis, which can start in children from 3 to 5 years of age, predominantly girls presenting between 3 and 5 years of age with joint pains. Please send them to an ophthalmologist because they often have a subclinical uveitis.
So what's your opinion regarding PRP injections to be given as a treatment?
Yeah, sir, a lot of controversies. People are getting different, this thing. I don't, because there is a lot of myth behind it. There is no evidence. Even now, the recommendations for osteoarthritis hasn't put PRP injections in, and actually they have favored against PRP injections rather than giving. But even now there are people giving PRP injections. We we need more information on that, sir.
Anyway, thank you, Dr. Ashwin, for that very informative presentation, and the house and a lot of questions which are fairly to a reason clear. I think a lot of centers are there who give the plasma injection, Tiruvalla, Ernakulam, and they make a big fortune out of that also. Thank you, Dr. Ashwin. Thank you very much for your excellent presentation.
Thank you, sir. I request the chairs to kindly present the memento to Dr. Ashwin. I invite Dr. Binu Ramesh, Senior Consultant Cardiologist, Apollo Hospital, Chennai, and Dr. Amit N, Associate Professor, Department of General Medicine, Azizia Medical College Hospital, to present the memento to our chairs.
Heart, the organ that embodies love, compassion, courage, and empathy, the very essence of our humanity. Our next talk delves into heart failure, a condition that echoes the symphony of human existence, reminding us of both the triumphs and tribulations that define our mortal journey. And for the same, let us invite Dr. George Koshi, sir, Senior Consultant Cardiologist, Cosmopolitan Hospital, Trivandrum, former Head of Department of Cardiology, Government Medical College, Trivandrum, to deliver on practical points in the management of chronic heart failure. Let us invite Dr. Anil Robi, sir, Professor and Senior Consultant, Department of Cardiology, Sri Gokulam Medical College, and Dr. Jinaraj Kumar, sir, Consultant Physician, Shankar's Hospital, Kollam.
Good morning. Good morning, sir. We are so fortunate to have Dr. George Koch here as our speaker who will be talking on the heart failure. Dr. George Koch is a former professor, HOD of Cardiology, Government Medical College, now presently working as a senior consultant cardiologist at Cosmopolitan Hospital, Trivandrum. He has been invited as faculty for several national and international conferences, has contributed to various textbooks in medicine and cardiology. His main interest is intervention cardiology. As usual, we expect an academic fees from you, sir.
Let me first of all thank my dear friend Dr. Rajashekharan, my former colleague, and rest of the members of the organizing committee for this kind invitation. I will be speaking on the practical issues in the management of chronic heart failure. We should understand that the most important part of the definition of heart failure is reduction in the cardiac output at rest or at least during exercise. This can happen in two situations. Number one, when the contractility of the heart or the systolic function is reduced. That is what you call as the heart failure with reduced ejection fraction, in which you find the end diastolic volume or the preload is actually more, but the heart is not able to contract properly. The ejection fraction is less. Actually, the ejection fraction is the stroke volume divided by the end diastolic volume. So the ejection fraction is something like 30%. This we all know. This is the heart failure with reduced ejection fraction. But there is another reason for the reduction in the cardiac output. That is reduction in the end diastolic volume. The ventricle is small, the preload is less, but the heart is contracting normally. You find the end diastolic volume something like 60 ml. The stroke volume is just 40 ml. If you calculate the ejection fraction, it is 66%. This is the entity of heart failure with preserved ejection fraction. This, I think, is the most important aspect of heart failure. Because heart failure is basically reduction in the cardiac output, reduction in the stroke volume, which can be because of a reduction in contractility or normal contractility, but the chamber is small or the end diastolic volume is less. This concept we should very clearly understand. And that is the classification. If the ejection fraction is less than 40%, you call it as reduced ejection fraction. More than 50%, preserved ejection fraction. Something between mildly reduced ejection fraction. And you know, this is actually a dynamic thing. A person with reduced ejection fraction can improve to preserved ejection fraction. Similarly, preserved ejection fraction can deteriorate to reduced ejection fraction over a span of time. And the treatment aspect, reduced ejection fraction, we have very strong database. We have good treatment available. There are 5 pathways: the angiotensin 2, norepinephrine, aldosterone, neprilysin, and SGLT2. And we have 4 important drugs: the ACE inhibitor, the ARB or ARNI, the beta blockers, the MRA, and the SGLT2 inhibitors, which we call the 4 pillars. And we have another 4 drugs: the old digoxin, we have the ivabradine, the hydralazine with isosorbide dinitrate combination, and the newer entrant, vericiguat. So remember, we have 5 pathways, 4 pillars, and 4 other treatments available, from which you will have to choose. And these are the primary 4 pillars for the management of heart failure with reduced ejection fraction. The ARNI is preferred over ACE inhibitor or ARB. We have the beta blocker, the MRA, and the SGLT2 inhibitor. Ideally, all our heart failure with reduced ejection fraction patients should be on all the 4 pillars at the earliest. And now we have very strong data telling that ARNI is better than ACE inhibitor. If you look at the total mortality, cardiovascular mortality, sudden cardiac death, or worsening of heart failure. So whenever possible, consider ARNI over ACE inhibitor or ARB. That is the important thing. Now ARNI has become generic, it has become cheaper. Now we should clearly understand that if you use the 4 pillars early in the management of heart failure, that is a combination of ARNI with beta blocker, with MRA, with SGLT2 inhibitor, we can reduce the mortality in heart failure by 64%. Very important point. Just by pharmacological treatment, the mortality in heart failure can be reduced by 64% if you use a judicious early combination of these 4 drugs. So we should treat patients properly right from the beginning. Now, common question: which should be the initial drug in heart failure with reduced ejection fraction? No controversy. Patients should become symptomatically okay. So diuretic should be preferred. Optimum dose. If the patient is congested, we call it as wet heart failure. The preference is for an ARNI, ACE inhibitor, or an ARB. But if a patient has less congestion, dry heart failure with resting tachycardia, preference is for beta blockers. This is what we were following earlier, which you call the conventional sequencing. Initially the ACE inhibitor, then after say 2 weeks or 1 month you put beta blocker, then slowly you give MRA, then slowly you give ARNI, change to ARNI. So the whole thing takes a very, very long time. So the introduction of all the 4 drugs takes more than 6 months, and many times the patient will be dead by that time. So now we have changed to rapid sequencing is the current recommendation. All 4 at the end of 4 weeks. Sequence decided by the clinical context. So you can start with beta blocker plus ARNI, change to ACE inhibitor if required, but we always prefer ARNI right from the beginning. Now beta blocker with SGLT2 inhibitor may emerge as the preferred initial option. You always start with a small dose of all the 4 drugs at the earliest if possible. Up titration can be done later. And always you should have a checklist. When the patient comes to you, make sure that the patient is on all the 4 drugs. If possible, at the time of discharge. If that is not possible, at least when they come for the initial follow-up. And these are the 6 other factors to be considered. Is the patient in sinus rhythm or AF? What is the heart rate? What is the blood pressure? What about the renal function? What about the sodium? What about the potassium? Now the issue is, most of these drugs tend to lower the blood pressure. And this is a hierarchy. Risk of hypotension, maximum with ARNI, followed by ACE inhibitor, followed by ARB, followed by MRA. Beta blockers generally do not lead to hypotension. except perhaps carvedilol. Then SGLT2 inhibitor. Ivabradine does not lead to hypotension. Digoxin, is the only drug which, probably has a favorable effect on the blood pressure. All the others indirectly, by improving the ventricular function, eventually improve the blood pressure, but not during the acute phase. Who should receive an SGLT2 inhibitor ahead of an ARNI? A person with a borderline blood pressure, for example, you are treating a patient, systolic BP 104, you cannot give an ARNI straight away. One comfortable drug will be, say, dapagliflozin or empagliflozin. When the risk of acute renal worsening, creatinine already 1.6, creatinine clearance 32, risk of hyperkalemia, your potassium is 5.1, a drug which can be safely given is an SGLT2 inhibitor. Now, beta blocker with SGLT2 inhibitor is better tolerated than beta blocker with ARNI. So many people feel that it can be considered as a first-line combination therapy. Now, electrolyte disturbances are a big problem when you treat heart failure. Now, there again, you have an advantage for SGLT2 inhibitor because this is one drug which does not lead to any electrolyte issue. Whereas, spironolactone, you have hyperkalemia, other diuretic, you have hyponatremia, hypomagnesemia. The ARNI, you can have hyperkalemia, ACE inhibitor hyperkalemia. So you have one drug which does not produce any electrolyte disturbance, and that is a plus point. Now, regarding diuretic, always keep the dose optimum, not too much, not less. Try to reduce the dose and stop depending on the improvement. Because if you continue to give a lot of diuretic unnecessarily, you won't be able to introduce the other disease course modifying drugs like ARNI or spironolactone or beta blocker and things like that. And excessive diuretics can delay the initiation and uptitration of disease course modifying drugs. It can also worsen the renal failure. The NT-proBNP guided treatment is good, but it is expensive. Now, hyponatremia is very common in people with heart failure and is associated with bad outcome. Sodium below 130, you have to be very careful. Loop diuretics and MRA. Always remember, when you tell about spironolactone, we all remember hyperkalemia, but spironolactone produces hyponatremia. Always remember that. Risk is more with combination therapy. Like, you are combining a loop diuretic with a thiazide diuretic, something like that. Or excessive sodium restriction. And SSRI, you tend to forget that. The drugs like escitalopram or sertraline, very commonly prescribed, also known to produce hyponatremia. And some of these people with heart failure, we have no option other than to give a small dose of tolvaptan. On a regular basis, we do that. Something like 7.5 milligram or 15 milligram twice a week or something like that, so that we can maintain the sodium around 130, 132, though it is not a standard recommendation. Now, hyperkalemia, we have to be careful in people with CKD. A combination of RAS blockade with MRA is the culprit. Usually it is spironolactone, which leads to the hyperkalemia. And something we can do, restricting potassium in the diet, and potassium chelating agents are now available, especially this patiromer. Beltasa is going to be available in India, so you can combine it with spironolactone in such situation. And always remember the reversible factors, like revascularization. You can do an angioplasty, CABG, improve the vascularization, and that will indirectly improve the ventricular function. Then the treatable myocardial diseases, like say, a lot of things are there. I am not going into the details, especially tachycardiomyopathy, then myocarditis, then conditions like sarcoidosis and things like that. Arrhythmias, always remember the entity of tachycardiomyopathy. And we have to address the comorbid condition like CKD, cardiorenal syndrome. Many times they coexist. Anemia and deficiency, very commonly missed. Diabetes, atrial fibrillation, control the ventricular rate. Mitral regurgitation, obstructive sleep apnea, very common. CPAP, infections, concomitant drugs. You should try to avoid NSAIDs, steroids, and all those things. Anemia in heart failure, extremely important. Every heart failure patient should have a serum ferritin examined. If the serum ferritin is below 100, that alone is enough. That candidate should be given iron infusion. If you find the ferritin is more than 100, between 100 to 300, you can check the transferrin saturation. If the transferrin saturation is below 10%, they are again candidates for intravenous iron infusion. Now, these are the beta blockers which are recommended: carvedilol, metoprolol, and bisoprolol. Always start with a small dose, can be up-titrated later. Hike up to the maximum tolerated dose, but the patient should be euvolemic, non on intravenous inotrope. MRA, we know spironolactone and eplerenone. We had to check the potassium and the renal function. The SGLT2 inhibitor, we had the DAPA and EMPA, 10 milligram. You can give till an eGFR of 30 or even 20 with empagliflozin. It can be a first line in those with borderline blood pressure, renal function, and hyperkalemia. So this is the current recommendation which I already mentioned, the 4 pillars. Now people with reduced ejection fraction, a prophylactic ICD could be good because one cause of death is ventricular fibrillation. Now people with left bundle branch block, you can always do a CRT. Now ivabradine is useful only in people with sinus rhythm. If the heart rate is more than 70, despite beta blocker, or if they have a contraindication for beta blocker, tachycardia with hemodynamic instability. Usual dose is 5 milligram twice daily. The combination of isosobate dinitrate with hydralazine, it is useful, especially in people with CKD. Now, digoxin, is it useful in 2024? Yes, it is still useful, but only to use in a small dose. Never exceed half a tablet per day. If possible, measure the serum digoxin concentration. It should be maintained between 0.5 and 0.9 nanogram per ml. If you use it carefully, it is useful. There is some trend towards reduction in mortality, especially in people in NYHA class 3 and 4, ejection fraction below 25%, and people with cardiomegaly. Before I conclude, just a word about heart failure with preserved ejection fraction. For example, a 78-year-old lady, obese, BMI of 32, diabetic for long, hypertension, CKD, paroxysmal AF. You do an echo, you find ejection fraction of 56%. You may think it's not heart failure, but in reality, it is heart failure. You measure the NT-proBNP. It comes as more than 3,000. Normal NT-proBNP in sinus rhythm ideally should be below 125. A value above 220 is considered abnormal. In atrial fibrillation, NT-proBNP above 600 is considered abnormal. And another important point to remember, in obese people, NT-proBNP tend to be lower. So you do require a correction. In obese people, the cutoff level is lower and not higher. And okay, there are various scores, echocardiographic substrates and all that. I am leaving that. Just remember the phenotype of reduced ejection fraction and preserved ejection fraction are different. Preserved ejection fraction mostly younger people, post-MI, dilated heart. They also can have risk factors, but when it comes to preserved ejection fraction, elderly people, females more than males, hypertension, diabetes, left ventricular hypertrophy, atrial fibrillation, COPD, CKD. That is the particular phenotype of people with heart failure and preserved ejection fraction. You are very likely to miss that heart failure. You will not miss heart failure with reduced ejection fraction because echo alone is enough for the diagnosis. Once you see an EF of 30%, okay, that clinches the diagnosis. But the elderly patient who is breathless on walking, you order an echo, you find echo ejection fraction 60%, you may think it is not heart failure. You ask for an NT-proBNP, you will be surprised to find that the NT-proBNP is significantly high. The point is, the only treatment which is beneficial in heart failure and preserved ejection fraction is the SGLT2 inhibitor. So that will be my conclusion. The current guideline, heart failure and reduced ejection fraction, you have the 4 pillars and a lot of other drugs. when it comes to heart failure and preserved ejection fraction, all that you have is a little bit of diuretic and the SGLT2 inhibitor, dapagliflozin and empagliflozin. So the point is you should be able to prevent heart failure with preserved ejection fraction by early addressing the risk factors which lead to that, like good control of hypertension, preventing left ventricular hypertrophy so that they will not develop atrial fibrillation, trying to preserve the renal function, preventing the CKD, addressing the obesity, obstructive sleep apnea, COPD, and all to the extent possible. And finally, it's all a multidisciplinary approach. A heart failure team, heart failure clinics, patient education, training on exercise, diet, lifestyle modification, salt restriction, and all those things, and a lot of psychological support, and prompt referral for acute decompensated heart failure. The role for monitoring devices, support devices, and all those things which I did not mention. And then, the cardiac transplantation, evaluation of the patient for that, and maybe terminally many patients, end-stage heart failure, may require palliative care and hospice. Thank you very much. No, absolutely no role, absolutely no role. People have tried that and it is not good. Whenever possible, use ARNI. If that is not possible, use ACE inhibitor. And if there is cough or any major issue, angioedema or something like that, you use an ARB. If you are using an ARB, to the extent possible, valsartan, because that is the one which has been proven in the heart failure trials. Candesartan is very good, but not available in India. Losartan is inferior to valsartan. But ARNI should be preferred, and be careful when you change from ACE inhibitor to ARNI, you should leave a gap of at least 36 hours because of the risk of angioedema. There is no role for direct renin inhibitor in heart failure. Okay. I think both are very good questions. I will answer the first question first. That is, the diuretic dose should be reduced at the earliest. But if you immediately stop, then the patient will become symptomatic. So basically, it's a good clinical assessment. Looking at the heart rate, then something we ignore, looking at the respiratory rate, because none of us have time to count for 1 minute. We are all very busy people, but it is very, very useful. Then your clinical evaluation, looking at the JVP, volume assessment and all that. You can have a look at the IVC with the echocardiography. You can look at the COMET and all those things. So clinical assessment, you can make the patient walk and find out whether he becomes breathless. So in your clinical assessment, if you think patient is euvolemic with reasonable effort tolerance, you can think of reducing the dose of the diuretic. But if finance is not a major issue, NT-proBNP guided reduction in the dose of diuretic is extremely useful. I do it very often in people who can afford. Suppose you find the NT-proBNP has come down to, say, 70 or 100. You are too comfortable, you can immediately reduce the dose of diuretic. The advantage of reducing the dose of diuretic is you can introduce the disease course modifying drugs and hike up the dose, because diuretic do not reduce mortality in heart failure. And it can worsen, loop diuretic excessive dose can worsen the renal function. So optimizing the dose of diuretic is actually an art. Clinical basically, but NT-proBNP guided could be useful. Now regarding your next question, a patient with heart failure has improved. The ejection fraction has gone above 50%. That is what you call heart failure with improved ejection fraction, HF, IMP, EF. We have 2 trials which have addressed that, and the conclusion is we should continue to give the drugs. We should not stop the drugs, especially the ACE inhibitor or the ARNI, ARB and the beta blocker. Maybe you can stop SGLT2 inhibitor. maybe you can stop the spironolactone, but the RAS blockade and beta blocker should continue. Because there are trials in which they prematurely reduced and discontinued the tablet, and the heart failure has come back. It has happened in cardiomyopathy, dilated cardiomyopathy, and if the patient again goes into heart failure, then treatment may not be as effective. They can go into ventricular remodeling and get into problems.
Any more questions on the? So there are no questions. I thank Professor George Koshi sir for his excellent lecture, and also I thank the Assisia team for giving an opportunity to chair the session. Thank you.
Thank you very much. Thank you. Thank you.
Thank you, sir. May I request our chairpersons to kindly present the memento to Dr. George Koshi, sir. May I request Dr. Ansar Aziz, sir, Director, Azizia Institute of Medical Sciences, and Dr. Ansi George ma'am, Consultant Physician, Government Hospital, Kottarakara, to kindly present the mementos to our chairpersons. It's our privilege to invite Dr. Ansar Aziz, sir, our beloved Director, Azizia Institute of Medical Sciences, to address the gathering. So please.
Late good morning to you. So I couldn't reach at time. I'm very thankful that I could get a pleasant crowd here, and thankful for finding your time to reach here in your busy schedule. So I'm privileged to be here, and this is an opportunity for all our medical students, postgraduates and faculties to get updated about the clinical practice that is good for your safe clinical practice. So you should try to take benefit out of this opportunity. And we have very renowned and eminent orators and faculties here. So we are grateful for that. So thank you for once again for gracing this occasion, sir. Thank you.
Thank you, sir, for gracing us with your presence. Now we move on to session number 6. Familiar faces, names unknown, like seeds of memory, long since sown, yet scattered now upon the wind, lost within depths within. Lines from The Long Goodbye by Linda Ellis. Dementia continues to be a significant global health challenge, particularly as the population ages. Research into understanding its causes, potential treatments, and methods for improving the quality of life for those affected remains ongoing. Our next topic is on the topic Pitfalls in the Diagnosis of Dementia by Dr. Robert Matthew, Head of the Department, Neuromedicine Department, Azizia Medical College Hospital. And to chair this session, let me invite Dr. Prabhash, Head of the Department, Department of Psychiatry, Azizia Medical College Hospital, and Dr. Ajay Kumar Ayyappan Unnithan, Head of the Department, Department of Neurosurgery, Azizia Medical College Hospital.
Good morning, everybody. We are blessed for the talk of about the current novel topic of dementia with Dr. Robert Matthews, who has passed his DM Neurology from Toronto Medical College and he has worked in Sri Chitra Medical College. He was professor and HOD of Department of Neurology in various medical colleges in Kerala, and now he is at present he is here. He had a fellowship in dementia, neurosciences research in Sydney, Australia. He had so many articles being published by him, even in DC textbook. 2 Malayalam books are available under his name. So really, we are blessed in hearing the topic of pitfalls of dementia. So many pitfalls are there in diagnosing dementia, especially the emergency physician department. They have to be more careful in initiating the diagnosis of dementia. I think they have to refer the patients to the concerned departments. Okay, over to Dr. Robert, please.
Good morning to all, respected director and very senior teachers of mine, especially Koshi sir and other senior colleagues, my students and friends. I have been listening to 3 information-packed sessions, so I was hoping I could do this in a lighter sense. I just have six cases and we'll have some discussion. I don't know whether the chair will permit me to get some feedback from the crowd. Can I ask some questions and get some answers? It's up to you. If you answer, then it'll be interesting. So, sir had asked me to present on pitfalls in the diagnosis of dementia. So, pitfall occurs when you start diagnosing in plenty. So, you start diagnosing a lot of diabetic cases, in between you may miss one. So, that's your pitfall. But in dementia, picture is totally different. You don't diagnose dementias. Somebody tell me the statistics. What percentage of dementia in India is being labeled as dementia? Just a figure. One wild guess. Perfect. It's exactly 10%. Oh my God. Pulmonologist wins. So it's 10%. So maybe there are 2 lakhs in Kerala, around 60 lakhs in India. Grossly underdiagnosed. So these cases will be focusing on diagnosis of dementia basically. So elderly couple staying alone, this is a common picture in Kerala. Son abroad, he doubts that mother is having dementia. Father denies any memory loss. The husband, he says my wife is perfect, absolutely no problem. She doesn't have any memory loss. Little bit of memory loss she has, but that's part of her age. No issues. And so next question, you're trying to make him say that she has a problem. Does she make mistakes in handling money? No. Absolutely no mistakes. Perfect in handling money. Does she misplaces objects? This is one of the common symptoms of dementia. So they keep objects in some other places, unexpected places, and then they keep on searching for it. So misplacing that's included in the diagnostic criteria also. So you are directly asking, does she misplace? No, absolutely nothing. So the picture painted by the husband is rosy and the son is worried. Now the next question, you come to a next way of cornering the husband. What are her daily activities? What does she do from morning to evening? She doesn't do anything. So she doesn't make mistakes in handling money because she doesn't handle money. She doesn't misplace objects because she doesn't place anything anywhere. So it's absolutely inactivity from morning to evening and everything is taken care of by the husband. So this gives you a clue that something is wrong. So why is it that she is not doing anything for the last couple of years? So that is where you start thinking of dementia. And then when you ask more and more, the husband will come out with more details. Like there were times 5 years back when she tried to cook something in the kitchen and she failed. Slowly she started withdrawing. She knew that she can't do it. Similarly, she had made mistakes in calculation. So slowly she withdrew. So the disease dates back to 5 years. And now she is in a state of inactivity. So this is one of the important concepts in diagnosing dementia. Activities of daily living. You have to ask specifically about the daily activities. For regular question on memory, the answer will be there is no issue. But when you start asking, then you know that they are not active, and you ask the reason for not being active, then they come out with real cognitive. And this is very, very important in the diagnosis of dementia. You make a diagnosis of dementia only when the activities of daily living comes down, consequent to cognitive impairment. So there are different scales for sort of measuring the activity. So I am just put an example, like phone ഉപയോഗിക്കാനുള്ള കഴിവ്. So when compared to what the patient was doing 10 years back, is the patient able to use the phone well now? And there are choices. So such sort of questionnaires are there, which tells you, which gives you a score, and then you can come to a conclusion whether the ADL is preserved or not, and you come to diagnosis. So whenever you inquire about dementia, inquire about activities of daily living. Okay. Just next case. 82-year-old engineer. He repeats the same questions. He misplaces objects. He is actively involved in construction work. At the moment when he came to me, he is the president of a body which is involved in constructing an auditorium, and the project is 3 crores. So he is still active. He denies having memory problem. It's the wife who says that he is having memory problem. And the MMSE score was 24 out of 30. Now, MMSE is mini mental status examination. It's a short questionnaire. You can complete it in 5 minutes, and it gives a score. The total score is 30, and if it is less than 24 for an educated person, then it is suspicious that the patient is having dementia. So the score was 24 here. His MRI scan of the brain was normal. So he is functional now. So anybody wants to give a diagnosis? Okay, we'll come back to that. So we did a neuropsychological assessment. He was having memory impairment. He was having language impairment. He was struggling to get the right words. But his activities of daily living, as per the scoring sheet, was preserved. So this is a situation where there is florid cognitive impairment, but the activities are preserved. So this is an sort of an interface between normalcy and dementia. Can somebody name this stage? So this is called mild cognitive impairment, abbreviated as MCI in cognitive circles. So he is having MCI. So the importance of MCI is approximately 30% of MCIs progress on to dementia in next few years. 30% remain the same and 30% improve. So here again, even though there are florid cognitive abnormalities, since the patient has enough reserves, he continues to function, and so he doesn't really qualify for dementia. Coming quickly to the diagnosis of dementia. Initially we had a pathological dementia. Initial cases were all diagnosed based on autopsy. And now we have the clinical diagnosis. And we are going into the biological diagnosis. We don't have the investigation of choice for dementia. We don't have the biological marker for dementia. We have diagnostic criteria and some biological markers. So just to show, these are some of the ones. The PIP scan helps you to directly visualize the amyloid load. As the amyloid load increases, patient develops more and more symptoms. So that is there. And FDG shows the areas where the brain is involved. Like in Alzheimer's dementia, it's a parietal and temporal region that's involved. So we have imaging modalities which are not at diagnostic ones. And the regular ones, CT scans, MRI, they are not of much use. I'll just skip the next slide. Okay, so quickly I'll go through the criteria for diagnosing dementia. This is the American Association of Neurologists diagnosis, widely accepted. This was modified in 2011 and it's still in vogue. So there are 5. There should be, first one is the ADL. There should be interference with activities of daily living, and there should be a decline from previous level, and there should be at least 2 cognitive domains impaired, of which usually one will be memory. So along with memory, there should be one other cognitive domain that is impaired, and that you will have to find out either through your clinical examination or through neuropsychological assessment. So it's like this. This is how they have mentioned the history taking from the patient and a knowledgeable informant. Very, very important. You have to take a detailed history and objective assessment of cognition. You can assess directly the cognition. Either you can do it as a doctor or you can get the support of a neuropsychologist. When the dementia is quite advanced, you can diagnose. It's easy. But in borderline situations, you may need the support of neuropsychologist. So these are the cognitive domains: memory, language, visuospatial function, executive function, and personality change. So 2 of this should be involved. Then only you can make a diagnosis of dementia. So I'll just keep all these. These are the finer details of these cognitive domains. Just remember that there are a couple of cognitive domains and you have to diagnose them either clinically or through neuropsychological assessment. So, we come to neuropsychological assessment. In situations where you are not able to really say there is a problem, then you can call the neuropsychologist. One simple example I'll say. The first one, you can see the cube. No, this is called a wire cube. So you are asking the patient to draw this cube. So these are the responses you are getting. So which is the right one and which is the wrong one? Or where do you draw a line? That's a very simple task. So this is to measure the visuospatial function. So whom do you take as normal and whom do you take as abnormal? So even though it's a very simple one, it's a big task. First you will have to devise a scoring system for the cube. Like let us say, for the number of parallel sides, we'll give a score. Faces, another score. Corners, another score. We have to make a score and justify it. And then you apply it in, say, 1,000 normals and say 300, 400 dementia patients. So how do you know that these thousands are normals? So you'll have to examine and make sure that they are normal. And how do you say that these are demented patients? Again, the same thing. And then you have to apply this, and then you have to get the cutoff scores. So, so you are having the cutoff scores here. We'll take this one. Here the MMSE score is 28, and the corner score is 25. So this patient is unlikely to have dementia because if you go by the MMSE, the cutoff is 24. So you give cutoff scores for each one and decide. Now this is an example. It's even a simple neuropsychological task needs a huge amount of effort to really bring it into use. So these are all done in the Western countries. Now adapting them to the Indian scenario is an equally big task. You cannot just translate it and use it. You need a lot of modification. You have to try out in your, let us say, see, there are some words here. These are words given to test repetition. Now, you cannot just use the equivalent Malayalam word. You won't get the result. So it depends upon the frequency of the word and the articulation difficulty of the word and all. So you'll have to bring in words which are similar or of the same utility. So this is called adaptation. So making a test battery is very, very difficult. Adapting it is still more difficult, and then you go for validation. I won't go into those details. Just one more. Now here, this is a picture naming task from the Western world. There's a penguin here, and this is our picture naming task. Now we had to remove this penguin because this was not at all common in our population. So we'll have to substantially change things. So this is something about complexity of neuropsychology. So this is what we have done in adapting these things to Malayalam. Third case, 65-year-old patient with memory lapses, leading a retired life, complaints of recent memory impairment, no other focal deficits. So MRI scan of the brain shows diffuse atrophy appropriate for the age. So patient comes to you with the MRI. So what's your response? So patient is asking, do I have dementia or not? Okay, so these are the general responses. It's easy, no? Take out the MRI, have a look at the picture. Then take out the report, read it out. And then you can say, so some people will say it's normal. The MRI is normal. And some will say it's showing atrophy, shrunken. What does it mean to the patient? So the question is whether there is dementia or not. And the answer is you can't say anything with the MRI. So this is a situation where MRI doesn't help. But if you have diagnosed dementia, if you want to rule out a chronic subdural, then this will help. If you want to diagnose vascular dementia, this may help. For a regular scenario, to say whether there is dementia or not, MRI may not really help. So it has a very limited role, and MRI cannot diagnose in the early stage, that's for sure. Just we'll skip these things. Another case, 64-year-old, there is a fall, hip fracture 1 week back. Following the fall, there is memory loss. On examination, patient is disoriented. And there is generalized paratonic rigidity. So memory cannot be assessed properly. Patient is disoriented. So patient is in delirium. Okay. And there is no history of memory loss. However, there is a history that the patient is less interested in household activities for the last couple of years. Makes some mistakes in taking decisions. Important things when they decide they are making mistakes. And the interpersonal warmth has sort of reduced. Family members feel that involvement in family matters or emotionally involvement is not as good as before. Any clues? What's the diagnosis? Okay, so little more. Episodes of swallowing difficulty and choking. Walk slowly, some imbalance. And a few episodes of falls also. Any clues? Yeah, somebody said Parkinsonism. That's a very good diagnosis. Basically, this is what is called a subcortical dementia. This is another concept. So dementia doesn't always mean memory loss. There are situations where there will be subtle personality change. And they still qualify for dementia. And the common vascular dementia which we talk of, many of them fall into this category. And it's a very tricky situation because memory loss is not in the forefront. You are very likely to miss this. So she is not very active because she is old. She is tired. She is walking like that because she has arthritis. So excuses are there. So initially in the diagnostic criteria, these were not included. This is called executive dysfunction. These abnormalities which I mentioned doesn't really amount to memory loss. So this is another situation where you make mistake and you miss it. Now, so how to diagnose dementia in this patient? So patient is in delirium. You can't examine the patient. So there are sort of questionnaires which can diagnose dementia from history. So you can diagnose dementia over the telephone. So these are all validated ones. So you can use some of them in this scenario. So this is a commonly used one, IQ code. So we had validated it in Malayalam. Fifth case, this is a patient with a corticobasal syndrome, basically Parkinsonism plus syndrome. There was a rapid worsening over 2 years and patient became bedridden. So memory loss with Parkinsonism, bedridden in 2 years. So they qualify for what is called the rapidly progressive dementia. So rapidly progressive dementia is different from the regular dementia. The cutoff is 3 years or 2 years. If they become significantly impaired in less than say 3 years, then there's a high chance that there is a treatable cause. Like let us say this is a chronic subdural hematoma. They present as rapidly progressive dementia. So this is another one which we are likely to miss a treatable cause. If you think that the time profile is little fast, then you should be more aggressive in investigating those patients for treatable causes. So this patient actually had a Hashimoto's encephalopathy, and the patient was treated with steroids and she made a very good recovery. So fast worsening, rapidly worsening dementia, always be careful. You may be missing something that is treatable. 70-year-old male, bilateral knee pain on and off for the last 4 years, walking difficulty 4 years, and occasional precipitancy of urine. Withdrawn decreased word output, subtle Parkinsonian features, severe postural instability, and has a magnetic gait. So this patient already has osteoarthritis of the knee for the last 4 years. So all the walking difficulty was easily attributed to the osteoarthritis, and the neurological part was totally missed. But what you have to remember is, if the knee has a reasonable mobility, if the joint is not too much tender, then the walking difficulty cannot be explained by the joint involvement. Some people, to complicate things, may have some amount of pedal edema also, and they will think the walking difficulty is due to the pedal edema. No. If there is a significant walking difficulty, most likely it's what is called a gait apraxia. It's a higher level walking difficulty, it's a neurological one, and this patient is having what is called a normal pressure hydrocephalus. So this may not be, even though it's rated as a treatable cause of dementia, may not be always treatable, but it's a neurological cause. So there are some treatment options which you can offer. So I've just touched upon some important, some common situations where you are likely to make mistake in diagnosis of dementia. This is again another interesting case, Geschwin syndrome. This is a situation where the patient becomes hyper-religious. So suddenly she became too much involved in religious activities, spending all the money on anybody who comes with a religious color, praying, sitting glued to certain channels in the TV and all. This went on for years before we could really make a diagnosis. Into the bargain, she was not taking care of anything at home. So everything was at disarray at home, and her bank balance was easily zero, looted by religious people. So such things also happen once in a while. I think that's the last slide. Thank you very much once again for giving me this very wonderful opportunity, and thank you to the crowd for giving some responses.
Thank you. Thank you, sir, for the wonderful talk. I have two questions regarding the underdiagnosis of dementia in India. What was your experience in Australia? Second thing, whether fMRI can be useful in diagnosis of dementia.
The second one, fMRI can be of use because it picks up activities in different parts of the brain, but it is not listed under the useful investigation so far. Australia, it is a place where I went was purely a research one. So 1 or 2 patients are examined in a day. So they are just examined neuropsychologically from top to bottom like that.
Okay, sir. Sir, how will you differentiate between malingering and dementia? I mean,
to make a diagnosis of dementia, you need at least 3 months duration, and the patient should not have psychosis or delirium. So probably if the patient is malingering, we get the help of you, and then we make a diagnosis.
Yes, sir. Sir, regarding NPH, what is the outcome after LP and shunt? What is your experience?
This is sir was asked, there is a neurosurgeon, I am a neurologist. He's purposefully pulling me down into that area where we are always having fight. And any patient with NPH, surgeon is there to do a shunt, and we are there to say, don't do like that. So normal pressure hydrocephalus is a situation where there is excessive CSF collection in the brain, and approximately 50% of the patients do respond to shunt surgery, and 50% may not respond. I think that's a fair answer. Sir.
We have started using ARNI very extensively. ARNI, the combination of sacubitril with valsartan in heart failure.
Okay, sir.
This neprilysin inhibition is supposed to increase the brain amyloid. And there was some concern that ARNI use can increase dementia. And there was some discussion along those lines. Do you have any?
No, sir. Okay. I'm sorry. Before answering that question, I should say something about George Kochi, sir. During our MD days, we always cherished classes by sir. But what I want to say is, it was not like that. The sir was kept as the gold standard in presentation. Oh, avante presentation, Kochi sir and attara clarity at one. So the way he presents is very clear. Now coming to the, sir, thank you very much for setting an example. Now coming to the question, I'm very sorry, I'm not at all aware of that. I'll try to find out, sir.
Sir, one question more. There are so many drugs to retard the dementia. as they claim. What is the evidence?
There are two main groups, cholinesterase inhibitors and the new SUMABs. So cholinesterase inhibitors were licensed 20 years back. They give little bit of namesake improvement. They may slow down the process for a few years. But they are cheap, 10 rupees to 20 rupees per tablet, can be given continuously. The new one has come, the SUMABs. SUMAB is poking the nose into all specialties. So it is poking into dementia also. Just $50,000 per year and namesake benefit. Luckily, it hasn't come to India. So, offering a treatment which doesn't have much benefit, but which is available, which is going to make you a persistent the bank is going to threaten you like that. So that sort of a treatment, SUMAB is coming. It's expected to touch our India by 2025. ISA is going to bring it. So it is now in vogue in US, and when the FDA approved, 3 people resigned, saying that it is not cost effective and all. Very, very controversial one, but it is catching up there, and it will come here in next 1 or 2 years.
Any more questions? So, thank you very much, sir. And I really congratulate the organizing committee chairman and the team for selecting this novel topic. And I congratulate you, sir, because it's a very broad chapter. You had almost completed the chapter within few minutes. Thank you once again.
I'd now like to request our esteemed chairpersons to award Dr. Robert Matthew with a token of appreciation. Next, I invite Dr. Shashidharan C., Senior Consultant Physician, Department of General Medicine, Azizia Medical College, and Dr. Bibin Abdul Qadir Kunya, Assistant Professor, Department of General Medicine, Azizia Medical College, to award our chairpersons with a memento. A gentle reminder to all of our esteemed guests to kindly fill up the feedback form at the end of each session. Thank you.
In the theatre of human health, where every heartbeat is a testament to life's fragile grace, the stage often belongs to the respiratory system, a silent maestro orchestrating the rhythm of existence. Within the delicate dance of breath lies a narrative of resilience and vulnerability, where the slightest interruption can herald a freely and fully. Our next talk is on the topic Practical Approach to the Management of Respiratory Emergencies by Dr. Jayaprakash Sir, Professor and Head of Department, Department of Pulmonary Medicine, Government Medical College, Alapi. Let us invite Dr. K. Srikandan Sir, former Head of Department, Department of General Medicine.
Morning. The next speech is on respiratory management of respiratory emergencies by Dr. Jayaprakash B, HOD, Department of Pulmonary Medicine, Government Medical College, Trivandrum. I think pulmonary emergencies are mainly first seen by the physicians, and it is a early diagnosis and management is very important to prevent mortality due to pulmonary emergencies. The common emergencies are pulmonary embolism, pneumothorax, the respiratory failure requiring ventilator therapy, and recently, till 2 years back, we had a COVID infection and many respiratory complications were there. I think Dr. Jayaprakash will go into emergency problems in the respiratory medicine and enlighten the audience. Thank you all.
Respected chairpersons, senior faculty members and dear delegates, a warm good morning. At the outset, I thank the organizing committee of this conference, especially Professor Rajasekharan sir, because the day one I started my house residency with sir, and I learned from him the art of actually caring the patients. And I know it's very difficult to batch after people who regularly score centuries. And a request from me is, don't compare my speech or talk with the gold standard talk which is sitting in front of me. Is also my teacher, Coach sir. And Rashir sir asked me to just touch on the respiratory emergencies, and I plan my talk like approach to a patient with breathlessness, hemoptysis and pneumothorax. There are a lot of other emergencies like respiratory arrest, a foreign body in the respiratory system. As the chairperson rightly pointed out, pulmonary embolism, chest trauma, even cardiac failure which present as a breathlessness in their casualty, drug-induced emergencies, etc., etc. But don't forget, a non-asthmatic patient can also present with the conditions like pneumothorax, foreign body, pulmonary edema, etc. The patient need not be in his basic exacerbation condition. Now, if a patient presents in the casualty with acute onset of breathlessness, these are the conditions you have to remember. As I mentioned, the commonest one is an acute severe asthma. It could be an exacerbation of COPD, a pneumothorax, foreign body, ARDS, pulmonary embolism, pulmonary edema, etc. That already we discussed. And what is this? Any takers in the audience? What is the relevance to my topic here? In one look, it looked like a bunch of coffee beads, But if you look carefully, you can see one person is hiding here. Can you see a face there? So like that, when patients present with acute breathlessness, a meticulous clinical examination or one or two points there like an absence of air entry in one side of the chest, or a stridor may clinch the diagnosis other than simple exacerbation of asthma or COPD. Now, can you see that? Yes. Now, when there is a patient with respiratory emergency comes in the casualty, there are 3-4 points which are there. One is A, B, C and D. Number one is the airway management, which is also very, very, very important. You know, our dead space is only 150 to 200 ml. So anything which is blocking, maybe a foreign body, maybe a blood clot, can produce the patient. Even a severe spasm can produce the patient in airway compromise. That will be manifesting as a stridor rather than rhonchi. Number two, you have to look into the breathing pattern, which can be easily accessed by the saturation. Any patient with a breathing difficulty, the saturation will fall. Then you just concentrate on the circulatory dynamics, and finally the disease-specific treatment. So this ABCD is the key in the management of acute respiratory emergencies. Now, the commonest condition which we see in the casualty is acute severe asthma, and which is defined as a sudden onset of breathlessness in an asthmatic patient, which is refractory to the usual modalities of treatment. What is the usual modality of treatment? We usually give a steroid or a nebulization 1 or 2, the patient will settle. But any patient who is not responding to the usual modalities of treatment, like one nebulization or a single dose of bronchodilator, the patient is not responding, you have to classify it as acute severe asthma. And the clinical criteria to make the patient as acute, the other way around is actually a simple exacerbation of asthma. To classify it into acute severe asthma, the criteria is the patient respiratory rate has to be more than 30 per minute, the pulse rate will be more than 110 per minute, the patient is not able to lie down, he used to sit up because of orthopnea, or he will not be able to complete a sentence. There can be a pulsus paradoxus, or if at all you are looking into the peak expiratory flow rate, it will be less than 30%, and the chest will show bilateral rhonchi. Sometimes you get a silent chest also. There are few signs which are life-threatening in case of asthma exacerbation. Number one is presence of cyanosis. If you are getting rhonchi, it's not actually the severe form of asthma, but in patients with a severe bronchospasm, the chest will be silent. So a silent chest always is a dangerous sign for asthma. Or patients with a bradycardia or a hypotension, a patient in coma or saturation below 90%, these are actually life-threatening signs of asthma exacerbation. Now coming to the management, any patient who is in the casualty with acute exacerbation asthma, the number one thing you have to look is the saturation. If the patient is falling below saturation, below 90, you have to start an oxygen therapy. And number two is patient has to be given a nebulization with the short-acting, which we all do that, putting an oxygen and a nebulization with the short-acting beta agonist. You ask the staff nurse to start an IV line. And one thing which I want to stress is a point called continuous nebulization. Now, what is continuous nebulization? Now, what we are doing is we nebulize with 1 or 2 ml of salbutamol and we stop it. After 20 to 30 minutes later, we again nebulize the patient. Now there is a new concept called continuous nebulization. What we do or what you are supposed to do is you nebulize the patients continuously for 20 to 30 minutes. As soon as the nebulizing solution, which is salbutamol or rivosalbutamol, is over in the nebulizing chamber, you again add 1 to 2 ml and continuously nebulize the patient for 20 to 30 minutes. That's called continuous nebulization. When you nebulize continuously, what will happen? The receptors which are in the respiratory system or in the bronchi will continuously subject it for bronchodilation and the patient will improve. And when the patient improves, the saturation improves, the rhonchi disappears, you can reduce the nebulization to 4th hourly, 6th hourly and later into 8th hourly or something like that. If levosalbutamol is there, that is a that's a vector. Something has happened in the screen. My picture is coming. If there is levosalbutamol is available, that is the better one because you can give little higher dose, double dose of salbutamol. And if the patient is not improving, you can add ipratropium for nebulization in the same chamber along with salbutamol. And don't panic even if a nebulizer is not available. The patient using already an inhaler or an inhaler with a spacer is almost equally good as nebulization. But for a patient with acute severe asthma, this modality will be a little difficult. So the only point I want to convey is you can nebulize the patient continuously rather than intermittent nebulization. And the next step, if the patient is still breathless, you can give a dose of steroid. The preferred one is a methylprednisolone, which is quick in acting. The dose recommended is 125 milligram as a single dose, initial dose, followed by 60 to 125 milligram, 6th hourly or 8th hourly, depending upon the condition. And if methylprednisolone is not available, you can give hydrocortisone 100 to 200 milligram as a single dose. Then you can repeat every 4th hourly as the condition warrants. And if both are not available, even a oral prednisolone of 40 to 60 milligram is equally good as there is a belief that injection steroid is always required. No, only the time of starting is different. An oral prednisolone of 40 to 60 milligram is equally good as injection steroids. Always try to avoid betamethasone or dexamethasone, which is not good for managing acute conditions of acute severe asthma management. Suppose the patient is still wheezing in the casualty. After your nebulization, after your oxygen, after your steroids, the next drug which is very safe is magnesium sulfate, which is very available, freely available, not very costly. 2 to 4 grams of magnesium sulfate diluted in normal saline 100 milligram can be given as an infusion. It's not a very strong bronchodilator, but in reserved cases, if the patient is refractory to our nebulization and steroid, this will work in a very meticulous manner. And the next step, the patient is still in wheezing, you can use aminophylline. The recommended dose is 5 milligram per kg as a bolus dose. Usually we give 250 milligram. Then you can continue as an infusion. The dose is easy to remember. 5 milligram as a bolus and 0.3 milligram per kg as infusion dose. Still the patient is wheezing. Instead of oxygen, you can mix helium and oxygen mixer and you can give. The difference is oxygen is flowing as a turbulent flow. When you make with helium, the flow will become more linear. So the patient hypoxia will be improved and then the patient saturation will be improved. And these are actually reserved drug which we hardly use, terbutaline, or previously we were using adrenaline, and which has cardiac problems and very refractory conditions only you can use terbutaline. After all this, if the patient is not improving, the only option is to take the patient into the emergency ICU and give NIV or mechanical ventilation. But the role of NIV, non-invasive ventilation, is not very good for asthma management. Probably if the patient is still in bronchospasm, you have to intubate the patient and manage accordingly. The common mistake which happens in the casualty, in my experience, for managing acute severe asthma is when you ask the patient to nebulize, the sisters will remove the oxygen from the nose and put the nebulizer mask. Never do this, and you have to simultaneously give oxygen and nebulization assay. So if you ask me, the treatment of choice for acute severe asthma is oxygen-enriched nebulization is the modality of treatment of choice for acute severe asthma. The drug of choice for management of acute severe asthma is short-acting beta-agonist or salbutamol. And less frequent nebulization, which can be managed, which can be overruled with the continuous nebulization, which is the art of managing acute severe asthma now. And people are fearing giving dose of steroids. After giving 100 milligram of steroid, they are afraid of giving one more dose or 2 more doses of. So the fear of giving little higher dose of steroids in patients with acute severe asthma is also a pitfall in the management of acute severe asthma. Finally, aminophylline can also be given for managing asthma. It's a good bronchodilator. But only thing is, patients with aminophylline, if they are already on theophylline, high dose of foreign theophylline, there can be a safety problem because the side effect profile of aminophylline is bit short. So if possible, you can do an aminophylline or a theophylline assay blood, then you can give aminophylline dose. Otherwise, if the BP is okay, you can give aminophylline also for patients. The next common condition is an acute exacerbation of COPD, which is defined as an increase in the breathlessness of COPD patients, which mandate a change in treatment. The patient with COPD is already on a bronchodilator. If they are presenting with increased breathlessness, and the doctor decide that the patient requires some change in the treatment, you can call it an acute exacerbation of COPD, which can be classified into mild, moderate or severe. Mild means you just add a bronchodilator. Moderate means you have to give nebulization, steroids and antibiotics, probably you have to admit the patient. And severe COPD exacerbation means the patient has to be managed in the high dependent unit or in the ICU. So the treatment of exacerbation of COPD is almost same as asthma management, but like asthma we manage with nebulization with short-acting beta agonist or protropium. You give oxygen for saturation, but most of the COPD patients, the saturation between 90 and 92 is enough. Never try to achieve more than 92 in patients with COPD of hypoxia. When there is hypoxia, it has to be between 90 and 92. A high saturation is not required for COPD exacerbation. You can give theophylline like aminophylline in selected cases. Steroid can be given. Antibiotics may be required in COPD exacerbation. But in one thing I want to highlight, in asthma exacerbation, the thing I was highlighting is continuous nebulization and little dose of steroids. But in COPD, as you know, the bronchospasm in COPD is already refractory. The difference between asthma and COPD is the bronchospasm in asthma is reversible. It will quickly revert to bronchodilator and steroid because the bronchospasm is easily reversing back and the inflammation is eosinophilic. So steroid will work, bronchodilator also will work. COPD is a disease where the bronchospasm is fixed. So what will happen? Even if you give bronchodilator, even if you give steroids, it may not revert much. So what will happen? The patient will be continuously breathless. His workup breathing will be high, and the patient will go for respiratory acidosis. So what we can do is, there is a tool called non-invasive ventilation, which is available in most of the hospital, in most of the emergency room. You just give non-invasive ventilation for a COPD patient if he is not responding to the usual modality like a bronchodilator or steroid. You put the patient on NIV. The non-invasive ventilation will reduce the work of breathing and it will improve the oxygenation and the respiratory acidosis will be corrected. So the patient with acute exacerbation of COPD want bronchodilator plus rest to the respiratory muscles, which can be easily given by non-invasive ventilation. Finally, if the patient is not improving, the next option is to take the patient for mechanical ventilation. But always remember, COPD patient going for mechanical ventilation like intubation, the weaning from the ventilator is too difficult. So always try non-invasive ventilation to the maximum before deciding the patient on mechanical ventilation. This slide also depicts the importance of non-invasive ventilation. If you put the patient on this machine is a small machine, you need not require an ICU or a semi-ICU for managing. Even the ward or even the casualty, you can put the patient on a non-invasive machine which will give rest to the respiratory muscles and the hypoxia will be improved. Now, the third, I think I will just rush through this condition. Pneumothorax is, as you know, the presence of air in the pleural cavity, which can be classified into traumatic and spontaneous. And usually in the casualty, we see secondary spontaneous pneumothorax. The common causes are COPD, tuberculosis, pneumonia, malignancy. And there is a condition called the primary spontaneous, usually occurs in young children without any obvious lung disease. They usually present with sudden onset of breathlessness and unilateral chest pain. Whether you decide to put a tube or not depends upon these conditions. The following pneumothorax, like a tension pneumothorax, a spontaneous pneumothorax with a symptomatic patient, breathless patient, or a bilateral pneumothorax, or a recurrent pneumothorax, or hydro or pneumothorax are the indications. But always remember, a tension pneumothorax is the absolute indication for putting a chest tube. So these are the indication for chest tube. Number one is a large pneumothorax or a tension pneumothorax where the mediastinum is shifted to the opposite side. Bilateral pneumothorax, a large pneumothorax, a hydro or pneumothorax. These conditions, don't hesitate. The treatment of choice is put a chest tube. And if the patient, the chest tube is not available in the casualty, what you can do is you can just do a needle aspiration either in the second intercostal space or in another spaces also. It is Now you can just take a 20 cc needle, a syringe and needle, put it in the pneumothorax area, and you can use your IV set to put the other end into the a water filled with the water. So that's the emergency treatment. But when facilities or consultant is available, the ideal treatment of pneumothorax is ICD insertion. But still, some patients will be breathless even after putting an ICD, maybe because of the bronchopleural fistula or malpositioned tube, which can happen in some cases where the breathlessness will still persist even after putting a tube. So you have to plan accordingly for the management. Hemoptysis again will a casualty. It is called as massive when it is more than 200 ml. And these are the common causes. Again, coming back to the management of hemoptysis, the most important thing in patients with hemoptysis is the airway management. Don't panic with the amount of blood which is the patient is spitting out. Just 150 ml is enough to kill the patient. The commonest cause of mortality in hemoptysis is airway compromise, clotting blood in the upper airway. So when there is a patient in the casualty with hemoptysis, the first thing you have to do is clear the airway either by a suction or somehow make the airway patent. Then only you go for the breathing control, put oxygen, and ask the staff nurse to look into the circulatory dynamics, and finally the definitive treatment or the drug switch. But remember, the drugs which are available usually for managing hemoptysis, like ethamsilate or other drugs which are available, are not very useful in managing hemoptysis. So what you have to do is make the patient's airway patent, make the breathing control with oxygen, and you can try the drugs which are available. And there is an emergency management which is called bronchial artery embolization, which is available in Trivandrum Medical College, Sritra, and most of the higher center bronchial artery embolization is done by radiologists. What they do is, they will just, suppose there is a lesion which is post-tubercular here, this is the bronchial artery embolization, this is the tortuous vessels, and they just block, like the cardiologist opening the blocked coronary artery, the other way around. We block the bronchial artery which is bleeding profusely so that life can be saved. So with that, I think the time is over. I will wind up my talk. Thank you for the patient hearing. Thank you.
Thanks, Dr. Jayaprakash. He has covered most of because of lack of time, he could not cover the whole subjects. Regarding severe hemoptysis, it is a embolization therapy, because we had one girl, about a 25-year-old, severe uncontrolled, maybe underlying cavitary tuberculosis, and patient was sent to Trivandrum. The embolization, bronchial artery embolization was done, and patient improved. And he was sent back within 2 days. I think he was sent to the SUT hospital, Pattam. Another problem is sometimes I experienced one patient in 1980. One boy around 16 years was attending the medical casualty 2 times in the night, and he was treated as acute severe asthma, giving steroid and derphelin and sent home. Then one night he was admitted in our medical ward, M1 unit. Because we are trying that, because he attended the previous another OPD, we are trying to shift the patient to the parent unit. At that time, Dr. K.B. Krishnadas came. He thought that it is not asthma. He said more like a stridor. Then one X-ray chest was there. He took the X-ray and he saw the tracheal shadow. And for this, some opacity is there in the trachea. I said something is there. Then the patient was referred to thoracic surgeon. He did a tracheoscopy and found that it was a tracheal adenoma. And it was resected, and the boy improved. And this case was presented in the clinical club of Trivandrum Medical College. I personally presented their case. Okay, thank you all. Any questions from the audience?
No, not really questions. One or two comments. One is, we do not, I'm in pediatrics. We do not give oxygen-enriched nebulization. We actually give oxygen-driven nebulization. So we do not use the nebulizer. We use the oxygen stores as the pump for nebulization. And the Second thing is a very sad thing that I should say. Traumatic pneumothorax. People are not really very much aware. We lost our Vandana only because the treating doctor never thought of that. So in any traumatic dyspnea, even if you have slightest of any doubt, put in an IV set and somehow relieve it. Because the savable people should not die. So that still is a very sad thing, because basically so many doctors saw Vandana, nobody really thought of it. It's a very sad thing to really think of that situation. Now coming to the other things, aminophylline personally I think is not a bad drug, although people now are not really using it.
Which one, sir? Which one?
Aminophylline.
Aminophylline.
People are now sort of afraid to use it. Maybe because of litigation rather than because when the child is not responding to many other things, ultimately we give it and they respond also. And lastly, your comment on various theophylline like aminophylline, doxophylline, abphylline. So please, your comment on that, please. And also one more thing, in COPD, the combination of NAC, N-acetylcysteine along with these abphylline.
So I'll go in the reverse order. N-acetylcysteine has no definite role in the management of acute exacerbation of COPD. But patients with the COPD, when there is sputum is a problem, NAC is a good mucolytic and maybe having a little bronchodilator. The second question was on aminophylline. Various theophylline. Now, the two theophylline which we use commonly is, one is aminophylline, other one is doxycycline. Sorry, doxophylline. Doxophylline is very cardiac safe. Aminophylline, the only problem is the side effect to the therapeutic window is very small. If the to get to the therapeutic effect, you require 10 milligram per this body level, blood level. The other one is only 20. The patients who are coming to the casualty already has taken 2, 3, 4 tablets of Durafil or something, or have taken 2 injections of Durafil from the periphery. So it is recommended that without looking into the therapeutic level of theophylline, you are not supposed to give a aminophylline group or Sandhian group of drugs. So the guidelines, if you look into the guidelines of acute severe asthma management or COPD management, theophylline will not be there as a drug because the safety margin is very less. And the third question regarding the pneumothorax, by literature, by textbook, the commonest cause of pneumothorax is trauma, not COPD. But as a pulmonologist, 90% of the pneumothorax which I saw in the casualty is secondary spontaneous due to COPD and all. So sir is very right that don't forget, if any patient with a trauma, RTA, a fall, if there is a slight reduction in the air on one side, like which happened to Vandana, you have to know, because simple releasing of the tension in that area will save a patient. That is the message. And regarding oxygen, the only point I want to continue is, when you ask the sister to give a nebulization, they go and remove the oxygen and put the nebulizer mask. The most important problem there is the hypoxia. So don't remove the oxygen, and along with you have to continue the nebulization. Simultaneously both should go. That is the only point I want to convey.
Sir, on asthma treatment.
Thanks for that very informative presentation. A couple of queries. Say, we had a young patient with profuse hemoptysis, and an angiography was done. It was normal. But then, as a trial, we gave one shot of, Mithapred IV. 2 days it cleared off. I think it would have been a case of pulmonary alveolar proteinosis.
Possible. That was a steroid responsive condition presenting as, it's not very common, maybe an isolated, but when there is a patient with a massive hemoptysis or a large quantity, more than 200, 99% of the cases the culprit vessel blood vessel will be bronchial artery. Because bronchial artery is a branch of aorta which is in systemic pressure. If your BP is also a bit high, it is going to bleed like anything. But carcinoma patients, to my experience, they will come with a streaky hemoptysis. And a condition which is steroid responsive coming with, that may be a rare problem, rare disease.
Second thing is that when you have multiloculated pneumothorax, and what is the treatment option?
So multiloculated chest tube will be difficult, sir. So now what we do is, if there is a multiloculated pneumothorax, what we do is we put a small bore needle, like pigtail catheters are available, 16 French, 18 French catheters. We will put in the large area where, so that the patient will be bit improved. Simultaneously, next day you have to refer to the thoracic surgeon for a definite management.
For pleurodesis.
Either with multiple pocket means there is adhesion in between. You have to release the adhesion, make the lung expand. If failing, go for a decortication. Decortication, remove the pleura.
Okay, thank you very much.
Sir, is there any role of regular yoga or breathing exercises in bronchial asthma, in preventing bronchial asthma?
Yes, sir. Asthma patients for management, yoga, breathing exercise do have a role, but it should be along with the pharmacotherapy, not as a single entity. You have to optimize the pharmacotherapy along with asthma, rehab, like breathing exercise, definitely has a role, but it will not replace your pharmacotherapy.
I have one more question. The patient has got a pneumothorax, not in tension, but is closed pneumothorax. But patient is symptomatic with a local unilateral chest pain and some dyspnea. So necessary to put an intercostal drainage and...
The second most common indication for putting a tube is any volume pneumothorax, whether small or large. The patient is symptomatic. Yes. You have to put a tube.
Okay, thank you for...
MCQ question, the commonest indication is tension pneumothorax. But in my practice, any patient with pneumothorax who is symptomatic, chest tube is the answer.
Okay, thank you.
Yes.
I think no further questions, you can stop the... Thank you.
Thank you, sir. May I request our chairperson, Dr. Srikandan, sir, to kindly present the memento to Dr. Jayaprakash, sir. Let me invite Dr. Wilson AP, Consultant Physician, KIMS Hospital, Trivandrum, to present the memento to Dr. Srikandan, sir.
The heart beats slow in a rhythm askew, the chill of winter in bones so frail. In the fog of mind where thoughts should soar, weight gathers like burdens unseen. Butterflies are symbols of transformation. From cocoons they embrace to skies unseen. And so is a butterfly gland, the thyroid, the unsung hero. Today, as modern science unravels the intricacies of thyroid function, we stand at the threshold of a new era in understanding and treating hypothyroidism. Our next talk is on the topic Pearls in the Treatment of Hypothyroidism by Dr. Amit N., Associate Professor, Department of General Medicine, Azizia Institute of Medical Science, Kollam. Let us invite Dr. Anil Vijaykumar, Professor, Department of General Medicine, Azizia Medical Hospital, and Dr. George K. George, HOD and Professor, Department of Anesthesia, Azizia Medical Hospital, Kollam.
eagerly waiting for this session to be over for the lunch. But we have got a very dynamic speaker, Dr. Amit, and he will speak on a current topic which is very important. As an anesthetist, I find it one of the most important topic for today. Dr. Amit will speak on the hidden topic, pearls in hypothyroidism. Dr. Amit, as you know, is one of the most sought after physicians in this hospital, and as you all know, he has got the most fan base among the students and interns. So let us hear Dr. Amit.
Good afternoon, everyone. Thank you, Joseph, for the kind words. No, it's very difficult. I'm having a panic attack to talk after such eminent speakers, George Ghosh sir, Jagumar sir. I just heard their names only before. And initially, my topic was actually pitfalls in the treatment of hypothyroidism. Then, since there was already a pitfall in dementia, we changed it into pearls. So, coming to why we choose this topic, because hypothyroidism, we know, is one of the most commonest endocrinological disorders that we treat. The studies that done in last decade, it is found that every 1 in 10 patients, 10 adults in India suffer from hypothyroidism. And mostly the risk of hypothyroidism increases as you pass the age of 35 years, and so you should screen more patients, in patients who are age of 35 years. And hypothyroidism is 3 times more common in female patients, and also in diabetic patients, it is seen in there is some thyroid pathology, 1 in every 3 diabetic patients. Coming to anatomy, this you all know, it's the thyroid gland. It is one of the largest endocrine organs, and it weighs around 20 grams, is located anterior to the trachea, and the blood flow of thyroid gland is around 6 ml, that is almost 2 times the blood flow of kidneys. And the physiology, I'm not going into deep, just you know that the TRH, thyrotropin releasing hormone from the hypothalamus comes to the pituitary, where it starts secreting TSH. The TSH comes to the TSH receptors in the thyroid gland, and it activates the secretion of thyroxine. So thyroxine, the thyroid gland secretes 2 types of thyroxine. One is T4, that is tetraiodothyroxine, and the T3, that is triiodothyroxine. And the most active hormone is the T3, that is triiodothyroxine, and but the thyroid gland secretes it in such a way that 80% of the hormone that has been secreted is T4, and only 20% will be 10 to 20% of will be T3 as such. And our body in cells, inside the cells, it converts using deadenases. Whichever cell requires the T3, inside the cell it converts T4 to T3. So our topic was in hypothyroidism, it can be of 2 types. It can be primary or secondary. Primary hypothyroidism, the pathology is in the thyroid gland, where the TSH from the pituitary comes and attaches to the TSH receptors, but the thyroid gland doesn't have enough follicles or have some problem in the thyroid gland that it will not produce enough thyroxine. So as a result, what happens in primary hypothyroidism, the pathology of thyroid gland, where the TSH will be high and T4 will be low. Then there is another entity. 99% of the patients, hypothyroid patients we get is a primary hypothyroidism. Then there is a rare entity, around 1 to 5%, where the pathology is either in the pituitary or in the hypothalamus, mainly in the pituitary. The damage to the pituitary causes reduced release of TSH. As a result, there will be less TSH coming to the thyroid gland, and thyroid gland will not be functioning properly. As a result, the thyroxine level also will come down. So, in primary hypothyroidism, TSH is elevated and T4 is reduced, while in secondary hypothyroidism, TSH is low, T4 is also low. There is another entity that we see usually that will mimic this. That is in a patients who are admitted to coming to us with acute illness. When you do a TFT, usually most of the bodies, guideline bodies ask us to avoid doing TFT during acute illness, because when you do a TFT during acute illness, it will mimic something like this. There will be, TSH will be in the low borderline value, and the T4 also will be on the low borderline normal. That we call as non-thyroidal illness, or previously called as sick euthyroid illness. Another entity I want to mention here is something called subclinical hypothyroidism. Subclinical hypothyroidism occurs when, again, there is a pathology in the thyroid gland. When the thyroid follicles are damaged, the thyroxine level in our blood will come down. As a result, the pituitary will start producing increased amount of TSH. so that the thyroid gland will be able to maintain the T4 level. So whenever the thyroxine levels comes down, the pituitary will start producing increased level of TSH, and with an increased level of TSH, the thyroid will be able to keep the thyroxine levels in the normal limit. So that is called a subclinical hypothyroidism. So with a supraphysiological level of TSH, thyroxine levels are kept in normal limit, that we call a subclinical hypothyroidism. In that case, TSH will be elevated, T4 will be normal. So just touching upon the two types of thyroxines, one is triiodothyroxine, the next is tetraiodothyroxine. In T4, the half-life is around 7 days, and it's a stable component in the body. It will remain as a stable, long-acting component, and the intestinal absorption when you give an oral T4 is around 80%. So it has got a very good bioavailability when you give an orally. But what about the active hormone, that is triiodothyroxine? The active hormone triiodothyroxine has a half-life of around 3/4 of a day, and the blood level fluctuates very rapidly. And the onset of the action is also rapid, around 2 to 4 hours only. So, and when you give it externally, it can falsely suppress the TSH values. Within few minutes, if you give, within few hours, if you give, it can falsely suppress the TSH values. Just basically touching about the thyroid function test. The thyroid function test, we will be doing TSH, total T4 or free T4, or total T3 or free T3. Free T3 is nothing. Free T3 or T4 is the active hormone that is unbound to the thyroid binding albumin and globulin. So usually thyroxines are kept in our body with the help of thyroid binding globulin or albumin. But the free hormones are the active hormones that are available for the physiological action. One more thing I want to make sure here is when you see a TSH, the normal values written in the lab will be around 0.4 to 4.1 to mu international units per ml. But if you check the functional range, that is a physiological range, it will be around 0.8 to 2.5, 2.2 mu international units per ml. Functional range means if you check TSH levels in a community and normal healthy adults, 90% of them have a TSH value in between this 0.8 to 2.5 mu international units per ml. So when you start treating hypothyroidism, better to keep the patients in this physiological range. Even though the TSH value is around 0.4 to 4.5, better to aim for the range of 0.8 to 2.5 in patients. So again, hypothyroidism, what are the causes of primary hypothyroidism, where the damage is in the thyroid gland? The primary hypothyroidism, the causes are autoimmune thyroiditis, or otherwise called as Hashimoto's thyroiditis. Previously it was iodine deficiency, but now we have become an iodine sufficient state, thus, thanks to the iodinized salt. Now the commonest cause is autoimmune diseases like Hashimoto's thyroiditis. The second commonest cause still in the worldwide is the iodine deficiency. Third is surgery, either a partial or a total thyroidectomy, or even radioactive iodine for hyperthyroidism treatment can push the patient to hypothyroid, or then it can be radiation therapy given for some other cause to the neck, can cause damage to the thyroid gland. Then certain medications which are rich in iodine, or like lithium, amiodarone, that all can cause reduction in thyroid secretion. And there are secondary causes. The commonest causes are tumors in the pituitary like craniopharyngioma or meningioma, pituitary adenoma. Then there can be trauma or surgery, radiation to pituitary, and infections like infiltrative diseases, tuberculosis, syphilis, toxoplasmosis can affect the pituitary and cause hypothyroidism, secondary hypothyroidism. Then infiltrative diseases like sarcoidosis or histiocytosis can also cause secondary hypothyroidism. So primary hypothyroidism, pathology in the thyroid gland where the TSH will be high and T4 will be low. And most of the cases when you check a thyroid peroxide, it's not always necessary when you get a patient with hypothyroidism to look for the etiology. Either way you have to replace the with the thyroxine, and which is a safe drug. So, but if you check for anti-TPO in those patients, most of them will be, especially young females, most of them will be positive for anti-TPO antibodies suggestive of the etiology being Hashimoto's thyroiditis. I'll just brush up on the clinical features. The usually patient presents initially with non-specific symptoms like arthralgia, myalgia, cognitive impairment, poor ability to concentrate, and can lead to even depression. Then cold intolerance. Cold intolerance is due to vasoconstriction, constipation, dry skin, edema. Edema here in thyroid is due to is a non-pitting type of edema, because the edema caused here is not due to not only due to fluid accumulation, it's because of the infiltration of the dermis by glycosaminoglycans or like hyaluronic acid. Then there can be fatigue, dryness or thinning of hair, infertility, lethargy, menorrhagia, voice change, hoarse voice, weight gain and weakness. And clinical signs, we will check bradycardia and diastolic hypertension. I have seen many cases where the young patients who comes to you, they will have sinus bradycardia with diastolic hypertension. When you check the TSH, patient will be in hypothyroid range. Then there can be again edema, I told, non-beating edema, goiter, hoarseness of voice. Hoarseness of voice is due to the infiltration of mucopolysaccharides into the larynx, causes hoarseness of voice. Hypothermia, coarse facies, periorbital edema, macroglossia. When on investigation wise, you can get normocytic and normochromic anemia, elevated CRP, hyponatremia, euvolemic hyponatremia. Hypothyroidism is one of the DDs for SIADH, and you should rule out hypothyroidism before diagnosing SIADH in euvolemic hyponatremia. Then increased creatine kinase, increased LDL and triglycerides, hyperprolactinemia. These can be the signs. I will just go to the treatment main aspect. So treating thyroid is always gratifying because most of the time we can able to resolve the symptoms fully. So goal of the therapy is always to normalize TSH, and the therapy almost always with levothyroxine, that is T4. Now there are certain controversial reports are coming there to start treating with T3 also, but still most of the guideline bodies prefer treating with oral levothyroxine. And the primary advantage of levothyroxine, I have already told that T4, it has a long half-life and it remains stable in the blood, and there's not much fluctuation in the blood level. And also one more advantage is when you give T4, we are also using our physiological deiodinase levels in the cell to convert it into the active hormone of T3. When we are giving a prodrug and our body, whenever the cell requires it, it can use the deiodinases in our peripheral tissue to convert it into T3 as and when required. Okay, that's the advantage of giving T4. So what's a full replacement dose of thyroxine is around 1.6 micrograms per kg per day of lean body weight. You should note that it's lean body weight, not the body weight that we calculate by measuring it. So that is a full replacement dose. That dose may not be required always. Full replacement dose is usually required when you do a total thyroidectomy. Okay, so in most of the cases, some of the thyroid gland will be preserved and it will be producing some amount of thyroxine. So the full replacement dose will not be required initially. Absorption regarding when the timing of the giving thyroxine, one thing is you should always be careful. When you given it in a fasting state, the absorption is complete and is less erratic. So better to prefer it at least 1 hour prior to food. Better to give thyroxine tablet at least 1 hour prior to food. That's a safe option. And one more thing is, this is another pearl that I want to discuss. Since the half-life is around 7 days, what you can give is, if a patient has omitted 1 day's tablet today, they can take today's tablet along with tomorrow's tablet. Means a patient was taking 75 micrograms of thyroxine throughout, and one day patient unknowingly forgot to take the tablet. He is supposed to replace the tablet on next day's dose. Means next day with tomorrow's 75 dose, he has to take the skipped dose also. So 150 mg next day he can take. That will not cause any harm, but it will stabilize the TSH. So since the half-life is of 7 days, so almost 1 week's dose we can adjust. I already discussed the full dose may not be required. It's always better to start low and titrate upward. Especially this should be very careful when you start a patient on thyroxine. Those cases who are having coronary artery disease or patients who are elderly, above 60 years, it's always better to start a low dose of 25 micrograms to 50 micrograms and then increase the dose gradually after checking the TSH. And you should be very, very careful when you start the thyroxine high doses on a patient who is having stable angina, because it can precipitate angina, can worsen angina, and also in patients who have a history of arrhythmias like atrial fibrillation. Thyroxine again can precipitate arrhythmia like atrial fibrillation. And one more pearl I have to discuss, when a patient requires both iron, calcium along with thyroxine, it's always better to place the drug around 4 hours gap should be there, because again thyroxine absorption is inhibited by calcium and iron. So when any of these drugs are given, you should at least keep a gap of 4 hours when you start these drugs. And the aim of your treatment is to titrate up to normalize the TSH. And when should the TSH be checked? This is a common mistake people make, I have seen. So they will start the drug and you will check the TSH after 3 weeks or 4 weeks. But in studies it has been found that it will take at least 8 weeks for the TSH level to be stabilized into the actual effect of the drug that we have started. So they are preferring, at least you should do TSH at least 8 weeks, preferably at least 3 months. Once you started a patient on thyroxine, you should do the TSH levels at least 8 weeks after, or at least preferably after 3 months of time. There are some scenarios where you want to sometimes check it early, like patients who are treating for infertility or in pregnant patients. Then also the better drug test to monitor is a T4 level than doing a TSH, because TSH either way takes 8 weeks. T4 can be stabilized within 2 to 3 days time. So some of the patients, when they come to us, when you check TFT, usually we'll do a TSH for follow-up. TSH will remain unchanged. When you do TFT, you can see that TSH is uncontrolled. It's a little more than the normal, but T4, T3 will be in the with normal limit. In that cases, you should suspect a drug compliance, because TSH again takes long 8 weeks to stabilize, but T3, T4, if you take it 2 to 3 days, these patients are very clever. They will take it, they will know that they want to check the thyroid, so they will do it 2 to 3 days before the checking thyroid, they will take the tablet properly. But that will not stabilize. That T3, T4 will be normal, but TSH will be abnormal in that case. When you see such a result, you should always look for compliance. Conditions require increased dose, I will just skip upon. Usually thyroxine is absorbed in the small intestine, so any pathology there, and also acid secretion is required. So conditions damaging acid secretion also requires a higher dose of thyroxine. And patients, agents that again bind with the thyroxine, that is sucralfate, we use it commonly nowadays, and ferrous sulfate, calcium carbonate, and sevelamer. When patients are on these drugs, the thyroxine dosing should be kept at least 4 to 6 hours apart. Then increased weight loss. Okay, subclinical hypothyroidism, I told you it's TSH is high, but T4 is normal. You call it a subclinical hypothyroidism. Affects 10% of the population. Either it can be a condition just prior to the patient becoming hypothyroid, or sometimes it can be just after insult of the thyroid gland is trying to recover. So most of the cases, 60% of the people will usually respond, become euthyroid after some 2 months. So it is not advised to start treatment on hypothyroidism until under specific conditions. So what are the conditions where you start treatment on subclinical hypothyroidism? When the TSH value is around 4.5 to 6.9 or 7, you should look at the age of the patient. If the age is less than 65, you should measure the anti-TPO antibodies. If the anti-TPO antibodies is positive, you can start the treatment patient on hypothyroxine. Or if the patient is planning pregnancy, then also you can start the patient. If it's in the value is in the subclinical hypothyroidism range, you can start the patient on treatment. Or if there's a goiter present, again you can start treatment. These are the indications. Or if the patient is having significant hypothyroid symptoms, you can start treatment. But if the age is above 65, even if the TSH range is in 4.5 to 7, don't start the patient on treatment. Next, the TSH value is from 7 to 9.9. You can, if the patient's age is less than 65, you can start treatment with levothyroxine. Patient above 65 can consider treatment depending on the patient's other comorbidity and patient symptoms. TSH value above 10 in any age group is better to treat, because most of these patients above 10 TSH will progress to frank hypothyroidism. 1 or 2 slides regarding hypothyroid treatment in pregnancy. Pregnancy is one condition where you should be very careful, because pregnancy hypothyroidism is associated with a lot of comorbidities. So it's better to treat the pregnancy specific TSH values are different actually. So most of the labs, they will give a pregnancy specific values. If you don't get a value, if a 2.5 in the first trimester, 3 in the second trimester and 3.5 in the third trimester will be a safe limit. And so oral levothyroxine in pregnancy also, oral levothyroxine is the drug of choice. Patients should be monitored for the serum TSH measurement every 4 weeks. This is the one condition you can measure the TSH level until mid-gestation. Target TSH level in the first trimester should be always less than 2.5. This is very important. In a target, it should be less than 2.5 in first trimester, because again, patients who are having above 2.5 or this is in hypothyroid patients. Hypothyroid patients already taking thyroxine treatment. When you check during first trimester, if it's above 2.5, you should increase the dose. So it's better to keep it low. So patients in the non-thyroid patients, not previously non-diagnosed case of thyroid, if the patient came for pregnancy, and that time when you check a TSH concentration 2.5 should be evaluated for anti-TPO antibody status. The anti-TPO antibody status is positive, then also you should start treating the patient. So one more thing is, if a patient is having planning to conceive, it's a non-case of hypothyroid, it's always better to reduce the level of TSH to less than 2.5 before planning conceiving. Okay, so that's another important. Then central hypothyroidism, due to lack of time, I'll just skip the slide. Central hypothyroidism, here only change is, in this case, we should not monitor TSH because TSH will be invariably low. So in central hypothyroidism, as a follow-up for treatment, what we monitor is T4 levels. So take-home messages, the hypothyroidism is very common. The treatment is total replacement dose is 1.6, but it's not always required. And start with a low dose and increase gradually, especially in patients who are having elderly patients who are having angina, patients who are having history of coronary artery disease and atrial fibrillation and other arrhythmias. And hypothyroxine should be taken 1 hour before food and 4 hours prior to drugs that has interaction with thyroxine. And also the monitoring should be after 8 weeks, at least 8 weeks, preferably 3 months. And pre-conceived, we should keep the TSH below, first trimester of pregnancy, we should keep the TSH below 2.5. In pregnancy, when you diagnose pregnancy itself, you can almost increase the dose of TSH, even without TSH checking, until unless the TSH is just above 2.5, you can just increase the dose of thyroxine to 30%. That's supposed to be done, okay? Thank you. So.
You said that in the first trimester, the TSH is more than 2.5 and TPO is positive, the drugs to be started. On what, which dose? Is it a low dose or high dose?
Patients, they will tolerate hyperthyroidism better than hypothyroidism. So hypothyroidism has been associated with a lot of risks like preeclampsia, premature delivery, all those things is associated with. So it's better to treat them, and you can monitor the T4 value. Better than TSH is better to monitor the T4 value after 4 weeks. If the T4 value is not coming in the range of normal, we can increase the dose.
But the T4 will be normally somewhat increased in the first trimester.
Yes, sir, it can be.
So I think...
but T4 if normally increase means, sir, it's due to the effect of HCG hormone. HCG hormone, it will be normally increased. But when we are talking in this case, the patient may be hypothyroid. That time it will not be normal.
So I had attended one CME at Thrissur,
yes,
where Professor Muralidharan sir told that if 10 is normal in the normal individual, 10 plus 5, 15 should be taken as normal in pregnancy. And
no,
if it is
sir,
about...
No, sir. That's, I don't know. I think that's not in guidelines. This I have taken from, the talk I have taken from American Association of Clinical Endocrinologists and American Thyroid Association guidelines. The full talk I have taken. Only the initial slides I have taken from endocrinology textbook. So don't think that in pregnancy the TSH level actually they will reduce it, especially in first trimester. It's not goes up.
Dr. Amit, here.
Sir.
Nice presentation. How common do you come across hypothyroid with fatty liver disease? There's been a lot of reports on, because time and again you don't screen for liver function test or you don't do an ultrasound abdomen for these patients. There has been a lot of report on. This is just a comment to say that NAFLD is very highly associated with hypothyroidism. Any comments?
Yes, sir. Even if normally also your cholesterol level in blood increases with hypothyroidism, because the receptors, hypothyroidism causes the reduction in receptors of LDL. So as a result, the cholesterol level will be more elevated. And even if metabolic disease, hypothyroidism in metabolics, many of my PGs are doing thesis, I think some of them are doing thesis regarding that. Thyroid diseases in metabolic illnesses is very common.
Yeah, that brings home the point that any case of severe dyslipidemia, always screen for thyroid and then start the treatment for dyslipidemia.
Sure. Especially young patients coming with dyslipidemia, hypertriglyceridemia and hyper LDL, you should are better to screen for a thyroid disease than before starting statin straight away. Because secondary dyslipidemia usually improves without statin if you treat the primary condition. So,
Any more questions before we close up the line?
So, I would like to add one point, in pregnancy, the total T4 level actually rises. So it's better that we monitor the pregnant woman with the free T4 value. And if we find that the TSH is more than 2.5, we go for a free T3 and free T4 value. If that is normal, then we'll go into a diagnosis of subclinical hypothyroidism. In that case, our management will be depending upon the anti-TPO value. So if the TP is also elevated, it is better we start on thyronome supplements. But if it is normal, it is better we just monitor the patient in every trimester with the TSH value.
yes, definitely. This point actually I have it in my slides. I just rushed through because of the short of time. There are both pro and people who are supporting that theory and people who are supporting the other. Also, any patient who are TSH above 2.5, there are endocrinologists who support that you should treat. It's better to treat. Again, the same mechanism, but see, I have that slide in American College of Clinical Endocrinology that they have written it there. Like if you have TPO positive, that is invariably, there is a high chance that patient will progress into hypothyroidism within few weeks or months. So it's better to start treatment early in that case. But there are both ways of views are there. Most of the textbooks, some of them, most of the guideline bodies, if you see, some of them are supported for treatment. And studies also show some of them are supporting treatment. Just when TSH above 2.5, they are supporting treatment.
Such value varying from 5, but the ideal value you have to keep on treatment.
Pardon me, sir?
Usual value is 0.5
Yes,
TSH.
Yes,
But the ideal value to be kept, ideal value of TSH. You cannot bring to, because the middle value should be there. Or it is varying from 0.5 to 5.
Yes, sir.
But the ideal value to be kept. Because sometimes it may patient initially patient had 25.
Yes, sir.
It brought down to 6.
Yes, sir.
Then you increment. It is a 25 initially patient started on 100 microgram. Increment 12.5 or a 25. Sometimes 25 if you add, the TSH will come very low.
Very low.
So 12.5 may sometimes increment may vary.
Yes, sir.
What should be the ideal?
Sir, ideal in young patients it's better to keep it between 0.8 to 2.5. That's I have written.
0.8 to 2.5.
Yes,
I
sir.
think when it reaches 5, you can add something more. So some increments may be 6.15, 12.5 milligram, microgram tablets are also now available.
Yes, sir. Now the titration is very easy because most of every 2.5 increment there is a tablet available. So the titration
And now it
is
is
very
a lower
easy
dosage also available.
We can
on that
give
way.
the drugs
Now, sometimes if you increase the dosage, suddenly the TSH will come down very low.
Yes, sir. Most of the cases, what happens is, sir, in this case, they will be taking a drug that has some effect on the absorption of TSH. And when they stop the drug, when you increase the dose, immediately the TSH will come down drastically. In young patients, the value better to keep it below 2.5, sir. But in older patients, they are telling up to 7.5 is a safe limit. In patients above 70 years, up to 7.5 is a safe limit. That don't increase the dose very drastically. That's what they are telling. Even up to 7.5 is okay.
Regarding that 2.5 cutoff, what I do is, if your TSH is near 5, but your T4 is again upper limit, like near 12.5 or 13, then I don't increase.
Yes.
If T4 level is in the middle range, and if TSH is above 2.5, then I increase the dose. That is what I usually do. And regarding pregnancy, irrespective of trimester, I usually, in case they ask me, I usually advise to keep it 2.5. Because above 2.5, generally better to.
Yes, sir, that's always better.
And the second thing is regarding how frequently we must monitor. Because a child whom I was treating, she is now a medical student. Now I reviewed and found that she is hypothyroid still. So, I mean, the interval, because she has put on a lot of weight now. So,
sir, ideally what they are telling is, sir, once you stabilize the dose, means initially you have to do it every 3 monthly, minimum at least 8 weeks or preferably 3 monthly. And once you stabilize the dose of TSH, you can do it every 6 months or at least 1 year. 1 year is the minimum time they should take to repeat the TSH level. But one thing you should be careful is, again, you should not be, these patients should not be taking other drugs. That's the importance of this interaction comes. When a patient was otherwise stable on a fixed value of thyroxine, suddenly it becomes uncontrolled. Then you should always suspect any variation in the food or any change in this the drugs that she has been taking. She might be started on young girls, she might be started on iron tablet. So that will impair the absorption of thyroxine, or calcium tablet. Sometimes being sucralfate, all these drugs can impair the absorption. So when a patient already stable suddenly become uncontrolled, you should really probe why the patient has become uncontrolled. It's better to always ask.
in this case, I think the factor that led to, she is now
Obviously.
actually 100 kilos.
That's
So
why they are
that-
telling
that
increasing
is-
the age at least every 1 year at least do, because once you grow the TSH level, the lean body weight changes. As a result, the TSH requirement will also change.
And one last question regarding puberty goiter with a normal thyroid function. Do you treat or not?
Puberty?
Puberty goiter with a normal thyroid function.
No, sir, I don't think we'll treat.
Actually, I treat. I mean, the usual recommendation is not to treat. I treat basically because my impression is that if you give a little bit of extra thyroxine from outside, this gland will become a bit quiet and become a little subdued in appearance. That's why I do.
In goiter, they have found out that once you stabilize the TSH, there will be around 50% reduction in the size of the goiter. That's what they have found. The patients who are having enlarged thyroid.
Is it necessity that the patient continue the same brand? The thyronome is there, L-toxin is there, thyrox is there. I have heard one endocrinologist told that continue the same brand, don't change the.
Sir, regarding that, I have looked into the literature. US FDA has done studies with the multiple brands, and they didn't find out any much variation in the T4 levels in the blood when they change the brand. But I don't think that we can offer the same with the Indian scenario. We have multiple brands.
Anything can be changed.
Yeah, actually, theoretically, we can give multiple drugs, sir. Yes. But again, we don't know how is the efficacy of these drugs when it comes to practical purpose. In India, I couldn't find any studies they have done like that. But FDA has done studies looking for the T4 levels after changing multiple drugs. In those studies, it has not found any variation in levels once they change. But still, there is a guideline bodies almost, they have wrote a line that it's better to continue the same drug, same company.
I think that's the last question. Thank you, Dr. Amit, for a wonderful presentation.
Thank you so much.
Wind up our session.
Thank you, sir. I request the chairpersons to kindly present the memento to Dr. Amit. I invite Dr. Sanju Daniel John, Senior Consultant Physician, Apollo Hospital, Kochi, and Dr. Ajay Kumar Ayyappan Unnithan, Head of Department, Department of Neurosurgery, Azizia Medical College Hospital, to present the mementos to our chairpersons. Now, it's time for the lunch break. I would like to request all our guests to move toward the lunch hall. We will resume the afternoon sessions here at 2:30 p.m. We have an e-poster presentation at 2:10 p.m. at lunch hall. Thank you.
While exiting, everybody is requested to use the front doors. The back doors will be closed.
Srija. So Dr. Shripa is having MBBS, MD and DMC in nephrology. She is a senior concerned nephrologist in Nayars Hospital, Kollam. She was a former consultant of nephrology in ESI Hospital, Ashramam. And now we very much anxiously awaiting, because we had taken fruit salad and ice cream. So we are having a sleepy mood. Let us hope that our fear will be over after your talk, madam. Okay, thank you. Over to you.
Thank you, sir. Good afternoon, everyone. At the outset, I thank Dr. Rajashekhan and team for giving me this opportunity to speak on this subject, diabetic nephropathy, approach to management. We know that diabetes is the most common cause of end-stage renal disease worldwide, and the incidence of ESRD due to diabetes is increasing over the years. Now, the diabetic nephropathy is actually the classical form of diabetic kidney disease, occurring due to microvascular complication of diabetes, and this is seen in about 40% of patients with type 1 as well as type 2 diabetes. Diabetic nephropathy is characterized by albuminuria, progressive decline in GFR, hypertension, and it is associated with increased cardiovascular morbidity and mortality. Typically, a patient with type 1 diabetes with nephropathy goes through the various stages. There is initially a stage of hyperfiltration and hypertrophy. This is usually seen at the onset of diabetes. Then in the second stage is usually silent, GFR is normal. There are some pathological changes taking place in the kidney. This usually is about 2 to 5 years after the onset of diabetes. Then there is the stage of incipient nephropathy, or stage 3, in which there is increased excretion of albumin in the urine of about 30 to 300 milligram per 24 hours, the earlier called microalbuminuria. This usually occurs about 5 to 10 years after the onset of diabetes. Then in stage 4, or overt nephropathy, there is macroalbuminuria, or severely increased proteinuria as we call it now. And in this stage, eGFR also declines, and this is usually between 10 to 25 years after the onset of diabetes. And end-stage kidney disease occurs in any period more than 15 years after the onset of diabetes. Now, diabetes is characterized by an increase in the mesangial matrix in the glomerulus, and the typical lesion is this one, the Kimmel-Still-Wilson lesion, characterized by nodular glomerulosclerosis. You can see nodules of extracellular matrix within the glomerulus. And pathology also consists of afferent and efferent arteriolar hyalinosis in diabetic nephropathy. Now, basically, in diabetic nephropathy, what happens is progressive fibrosis, and this occurs because of the metabolic dysregulation that occurring due to hyperglycemia. Hyperglycemia activates the formation of advanced glycosylation end products, hexosamine pathway and polyol pathway and protein kinase C. All these pathways, along with an increase in activity of the renin-angiotensin system, lead to a state of inflammation and an increase in oxidant stress. All these activate various intracellular pathways, and these various intracellular pathways lead to generation of production of various cytokines that cause increased formation of matrix within the kidneys, extracellular matrix, and this ultimately results in fibrosis. Now, the diabetic nephropathy that I described earlier is the typical form, but now it is identified that diabetic kidney disease is heterogeneous. That is, a few group of patients present without proteinuria, and these have been called as non-albuminuric form of diabetic kidney disease. Now, this form of diabetic kidney disease is non-albuminuric. That means the urine albumin creatinine ratio is less than 30 milligram per gram. They have a low GFR, and it is more of a macroangiopathy and not microangiopathy. And there is no correlation with retinopathy in these patients. And these patients have more of tubular and vascular damage rather than glomerular damage, more common in females, and it is not correlated with HbA1c. Now, these patients with non-albuminuric form of diabetic kidney disease probably would have had multiple episodes of AKI in the past, or they would be having associated cardiovascular disease, renovascular disease, ischemic nephropathy causing this non-albuminuric form of kidney disease. Now, how do we screen for diabetic nephropathy? Now, in every patient with type 1 diabetes, from about 5 years after the onset of diabetes, we have to look for the development of nephropathy. And in case of type 2 diabetics, the screening should begin at the time of diagnosis because very often they present with complications of nephropathy. And screening should consist of evaluation for proteinuria, then estimating or calculating the estimated GFR and look for retinopathy. Now, depending upon the degree of proteinuria, we have classification as mildly increased, moderately increased and severely increased proteinuria. Less than 30 milligram per gram is the normal one. Moderately increased or earlier called microalbuminuria is 30 to 300 milligram per gram of protein in the urine, and severely increased proteinuria is more than 300 milligram per gram of creatinine. Now, in addition to this, glomerular filtration rate also has to be calculated after looking at the serum creatinine, and depending upon the glomerular filtration rate, we have various categories: G1, G2, G3A, G3B, and G4 and G5. And if you look at this picture, those patients who come under these categories, that is, those in the red squares and orange squares, are more likely to develop kidney failure in the near future. Whereas those in the green box, that is, those having lower grades of proteinuria and high GFR, they are not likely to develop renal failure in the near future. Now, whenever a patient with diabetes presents with proteinuria, first we have to quantitate the amount of protein in the urine by 24-hour collection, and after that you have to look at the urine for any active urinary sediment, for the presence of any red blood cells or white blood cells, red blood cell casts, etc. You have to rule out urinary tract infection and do a renal ultrasound. And if any systemic disease is suspected, you may have to do serologic tests like ANA, ANGA, etc. Now, once you evaluate all this, you can decide whether you need a biopsy or not. If it is a type 1 diabetic patient having disease for more than 5 years with associated retinopathy, having microalbuminuria in the past, progressing to nephrotic range proteinuria, there is no need to do a renal biopsy. The diagnosis is most likely diabetic nephropathy. On the other hand, if it is a type 1 diabetic patient with less duration of diabetes, no retinopathy, nephrotic range proteinuria without any previous microalbuminuria, presence of active urinary sediment, that means presence of RBCs or RBC casts in the urine, and absence of retinopathy. All these are indications for doing a renal biopsy to rule out non-diabetic kidney disease. Now, the other one, that is the non-albuminuric form of CKD, is suspected if you have patients with azotemia and less of proteinuria, with features of papillary necrosis or past history of tuberculosis in the past. These patients also you do not need to do biopsy. So, a non-diabetic kidney disease is suspected if the onset of proteinuria is rapid, if the progression of the kidney disease is rapid, if the duration of diabetes is less, if urine shows active urinary sediment and no retinopathy. In all these cases, we have to suspect non-diabetic kidney disease and go for renal biopsy to establish the alternate diagnosis. Now, management of diabetic nephropathy basically consists of cardiovascular risk reduction strategies, glycemic control, hypertension management, and now we have many drugs which have proven to decrease the progression of kidney disease. These include the renin-angiotensin system inhibitors, SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonists, and glucagon-like peptide 1 receptor agonists. So for cardiovascular risk modification, we should advise all the patients with diabetic nephropathy to stop tobacco use. They should have a good diet rich in vegetables and whole grains and fiber, and less of processed meat and sweetened beverages. Protein intake recommended is 0.8 gram per kg of body weight in patients with CKD, not on hemodialysis. And all patients with diabetic nephropathy should be advised to have exercise depending on their cardiovascular and physical tolerance, lasting for at least 150 minutes per week, that is around 20 minutes per day. Now, lipids in diabetic kidney disease patients, usually they have low HDL, high triglyceride, high apolipoprotein B and apolipoprotein C2, and these contribute to the cardiovascular risk. And it is statins and with or without ezetimibe are recommended for CKD patients with cardiovascular risk. Statins, if they have been initiated at a GFR of more than 15 ml per minute, it can be continued even when the patient is on dialysis. However, usually initiation of statins beyond initiation of dialysis is not advised. Now, fenofibrates are contraindicated in patients with a GFR of less than 30 ml per minute. And whenever we start high dose statins and fenofibrates in these patients, we should be on the lookout for side effects. Because many patients, we have had many patients presenting with rhabdomyolysis and worsening of renal function after initiation of fenofibrates along with high dose statins. Now, what about the dose of statins? All the statins can be used in the same dose as in general population except atorvastatin, whose dose should be only 20 milligram in patients with later stages of CKD, that is in CKD stage 4 and 5. And rosuvastatin dose should be only 10 milligram in CKD stage 4 and 5. Rest of the other statins can be used in the same dose as in general population. And whether the improvement in lipid profile improves the progression of kidney disease is not exactly known. Now, glycemic control in these patients is assessed by using HbA1c, and HbA1c is a suitable marker to assess glycemic control in earlier stages of CKD, that is in CKD stage G1 to G3b, whereas in CKD stage G4 and G5, HbA1c is less reliable. In these patients, CKD stage G4 and G5, it is better to use continuous glucose monitoring or self-monitoring of blood glucose to assess glycemic control. Now, in patients with type 1 diabetes, it is found that intensive blood glucose control can prevent the development of diabetic kidney disease. And an HbA1c target of 7 has been recommended. Now, these are various trials where glucose lowering strategies were tried. In diabetes control and complication trial and EDIC trials, type 1 diabetic patients were enrolled, and it was found that a reduction in HbA1c to around 7.3 when compared to 9.1 was associated with decreased microvascular complications including microalbuminuria. It is only these two studies that have proven that a reduction in HbA1c translated into better progression, better or a decrease in progression of kidney disease. However, in non-diabetic patients, a reduction of HbA1c to further lowering of HbA1c did not translate to better outcomes. Hence, KDOCI has recommended target HbA1c of 7 for both type 1 and type 2 diabetic patients, because when a target of around less than 6.5 was aimed, it was found that there was more of cardiovascular mortality and there were more episodes of hypoglycemia. So the target is only 7 for these patients. In fact, the HbA1c target should be individualized. The KDIGO says that it should be individualized. That means a lower HbA1c should be targeted in those patients who are in lower stages of CKD, in those patients who are expected to live longer, whereas in those patients with less life expectancy and those patients who are in higher stages of CKD, it is better to have a higher HbA1c target. Now, the glucose lowering therapy in diabetic kidney disease mainly depends on lifestyle modification like physical activity, nutrition and weight loss. And if HbA1c is not achieved with these, we start medications. The first recommended drug is metformin. Metformin can be started in all patients who have got an estimated glomerular filtration rate of more than 45 ml per minute. Now, once the eGFR, we have to keep monitoring serum creatinine, and once the GFR becomes less than 45 ml per minute, we have to reduce the dose to half the dose. And once the GFR is less than 30 ml per minute, this drug has to be stopped. And metformin should not be continued in any patient on dialysis because of the risk of lactic acidosis. Now, if HbA1c is not controlled with metformin, we go in for the SGLT2 inhibitor because of its cardiovascular and renal benefits. That is the second drug which is recommended, and SGLT2 inhibitors can be started in all patients who have got any GFR of more than 20 ml per minute. Once eGFR is less than 20, we should not use these drugs. That is dapagliflozin, canagliflozin and empagliflozin. And actually, if SGLT2 inhibitors have been started before the GFR comes down to 20, we may continue it until starting dialysis because of this cardiovascular benefit. Now, after starting these drugs, if we do not achieve the target HbA1c, other drugs like glucagon-like peptide-1 receptor agonists, which is then DPP-4 inhibitors, insulin and sulfonylureas may be added depending upon the patient's comorbid condition and also depending upon the affordability of the patient. So, most of the patients that we have cannot afford GLP-1 receptor agonists, or and most of them we usually put them on insulin and some sulfonylureas like glipizide. Now, metformin was initially recommended for patients with diabetic kidney disease because metformin was able to reduce and achieve HbA1c target without causing any weight gain, and it is relatively cheap and widely available. But once you start the patient on metformin, before starting itself you have to look at the eGFR and keep monitoring the eGFR annually, so that once the GFR becomes less than 45 ml per minute, you have to reduce the dose, and when the GFR becomes less than 30 ml per minute, you have to stop the drug. And any patient on metformin for more than 4 years, we also should look for vitamin B12 deficiency. Now, regarding the SGLT2 inhibitors are those drugs which act on the proximal convoluted tubule of the kidney. It acts on the sodium glucose co-transporter 2, and what it does is it inhibits the absorption of glucose in the proximal tubule. So, sodium as well as glucose, more of sodium and glucose is delivered in the distal tubule and more of it escapes in the urine. So, what happens is in the distal tubule more of sodium is detected, and what happens, this is detected with the macula densa, and this excess amount of sodium is detected, and this will influence the tubular-glomerular feedback and cause afferent arteriolar constriction. So, basically what it does is it decreases the glomerular pressure by causing afferent arteriolar constriction. It also causes a decrease in the activity of the renin-angiotensin system. In addition, it decreases inflammation and fibrosis in the kidney, and SGLT2 inhibitors decrease the renal metabolism, and hence proneness to hypoxia will be reduced. So, as a result, there is preservation of GFR, blood pressure reduction, tubular and glomerular damage attenuation, ischemic renal damage attenuation. So, these drugs afford renal protection. They prevent the progression of kidney disease. The glycosuric effect of these drugs is lost once GFR is less than 60 ml per minute. However, the renal protective effect and the cardiovascular benefit are retained. Now, who are the patients in whom we can start SGLT2 inhibitors? SGLT2 inhibitors, we know the drugs dapagliflozin at a dose of 10 mg, canagliflozin 100 mg, and empagliflozin at 10 mg. They can be started in patients with eGFR of more than 20 ml per minute with a high albumin creatinine ratio of 200 mg per gram with having features of heart failure. These are the patients who will benefit. And it is contraindicated in patients who are at risk for genital infection, diabetic ketoacidosis, foot ulcers, and also in immunosuppressed patients. That is, renal transplant recipients who are on immunosuppression are not advised SGLT2 inhibitors. Now, whenever we are using these drugs, we have to follow the sick day protocol, which means when the patient is extremely sick, patient is not taking adequately, there is prolonged fasting, or when the patient has got an acute medical illness or acute surgical illness, we may have to temporarily stop these drugs. Now, always follow up these patients with serum creatinine, a 30% fall in serum, 30% fall in GFR or a 30% increase in serum creatinine will be seen in these patients, and this is not an indication for stopping the drug. After about 12 weeks, it will stabilize. And these drugs do not cause or they do not increase the risk of hypoglycemia. However, when they are used along with sulfonylureas and insulin, hypoglycemia may occur, and if hypoglycemia occurs, we should reduce the dose of insulin and or the accompanying sulfonylurea. Similarly, if the patients are at risk for volume loss, that is, if a patient is already on diuretics, we may have to reduce the dose of diuretic when we start these drugs. Otherwise, they will go in for volume depletion. Now, these are 3 studies. Like in Credence study, canagliflozin at a dose of 100 milligram was used. In all these trials, Credence study and dapagliflozin in DAPA-CKD trial and empagliflozin in EMPA-kidney trial all showed a benefit for decreasing the progression of kidney failure. That means there was about, in case of Credence study, it was found that about 30% reduction in fall in GFR was seen. Now, the next group of drugs which will be beneficial in controlling sugars and also in arresting the progression of kidney disease is glucagon-like peptide-1 receptor agonist. Glucagon-like peptides, we know they are incretins, and these are released when you take food. When the food reaches the stomach, gut releases incretins, and these incretins stimulate insulin release from the beta cells and inhibit glucagon release from the alpha cells of the pancreas. In addition to this, these incretins have multiple effects on the brain and multiple organs, causing a decrease in appetite, weight loss. They are found to have cardiovascular as well as renal protective effects. And in those patients in whom HbA1c is not controlled or not achieved with SGLT2 and inhibitors and metformin, patients may be started on these drugs if they can afford. And these drugs should not be combined with DPP4 inhibitors. These are the various drugs available. All of them are in injectable forms except semaglutide. Dulaglutide, liraglutide, and semaglutide are available in our country, and these drugs were found to have cardiovascular protection by reducing major cardiovascular events in various studies. However, the oral form of the drug semaglutide did not have any effect on the major cardiovascular events. Now, one study is going on with injectable semaglutide in patients with diabetic kidney disease to prove its efficacy in retarding the progression of kidney disease. Now, the other oral hypoglycemic agents we have in hand are the DPP4 inhibitors. Though they reduce proteinuria, they were not found to have any significant effect on the cardiovascular risk, nor did they arrest the progression of kidney disease. Now, control of blood pressure is of paramount importance, and it is recommended that a BP of 130/80 has to be achieved in patients with diabetic nephropathy, that is, in those patients having proteinuria. And RAS inhibition formed the cornerstone of treating diabetic nephropathy since the 1990s. RAS inhibition can be achieved by using ACE inhibitors, ARBs, direct renin inhibitors, and mineralocorticoid inhibitors. Now, the RAS inhibition has been tried for primary prevention in type 1 diabetics, but it was not found to be useful. Whereas in type 2 diabetics, some drugs like prandolapril was found to be useful in preventing the progression from normoalbuminuria to microalbuminuria in type 2 diabetics. And in roadmap trial, olmesartan was found to be useful in preventing the development of microalbuminuria in type 2 diabetics. Now, for secondary prevention, these RAS inhibitors have been found to be very useful. In IRMA trial, irbesartan was found to prevent the progression to overt nephropathy in patients with microalbuminuria. And in IDNT and renal trial, irbesartan in IDNT and losartan in renal trial helped in decreasing the progression to end-stage kidney disease. A combination of these drugs, ACE inhibitors and ARBs, were tried in on-target and VA nephron D trials, but they were found to be more harmful because of the occurrence of hyperkalemia. Now, whenever you initiate a patient on ACE inhibitor or ARB, we have to monitor serum creatinine about 2 to 4 weeks after starting the drug. And also you have to check the serum potassium. If The serum creatinine, it is expected that serum creatinine will rise by about 30% of the baseline. Only if it is more than 30% of the baseline, we have to be worried. If it is less than 30% of the baseline, you can continue the drug. And if you see it is more than 30% of the baseline, you have to look for any other causes of worsening of renal function like volume depletion, concurrent use of other nephrotoxic agents, correct those, and even after that, if the creatinine continues to rise, you may have to stop the drug. And if there is hyperkalemia, that is more than 5.5, we have to look for other causes for hyperkalemia, the dietary indiscretions, etc. And then advise the patient to take potassium binding resins. And even after that, if hyperkalemia persists, we have to stop RAS inhibitors. And it was found that RAS inhibitors reduce the rate of decline in GFR to 4 to 5 ml per minute per year. Whereas without these drugs earlier, patients with diabetes and nephropathy used to lose their GFR by about 10 to 12 ml per minute per year without these drugs. So, however, even though we are able to decrease the progression of kidney disease, still there are some pathways which cause continued progression of kidney disease, and it was recognized to be due to aldosterone. Increased activity of aldosterone was found to be causing this further worsening of kidney function. Hence, mineralocorticoid receptor antagonists have been tried in kidney disease. We know that mineralocorticoid receptor antagonists, the steroidal varieties, spironolactone and eplerenone, have been used in cardiovascular trials. However, they are not used in kidney disease because of the risk of hyperkalemia. We have a new drug on the block, that is finerenone. This is a non-steroid mineralocorticoid antagonist useful in patients with proteinuria who are already on RAS inhibitors and SGLT2 inhibitors, who have persistent proteinuria despite the use of these. And in these patients, it was found that there was a risk reduction of development of kidney disease by about 18% when finerenone was used. Now, so we use, use of finerenone is recommended in patients with persistent proteinuria having a potassium of less than 4.8. The dose that we usually initiate is 10 milligram per day if eGFR is less than 60 ml per minute. A dose of 20 milligram may be given if the GFR is more than 60 ml per minute. We have to monitor potassium of these patients at first month, and if potassium is stable, you have to repeat it every 4 months. And if the potassium is between 4.9 to 5.5, you can maintain the same dose, whereas if the potassium is more than 5.5, you will have to hold finerenone, and after correcting hyperkalemia, we may restart it. Now, use of low sodium diet and diuretics can enhance the antiproteinuric effect of RAS inhibitors. Beta blockers like carbidopa and nebivolol improve the BP and cardiovascular outcomes in diabetic kidney disease. Many new drugs have been developed by interfering with the various intracellular pathways. These are all under development and have not been of proven benefit. Now, I shall conclude my talk with this slide, which shows the 4 pillars which can arrest the progression of kidney disease. Just like we saw the 4 pillars in the management of heart failure. Here, RAS blockers, SGLT2 inhibitors, and finerenone are the 3 known pillars to decrease the progression of kidney disease. And once the FLOW trial results come out, GLP-1 receptor agonists will also be able to arrest the progression of kidney disease. So our prescriptions now, in case of patients with diabetic nephropathy, should be including these drugs with careful monitoring of renal functions and potassium. Thank you all for patient hearing.
Thank you, madam. It's a very vast area, and hence we possibly overshoot the time. So we hardly have any time for discussion. So any doubts, you can personally ask the speaker. Thank you.
Thank you for this wonderful session, ma'am. I invite the chair to give memento to Dr. Sripa PG. I invite Dr. Jayasurya sir, former consultant physician in Aziza Institute of Medical Sciences and Research, and Dr. Anil Vijay Kumar sir, assistant professor in Department of General Medicine, Aziza Institute of Medical Sciences, to give a small token of gratitude to the chairs.
So it's come down to the last session of the day. Water, a symbol of life, renewal, and regeneration. Water is the reason for our birth. It is the healer, the destroyer, and the final consumer. Fluid resuscitation is a cornerstone of sepsis management. However, unless judiciously managed, this double-edged sword might result in detrimental effects on the patient. Our next talk is on fluid management in sepsis by Dr. Vivek Prasad, Head of Department of the Critical Care Medicine, NS Hospital. I kindly invite Dr. Liaquat Rupesh Johnson, Head of the Department of Community Medicine, Azizia Medical College Hospital, and Dr. Jafin Bashir, former Assistant Professor, Department of General Medicine, Azizia Medical College Hospital, to chair this session.
So today's last session is by Dr. Vivek Prasad, who is the Head of the Department of Critical Care Medicine at NS Hospital in Kollam. We've heard a lot about a lot of other aspects, but sepsis is something which all of us need to be wary, especially in the times of antimicrobial resistance. So we really look forward to this session. Just a word about Dr. Vivek Prasad. He has completed his MBBS from Government Medical College, Ernakulam, and DNB in Anesthesia from Lisi Hospital, Ernakulam. He has a DRNB in Critical Care Medicine from ICRA International Hospital and Research Center, Calicut. I invite you to commence your speech.
Thank you, sir. Thank you for the invitation. And I thank all the organizers for inviting me to have a talk. So, good afternoon, everyone. I'll be talking about fluid management in sepsis. So, sepsis, as you all know, is a life-threatening organ dysfunction caused by a dysregulated host response to infection. In other words, it's a life-threatening condition that arises when the body's response to an infection injures its own tissue and organs. So, coming to the pathophysiology of sepsis, as depicted, can I get a pointer? Point. So, as depicted in the picture, a pathogen is which can be a bacteria or a fungus or a virus. As it enters the body, our white blood cells will attack them by producing cytokines and other inflammatory mediators. This influence of the cytokines not only affects the pathogen, it also affects the blood vessels. That's when the sepsis occurs. It causes a leak in the capillaries along with release of nitric oxide, which causes vasodilatation, and also blood clots in the thin capillaries, which we term as septic emboli. So primarily, this vasodilation pattern occurs mainly in the peripheral vessels, and the blood volume will be shunted to the periphery and the central circulation will be compromised. This phenomenon will lead to a dysfunction in all the major organs like brain, lungs, heart, liver and the kidneys. And these dysfunctions will ultimately lead to multi-organ dysfunction. So we all know that the septic shock, we recognize a patient with septic shock by feeling the patient. We touch the patient, and if the patient is warm, the patient is in sepsis. That's because the blood volume is shifted from the core to the periphery, and the peripheral veins are dilated. So this phenomenon of septic shock, what the immediate management of septic shock, as we all do, is by fluid resuscitation, is that we will fill the inner core part so that the organ dysfunctions can be minimized. Hence, the vasodilation will be reflected as a low BP also. Coming to the proper management of sepsis according to the Surviving Sepsis campaign, I will just give an introduction of the Surviving Sepsis campaign. This is a task force by the European Society of Intensive Care Medicine. They have made, from 2002 onwards, recommendations and guidelines for managing sepsis. They have devised various bundles. Earlier it was a 3-hour and 6-hour bundle, and now in the 2021 recommendations, they have coalesced to a 1-hour bundle. And a bundle concept in critical care is that there are certain group of things that should be carried out together, so that which will implement, which is implemented together, so that they are concerned to a common cause. That is, on implementation of all these bundles, the common cause will be corrected. So the Hour 1 bundle in 2021 guidelines of surviving sepsis denotes 5 different bundles. That is, first one is emergency or recognition of sepsis, and all these 5 bundles should be initiated in the first 1 hour. The first bundle is to measure the lactate levels. If the lactate is more than 2 millimole per liter, we have to remeasure it within 3 hours. Then to obtain cultures before administering antibiotics. Ideally, 2 sets of blood cultures, aerobic and anaerobic, is recommended. Third is to administer empirically broad spectrum antibiotics. Fourth is our fluid management part, to begin rapid administration of crystalloids, mainly balanced crystalloids, at a rate of 30 ml per kg if the patient has hypotension or he has a lactate level of more than 4. And in spite of giving these crystalloids at this rate as a resuscitation mode, if the patient is not improving or the BP is not improving, his cardiac output is not improving, then we have to apply vasopressors to prevent hypotension and maintain a MAP more than or equal to 65 millimeters of mercury. This MAP target of 65 is for the vital organ perfusion. So this is the 2021 recommendation, as I mentioned, for initial resuscitation. For patients with sepsis or sepsis-induced hypoperfusion and septic shock, the recommendation according to Surviving Sepsis is 30 ml per kg within the first 3 hours of resuscitation. And the change from the 2016 to 21 is that initially the same recommendation they considered to be a strong recommendation with low quality of evidence. But in 2021, they have changed the recommendation to weak and the same status, low quality of evidence. This is because they have realized that the fluid resuscitation in sepsis will in turn lead to further complications, which the patient has to suffer in the following days, the initial resuscitation part. And there are no much studies to back the 3 ml per kg. They have given an empirical value like that. And also the per kg body weight. They haven't mentioned whether it's an ideal body weight, actual body weight, or predicted body weight. So this graph I have just put to make a realization that in this graph there are 3 different 1, 2, and 3 scenarios. Same patient. Initially, when we are loading the patient, is a stage 1. It can be stage 2 or 3. If the initial resuscitation has been given in any outer peripheral centers, we can receive the patient in stage 2 or 3 modes. The initial resuscitation 1, if the patient's volume of venous status is lower on the lower side and he is on the steep portion of the Frank-Starling's curve, then on giving a 30 ml per kg bolus, rapidly his cardiac output increases. Up to the third part of the graph, third line graph, as the volume of venous return increases, the right atrial pressure increases and the cardiac output increases. At the third part, you can see that there is no much further increase because the patient has been fluid loaded already. All the compartments has been filled. So, initially when you assess a sepsis patient, we should recognize that our patient is in which criteria, either 1, 2 or 3. If the patients fall in 1 to 2 group, then fluid resuscitation is appropriate. And if he is in the third criteria, there is no use in fluid resuscitation. Further, it will lead to adverse effects only. So how to assess whether our patients are in the criteria 1 and 2 is that we will say if the BP is improving, the patients fall in this criteria. As we give fluids, the BP is improving, they fall in the 1 and 2 criteria. But it's not like that. In sepsis, the BP may not improve because the arterial elastance may be high. In these patients, they will not, elastance low. So the BP won't improve even if there is a increase in cardiac output. So if the arterial elastance is high, then the BP will. It may not be true in all the patients. So only 50% of the patients who are in a septic shock state will improve on fluid resuscitation alone. That is coming to the group 1 and 2 patients. Another phenomenon is that our patient which we receive can have different states of LV function. They can have a natively normal LV function. They also can have a decreased LV function due to a native cardiac disease or sepsis-induced cardiomyopathy or cardiac dysfunction. And we can see that in this graph, the stroke volume to preload comparison graph, the stroke volume variation at the same 2 points are different for 2 categories of the patients. The patients with normal LV function, the stroke volume variation is 23%, and decreased LV function is 20%. So even though they are coming in the steeper portion of the Frank-Starling's curve, the response to fluid resuscitation will be more on a patient with normal LV function than the decreased LV function patient. So LV function has also to be assessed. So when we receive a patient in a septic shock state, we have to resuscitate the patient. How will we assess whether the patient is fluid responsive or not? The most commonly used and most commonly done is the bedside ultrasonography assessment of the IVC. This picture shows the IVC and the measurements are shown in the next picture. Ideally, the IVC should be measured at the distal part of the hepatic vein joining area by the bedside ultrasonography, and the maximum and the minimum diameters are noted. So if the patient is spontaneously breathing, we should look for the IVC collapsibility index, that is IVC maximum diameter minus IVC minimum diameter by IVC maximum into 100. And this should be more than 42% to be fluid responsive, patient to be fluid responsive. In a mechanically ventilated patients, we look for distensibility index. It is maximum minus minimum by the minimum diameter into 100, and it should be more than 18%, which offers antiburn sensitivity. So this is the commonly used, and this was the previously consulted method for fluid resuscitation, but now it is not so recommended. It is downgraded because even though in mechanical ventilation distensibility index is noted, it is not perfect. So we now come to the newer methods for bedside ESG assessment. That is the LVOT, left ventricular outflow tract velocity time integral variation assessment. This picture shows the LVOT VTA assessment. In this, we take the 5-chamber view, apical 5-chamber view, and put the pulse Doppler wave in the aortic valve opening part. And we will get the VTI waves like this. You can see that the VTI waves are varying in each heartbeat. This indicates that this patient is in a fluid compromise, that's in a septic shock state or fluid deficit state. And this variation should be assessed to assess whether he is fluid responsive or not. So a beat-to-beat variation of LVOT maximum velocity more than 12% will definitely predict fluid responsiveness. This patient can be of a LVOT variation of more than 12%. We can resuscitate with balanced crystalloids at the resuscitation method of 30 ml per kg to get a good result to improve the output and perfusion. Another method is the stroke volume variation. We have shown the graph, I have shown the graph earlier of the stroke volume variation, how it changes according to the LV function. We can measure the patient by the bedside, the stroke volume variation by a non-invasive method using the area calculation in the bedside echocardiography by calculating the LV outflow tract circumferential area, cross-sectional area. So this is done in the first picture. This is the LV outflow tract circumferential area. It is measured in the plaques view. Plaques view with in the systole mode, the aortic valve completely opened. The distance between the two cusps is measured. And it is the LVOT diameter. Plaques is the parasternal long axis view. So after measuring the diameter, we have to note the diameter, and we can calculate the cross-sectional area by the formula pi r square. Since we are taking diameter, 3.14 into LVOT diameter by 2, we will get the radius, the whole square. 3.14 into pi r square, we will get the cross-sectional area. So this cross-sectional area, when multiplied to the velocity time integral, we will get the stroke volume of that patient. So in order to get the stroke volume, we have to calculate the velocity time integral also. For getting the velocity time integral, as I already mentioned, pulse wave Doppler in apical 5-chamber mode, we could get the velocity time integral graph like this. We can trace the graph and get the VTI. So multiplying the VTI and the cross-sectional area, stroke volume of the patient is being found out. And the stroke volume variation of more than 14 is considered 14 or less than 10. Ideally 12 is the taken value. The patient is fluid responsive. And the stroke volume variation calculation formula is this: SV max minus SV minimum by SV max plus minimum into 0.5 into 100. So coming to the, after the resuscitation part, coming to the definitive fluid strategies, the recommendation by the Surviving Cells campaign is for liberal or restrictive fluid management strategies. There is no recommendation because they have seen that much complications of resuscitation have occurred in liberal and restrictive, both ways. So they haven't given any clear recommendation in the 2021 guidelines also. So this is the part where we have to concentrate, and this is the crux of the talk. The recommendation to be like that is that we can see that in graph, initially the cohort of the patients who are fully fluid responsive, the same patients after 2 hours, 4 hours and 8 hours become fluid non-responders and had led to fluid edema and fluid overload. The main phenomenon behind is that 3 compartments, the intravascular compartment, interstitial compartment, and intracellular compartment. In sepsis, the intravascular compartment will be leaky, as I mentioned. As we give intravenous fluids, due to these leaky compartments, it will get rapidly distributed to the interstitial and the intracellular compartments. And this distribution to the intracellular compartments will in turn lead to severe tissue edema. It impairs the oxygen and metabolite diffusion, distorts tissue architecture, impedes capillary blood flow and lymphatic drainage, disturbs the cell interactions, and ultimately resulting in fluid accumulation syndrome. So this is a picture depiction of a fluid overloaded patient with all the systems mentioned. We have noticed that all the systems, the hepatic, the abdominal, renal, central nervous system, all compartment syndromes will emerge on fluid loading the patient. And these compartment syndromes will lead to a decrease in perfusion of the organs and ultimately lead to organ dysfunctions, all the organs. And in case of critical care point of view, the weaning, there will be difficulty in weaning, prolonged ventilation, and the work of breathing will be increased. So this vicious cycle of septic shock resuscitation goes on. That is hypovolemic shock, fluid resuscitation leading to interstitial edema, visceral swelling, intra-abdominal hypertension, which in turn leads to oliguria, also mesenteric vein compression, venous hypertension, both leading to further fluid resuscitation. This vicious cycle goes on. So how to tackle with this vicious cycle is the newer model which the Malbrain has devised is the Rose model of resuscitation. Resuscitation, optimization, stabilization, evacuation. And this model is being depicted with this graph. This is the graph depicting different phases of a septic shock in a patient. First is the ebb phase and next is the flow phase on a broader terms. Ebb phase is the phase when the patient is sick. Initially, the first and the second hit occurs. That's the ebb phase. When there is an AKI, there is a fluid compromise, the patient is retaining the fluid. That's the ebb phase. And flow phase is the recovery phase. Like the phase of recovery in an AKI, there will be a diuretic phase, patient will be losing fluid. So in ebb phase will be the initial thing which we mentioned, the hypovolemic shock, which we have to resuscitate. That's the resuscitation phase. That occurs within minutes to hours. So early adequate fluid management, EAFM, comes in the ebb phase of resuscitation up to the phase of optimization. From optimization onwards, the fluid responsiveness has to be assessed adequately and patient has to be maintained in a neutral balance in the optimization phase, coming to late conservative fluid management and to the stabilization phase. After the stabilization phase, it is the late goal-directed fluid removal. In the stabilization phase, we have target for 2 negative balances in 1 week. And further, in evacuation phase, we have to de-resuscitate the patient. That's to give diuretics or renal replacement therapy if the kidney is not working to remove the fluid. Otherwise, it will lead to a further interstitial edema and organ dysfunction. So the first hit phase, that's the hypovolemic phase, which will lead to decreased perfusion and organ dysfunction. Second hit is the ischemia reperfusion phase, where we have reperfused by giving adequate fluids, but the ischemia which has been reperfused, which will lead to release of free radicals and organ damage. And third hit is the global increased permeability syndrome, which occurs due to further advanced increase in fluid inside the cells and decreased permeability. And fourth phase of hit is the risk of hypoperfusion. This occurs due to de-resuscitation, excessive de-resuscitation, and which in turn leading to lowering of the volume. This graph is a comparison of the Rose phases and the organ failure. We can see that if, the organ failure is maximum during the initial phase when there is hypoperfusion and shock. And as we resuscitate to optimization phase, the organ failure improves and becomes negligible. And again, when the optimization comes to stabilization phase, we are targeting for a neutral balance. The fluid accumulation in the patient persists and the organ failure rate worsens. And again, when we come to the next phase, that the fourth phase of evacuation and re-resuscitation, the organ failure improves. And further on giving a patient exacerbative evacuation or diuretics, they can again go for an organ failure phase. That's the fourth phase of organ perfusion decrease due to excessive diuresis. So we have summarized the whole thing as 4 block points. So the resuscitation phase is the early adequate fluid management to reverse hypoperfusion. Administer initial fluid bolus at the rate of 30 ml per kg per hour. Vasopressors if necessary to maintain MAP more than or equal to 65. Assess fluid responsiveness. Optimization, establish perfusion and organ rescue. Fluid based on responsiveness, avoid fluid overload. Titrate vasopressors and confine to the specific hemodynamic targets, that is MAP of more than 65. Aim for neutral balance. In stabilization phase, maintain perfusion and organ support with late conservative fluid management, monitor for fluid overload and organ dysfunction, and target for 2 consecutive negative balances within the first week after the insult. Next is the evacuation phase. This is for organ recovery and removal of excess fluids, for resolving the fluid overload. Active late goal directed fluid treatment, either using diuretics or renal replacement therapy if the kidney is not working. So there's an escalation phase, de-escalation phase, and de-resuscitation phase in the Ross model. So when do we resuscitate the patient? What are the triggers? First is the clinical signs like increase in weight, positive fluid balance continuously, emergence of delirium. Laboratory parameters like hemodilution, capillary leak index, that is ERP by serum albumin, more than 60. Radiological signs like B lines in the lung ultrasound, pleural effusion, low inferior collapsibility index, and high-grade vexus. Vexus is the venous excess ultrasound. This is the objective finding of fluid overload. We have assessed the fluid deficit objective method. This is the fluid overload assessment method by bedside ultrasonography. And other cardiopulmonary functions like absence of fluid responsiveness, increased filling pressures and volumetric preload, low pulse pressure variation, and endocrine dysfunction features like intraabdominal pressure more than 12 to 15, increased bilirubin, increased creatinine. So I'll conclude the talk by discussing the next bedside assessment tool which we can do to detect the fluid overload status of the patient. This is the venous excess ultrasound or VEXUS. So first, in the VEXUS, the first step is to look for the IVC diameter. If the IVC diameter is more than 2, we will then proceed to the next step. If it is less than 2, there is no congestion. If it is more than 2, we will grade into 1, 2, and 3 based on the 3 parameters, the hepatic vein Doppler, portal vein Doppler, and the renal vein Doppler. This is the normal hepatic vein Doppler. In this we can see that the systolic wave is more than the diastolic wave, and both are negative. When it becomes mildly abnormal, the diastolic will be more than the systolic, and when it is severely abnormal, there will be reversal in the systolic wave. It will become positive. Next is portal vein Doppler. Portal vein Doppler is assessed by the pulsatility index. That's the Vmax minus V minimum by Vmax. If the pulsatility index is less than 30, it's normal. It's mildly abnormal when it is 30 to 49, and severely abnormal if it's more than 50. Step 4 is the assessment of renal vein Doppler. It has a continuous flow, continuous monophasic flow if it is normal, mildly abnormal if it is discontinuous and shows biphasic waves with systolic and diastolic patterns, and severely abnormal if there is disappearance of the systolic pattern, isolated diastolic is there. So this is a pictorial representation where the probe should be placed. First IVC assessment, as I have told, hepatic veins in the same region itself, look for the hepatic veins. Portal vein, we have to move the probe slightly to lateralwards, and we can see the portal veins. And renal veins, obviously in the renal parenchyma, we have to look for the Doppler. So according to the various waveforms, we can grade it as grade 1 as mild congestion if the IVC is more than 2, and any combo of normal or mildly abnormal patterns. Grade 2, moderate congestion, IVC is more than 2, and any one of the severe abnormality patterns there. Grade 3, if more than 2 severely abnormal patterns along with more than 2 IVC. These are just pictures, real-time pictures of the waveforms that I have mentioned. This is the hepatic vein Doppler patterns, normal, mild dysfunction, and severe dysfunction. Portal vein Doppler, pulsatility index, according to pulsatility index, the variations, normal, mild, and the severe. And this is the intrarenal vein Doppler. The systolic, diastolic, discontinuous, continuous waves, normal, and the disappearance of systolic waves, that is severely abnormal. Thank you. Hope all of you understand. Any further questions or queries can be answered.
What about this leg raise regulation test for assessment of fluid responsiveness in septic
Yeah,
shock?
passive leg rising test. This is also known as auto transfusion of about 300 to 500 ml from the lower limb veins to the core. Can be done. But the scenario for testing that is that the patient should be initially in a 45 degrees recombinant position. Then either LVOT VTI or an invasive cardiac output monitor should be there. That's the main crux in that. The couch should be there, that should be remote operated and should be operated by the operator itself. Initially, the patient should be in the 45 degrees recombinant position, and rapidly he should be changed to supine position with leg elevation. That should be done within a fraction of a second. And the variability in LVOT VTI and or the invasive monitor is to be done. And that should be without any external influence or patient stress. Should be done by a motorized couch.
But we cannot check the BP variation with the passive leg rise. We cannot
No, BP variation will not correspond to the cardiac output. That's why I have told in the previous slide, the venous elastance will be low in such patients. So BP won't be reflecting the cardiac output. So a fluid responsiveness will not be equal or concordant with the BP variation. It will be concordant with the cardiac output or the stroke volume or the variation in the stroke volume. It won't be concordant with the BP variation because of the difference in elastance.
One more doubt is regarding the use of beta blockers, short-acting beta blockers in septic shock patients, slight variation from the topic. Those who are on inotropic support, like those who are on inotropic support like noradrenaline, there will be rise in the heart rate. So what about using a short-acting beta blocker or ivabradine? There is some concept is happening like that.
There is no recommendation to use short-acting beta blocker because in a patient who is in a septic state, there will be peripheral vasodilatation. And will be dependent on, like a pediatric patient, he will be dependent on the cardiac output and the heart rate for maintenance of his BP and perfusion pressures. If you give a beta blocker, then as the rate reduces, the BP will also come down. Or if at all the BP has with any elastance. So there is no recommendation for beta blocker. And if there is any LV dysfunction, that will further aggravate. The patient will crash if you are using a beta blocker. Regarding ivabradine, there are no definite studies for ivabradine in sepsis to control heart rate. Ivabradine plus or minus thoughts are there, but ivabradine is not recommended in sepsis. There are no definite studies to recommend for reducing heart rate. The idea, the increase in heart rate is a protective mechanism of sepsis for compensating for the decrease in pressures.
Yeah, but I think they are doing studies with ultra short-acting beta like finenolone with the septic shock patient. The study is going on and the results.
Going on studies are there. There are no recommendations now. So we can't say about going on studies. We'll wait for the results.
So, thank you, Dr. Vivek Prasad, for that very informative session. As we are already beyond the time permissible, I would like to conclude the session here with a thanks to you and for the audience for their patient listening. We will conclude the session here with this. Thank you.
I kindly request our respected chairpersons to award Dr. Vivek Prasad with a token of appreciation. I cordially invite Dr. C. Rajashekharan, Head of the Department and Professor, Department of General Medicine, Azizia Medical College Hospital, and Dr. Amit N., Associate Professor, Department of General Medicine, Azizia Medical College Hospital, to award the chairpersons with a small token of gratitude.
Now, we shall have the prize distribution of our e-poster presentation. May I request Dr. Rajashekharan sir, Head of Department of General Medicine, Azizia Medical College, to come upon the stage and give away the prizes. I also invite Dr. Sanju Daniel John, Senior Consultant Physician, Apollo Hospital, Kochi, onto the stage.
Yes, good evening. So 2 posters were presented by the PGs of Azizia Medical College, and 5 minutes of presentation was given and 2 minutes of questioning. So we have made some points. I have made some points based on how they perform, based on the overall visual content, based on the overall presentation and the clarity of the presentation. So based on all, both the PGs have done well, but then we have to anyway give a first place and second. So the content, I think I'll go to the first place for this one. Yeah. Shehnaz Salim. Okay. Second place to Dr. Nidisha Raj.
I would like to thank everybody on behalf of Department of Medicine and SM Medical College, senior faculty, Prabhash, medical superintendent, and all those people who have come from far places to just follow this function right from the morning. So thank you all. Thank you for your overwhelming and enthusiastic response. Thank you.
We hope this conference has illuminated crucial advancements in medical research and practice, highlighting the importance of collaboration, innovation, and patient-centered care in shaping the future of healthcare. Let's carry forth these insights to drive positive change and improve outcomes for patients worldwide. I thank all the delegates, speakers, and chairpersons in making this event a grand success. Once again, a very big thank you to each and everyone. Now I kindly request you all to rise for the national anthem.
Thank you.
I request everyone to come forward to click a photo.